C. Jayakumar, Professor and Head of the Department of Pediatrics, Amrita Institute. And in fact, he was my colleague in SAT during my postgraduate training also, and my very good friend, Dr. Jayakumar is. And we are also having Dr. Balachandran, consultant pediatrician in the health service and the National Secretary of IAP Environment Chapter and the state IAP Secretary 1819 as chairpersons. Now over to Dr. Jayakumar to introduce the speaker and introduce the subject. Over to Dr. Jayakumar. Jayakumar, you are not audible. Jayakumar, you are not audible. Dr. Balendran, can you take over? Okay. Start the session.
Jayakumar sir, shall I start? Okay. First of all, let me thank on the behalf of Jayakumar sir and myself, thank IAP Madhyakerala and the Respiratory chapter for giving it as an opportunity to chair an important session, that is antibiotic use in respiratory infections. As you all know, COVID has taught us how hand washing and masking can reduce the use of antibiotics. And antibiotics rarely needed for URI and should be avoided unless there are signs of bacterial infection. And we all know amoxicillin is the drug of choice for most of the respiratory infections. And 3 points I have to highlight. One is that we have to convince the patient not to use the antibiotic unnecessarily, and how to differentiate viral and bacterial infections, and when to start antibiotic for a LRI makes the physician unique in his practice. So the benefits we all know, antibiotic resistance will come down, and only method is you should audit your prescriptions whenever in your busy practice. With these words, we have a very good academician and very good academician in Dr. Pallab Chatterjee. I would like to introduce Pallab sir. He is the consultant pediatrician with his interest in pulmonology, and he was the chairperson of IAP CMIC 2021 and a member IAP National EB 2020. He was the secretary of the West Bengal Academy of Pediatrics 2018 and 19, and he was the chairperson of the West Bengal Pediatric Pulmonology chapter. He is also a member of Advisory Committee of Vaccines and National Practice 2018-19. With these words, I invite Pallab sir for the session. Over to you, sir.
Thank you very much, Madhyakerala branch, for organizing this conference and giving me this opportunity. Thank you, IAP Respiratory chapter, and particularly I feel honored to give this to be here in front of all of you. Particularly Dr. Sukumaran sir, who I know from a long time since I was a student. Dr. Ramesh Kumar, our incoming president, Dr. Subbu, who's very close to me, and all the others. And I also saw Dr. Meenu Singh in between, but she's probably left. So all the others, my contemporaries, my friends, my teachers, everybody I can see there. So thank you very much for giving me this opportunity. And I think I need to, I will share my screen now. It was disabled. Okay. So am I visible? Is yes, my screen visible? Okay. So
hello, Pallab. Hello, Pallab.
Yes, sir.
Yeah.
Yes, sir. You are visible. Yes, sir. You are visible.
Yes, Dr. Jayakumar.
Yeah. Please. Carry on.
Another very close to me, Dr. Jayakumar is there. So thank you very much for this opportunity, sir. And I will start off with the session without wasting time. And why is this session so important? As Dr. Balachandran has said, that we need to actually differentiate when to give, but more important, when not to give. A good surgeon is one who knows when not to operate. So we should know when not to give an antibiotic also. rather than giving antibiotics. So, and statistics say that a child dies of pneumonia every 39 seconds, and pneumonia kills more children than any other infectious disease, claiming the lives of more than 8 lakh children under 5 every year. So there are large number of patients who die of pneumonia every year. There are large number of patients who suffer from pneumonia every year, particularly in South Asia. And in India also, we are one of the leading countries with this under 5 deaths due to pneumonia. So with that, we'll come to a case, a typical child, 5-year-old, having acute onset of cough, rhinorrhea, associated diarrhea. So more than one system involved. Mild throat congestion is there. There are similar cases in the family. So again, as Dr. Balachandran was saying, what is this case? So do we need to investigate this case? Do we need to give antibiotics in this case? Do we need to do anything? It is a seasonal viral pharyngotonsillitis. So these are cases where we need to not to give antibiotics. And compare this with another child, a 4-year-old, acute onset of fever, high-grade fever, mild cough, no rhinorrhea, differentiating from the previous child. There was severe difficulty in swallowing. There are no similar cases. And there was purulent discharge on the tonsils. So there were tender cervical lymphadenopathy. So now what about this? Do we need to do anything? Do we need to do a rapid antigen detection test? Do we need to do a culture sensitivity? This is an acute bacterial tonsillitis. So these are the two different cases where upper respiratory infections, and we need to differentiate what is viral and what is bacterial. So we need to understand that in bacterial, there will be less cough. So cough is minimal or absent. There will be tonsillar exudates. There will be history of fever and tender anterior cervical lymphadenopathy. So if there are palatal petechiae and vesicles, think of more of viral infections. If there are tonsillar exudates and cervical adenopathy, there's a very high chance of being a bacterial infection, though they are not watertight compartments, but usually more often than not, that's how it goes. And there are various criteria that also differentiate. So they've given points to tonsillar exudates, tender anterior cervical lymphadenopathy, fever, absence of cough. And if these are more than 3, then it's more likely to be a group A streptococcal infection of pharyngitis. And treatment, when we think of a viral infection, it's mainly supportive. So rest, oral fluids, absence of irritants, mainly analgesics, antipyretics, particularly paracetamol. Some home remedies like tulsi, ginger, lemon can help. Sometimes some salt water gargling might help to relieve the pain in the throat. And all these other medicines like herbal products, soup, special diet, zinc, vitamin C, brandy, they've got no confirmed role. So they should not be advised at all. So as we said that we should explain that it will take 5 to 7 days to resolve. So whatever we do, it will take that time, and that is what will help the parents to understand that we have to give time to the virus to resolve. First generation antihistaminic should be avoided unless there is a severe bothersome rhinorrhea where you might give for 1 or 2 days to help them sleep, and it might relieve some amount of rhinorrhea, but it's better to be avoided. Dextromethorphan also may be given, but preferably in an older child. Now, this first child, you have explained everything. This child went home very happy and then came back and said, see what has happened after 10 days. Now there's fever, there's headache, there is purulent nasal discharge and slight periorbital edema with tenderness on percussion on the maxillary sinuses. Imaging is usually not required. Clinical picture is very suggestive that this child is suffering from an sinusitis. So, however, we do imaging when these children are non-responsive to usual management, they are having recurrent problems, and they have some predisposing factors which lead to a recurrent sinusitis, anatomical abnormalities, or there are complications of sinusitis which you are thinking like an orbital complications, CNS complications, and there you can do a CT scan of the PNS or a MRI, it can be done. So what are the usual bugs that cause an acute or a subacute sinusitis? The acute subacute sinusitis that occurs after usually a viral infection are strep pneumoniae, non-typable Hib, Moraxella catarrhalis, and strep pyogenes, which is beta hemolytic. Chronic sinusitis, it is usually polymicrobial. And the problem with these is there are a lot of anaerobic bacteria that can be there along with the other infections, particularly the Moraxella catarrhalis, Staph aureus, and non-typable Hib. And accordingly, you have the drugs. So we need to understand that once it becomes a chronic sinusitis, then we need to give other medications. And if we are thinking of a strep pneumonia, particularly an unimmunized or an undimmunized child, we might have resistant strains. H. influenzae now are becoming very high beta-lactamase positive. So you can have resistant strains with H. influenzae infection. Moraxella catarrhalis, nearly 100% are becoming beta-lactamase positive. So we need to now decide on the antibiotic that we give for these children once they develop a sinusitis. And there are certain risk factors for resistance, for example, living in high endemic areas, young age group, daycare attendance, received antibiotic therapy within a month of presentation. So all these points we need to keep in mind before we prescribe an antibiotic to these children. So management of sinusitis, again, there are three things that we need to give. One is the pain relief by giving NSAIDs like paracetamol, preferably. Sometimes you might give ibuprofen. You give saline nasal drops, steam inhalation, aspirate the nose and clean the nostrils. Preferably avoid using decongestants and antihistaminics. And the drug of choice is always, we start off with amoxicillin. If it does not respond, then we go to co-amoxiclav, and then the others are there like cefuroxime, cefotaxime, or cefdinir. So mainly the first line is amoxicillin, amoxicillin, and amoxicillin. If it is not responding, then we think of co-amoxiclav. And if these sinusitis are very severe, so there is a very high grade fever, which is more than 39 degrees, with facial pain, with purulent nasal discharge, and there is this is associated with orbital edema, there's severe headache, visual disturbance, and altered mental status with meningeal signs. So all these are there. Then we think of a complicated sinusitis, and we start off with ceftriaxone once the child has been hospitalized. So persistent upper respiratory infection lasting for more than 10 days, severe URI with symptoms referable to the sinuses, and this URI which was initially improving and then worsening. So these are the three ways that the sinusitis can present. And there the clinical examination is suggestive of sinuses. And you need not do any radiological investigation at this stage. Once you diagnose a sinusitis, start treating on the clinical basis. The first line will be amoxicillin if it's an acute non-complicated. You will start with ceftriaxone if you are thinking of a complicated sinusitis. If there is no response by 3 to 5 days, or there is worsening after 3 days after starting the medication, then you can shift to the second line drugs. So if it is, you started off with amoxicillin, shift to co-amoxiclav for the non-complicated cases. And if if it is cured, continue for 2 weeks or at least 1 week after the child is improved. If there is no improvement, then sinus imaging, CT scan, followed by aspiration of the sinuses. And there we need to take the help of our ENT colleagues. Another child will come, a 4-month-old female child who presented with severe cold and cough for 4 days, high-grade fever, difficulty in breathing. There was severe cold and cough in the attendant. Sick-looking child, nasal discharge was there. There was a harsh cough, and there were scattered crepitations, fine bronchi, and respiratory. There was tachypnea. And this is a typical child that we are seeing in this current situation. And we actually do not need to investigate these children. They are the textbook, the garden variety of acute bronchiolitis. And they usually start off with fever, coryza, and management is only symptomatic. So nothing, no antibiotics will help, and no other medications are going to help in the usual mild cases of bronchiolitis. And here again, we need to, as Dr. Balachandran said, we need to understand that these are cases where we do not give antibiotics. This child worsened in the hospital. We did an X-ray. There were patchy shadows. And then we did a PCR test. And this is something that we now do quite commonly if children are not responding. And what we got was a influenza A RNA was detected. So this biofire or the PCR test is a boon to us at present, because it can detect in a very short time around 20 respiratory pathogens, and that can help us in guiding our treatment. And this is important because once we know the diagnosis that this child is actually not a RSV bronchiolitis or a rhinoentero infection, but it's a infection by influenza A, then we can plan for giving specific drugs to these children. So who are the high risk groups? The young children, the chronic diseased children like pulmonary, cardiac, renal, hepatic, any neurological conditions, hemoglobinopathies, immunosuppressed children, children on aspirin therapy. And these are the children where we need to give oseltamivir is the drug of choice. Zanamivir is not available at present in our country. It was available in between. So oseltamivir is the drug of choice that we need to give in these children. And chemoprophylaxis also we need to remember in groups of children at transplant units, patients with severe immunosuppression, neonatal units, or where this influenza virus infection is present. We come to another child, 11-year-old boy, an older child, good weight, high grade fever, associated grunt. So once you have a grunt, you know there is something which is happening quite low down in the airways. This child also was tachypneic with a low saturation. There were recessions. There were breath sounds were reduced on the right side, and scattered bronchi was there. So this is a very consistent sign, according to WHO, tachypnea in a child, young child, of pneumonia. So less than a month, you have the respiratory rate around 60, 2 months to 12 months, 50, and above 1 year, it's 40. So this is a cutoff which is very important if we remember. So we need to count the respiratory rate for 1 minute. And not all of these patients need chest x-rays. Not all of these patients need investigations. Even the routine microbiological tests are also not very important to be done in all these patients. Only clinically we can suspect and we can start. But very often, if these children come to the hospitals, get admitted, then we need to do these investigations and decide on the management. We need to know that in this age group, less than 5 years, the viruses cause around 35% of the pneumonias. Bacteria cause around 60% of the pneumonias. Of them, the H influenza, strep pneumoniae, staph, and mycoplasma can be important causes. Chlamydia can be there, and very few mixed infections can be there. So the risk factors for pneumonia, it's low socioeconomic status is very important. Low maternal education level is very important. Poor access to care. Indoor air pollution, I think we have a session on that. So that is extremely important. Malnutrition, lack of breastfeeding, again, exposure to cigarette smoke, whether it's active or passive, drugs, alcohol, cigarette use, particularly in the teens, that is increasing nowadays. If there is any underlying cardiopulmonary condition or a metabolic condition is there, then that can lead to predisposed to pneumonia. In neonates, child presenting with a PROM for more than 18 hours, a maternal chorioamnionitis, premature delivery, a maternal intrapartum fever, and again, ventilation-associated pneumonias, anomalies of the airways, and all these can predispose to pneumonias in a neonate also. So we need to, before we decide on what management we need to give in a community-acquired pneumonia, we need to understand that what are the pathogens that are related. So the moment we see a child less than 3 months, we should think of gram-negative infections, strep pyogenes, and later we think of chlamydia and viruses. 3 months to 5 years, again, strep pneumoniae, H influenzae, staph, again, viruses and mycoplasma come later. And above 5 years, again, here, the viruses and mycoplasma are higher up in the list. Strep pneumoniae, staph is always there, followed by strep pyogenes and H influenzae. And if these children have a predisposing pyoderma or measles, think of staph first. If this child is having an HIV, think of pneumocystis. If this child is a neutropenic child, then gram-negative or has aspergillus or has been in the hospital for a long time, think of aspergillus. CF, think of Pseudomonas and staph. So initially they are colonized with staph, and then Pseudomonas comes in and they can be there together. Severe PEM, think of gram-negative infections and staph, and aspiration pneumonias are usually anaerobe. So we need to know the organisms before we decide on what antibiotics to give. So if you are suspecting MRSA, then start off with ceftriaxone, clox, vanc, and clinda till we get the culture reports. And if we are thinking of a severe necrotizing pneumonia with a pentan-valentine leukocytin toxin, then clinda or linezolid can be good choice of antibiotics in these children. So remember, linezolid is a bacteriostatic. So, and we should not be using linezolid left and right, because that is one of the drugs that is also kept for drug-resistant tuberculosis. So linezolid should be reserved for certain cases and not all cases of infection. So we need to understand when we need to hospitalize these children for for pneumonia. In infants, it's falling saturation less than 92 with cyanosis, tachypnea, difficulty in breathing, not feeding, or the family, even if they are there, but the family is not able to provide appropriate observation, or they are living far away from the healthcare center. And an older child, again, the similar things, only the respiratory rate more than 50, grunting, and again, the family is not able to provide adequate observation or supervision. And ICU, we need to admit when these children are not being able to be managed in the ward, and there the saturation is still falling, then we need to, and is requiring high FiO2, then we need to admit these children in the ICU. General management is extremely important. So along with the antibiotics, we always need to remember what general management we need to give for these children. So they have to be reassessed for every 1 or 2 days to understand whether this the bug, whatever we are treating, is responding to our treatment. And if there is no response within 48 to 72 hours, then further investigations need to be done, whether it is worsening, some complication is developing, and we need to also maintain adequate hydration of these children and monitor their electrolytes and creatinine levels. So if it's a penicillin sensitive, then drug of choice is ampicillin, amoxicillin, cefuroxime, ceftriaxone, cefotaxime in that way. If it's intermediate and resistant strains, then think of cefotaxime, ceftriaxone, linezolid, clinda, and cefdinir. And if we are thinking of a pneumococcal serotype 19A, then think of the vancomycin, linezolid, and levofloxacin. Mycoplasma, the drug of choice is azithromycin followed by clarithromycin, and in an older child can give doxycycline and fluoroquinolones. And chlamydia, again in a child more than 8 years, doxycycline; less than 8 years, the drug of choice is erythromycin. And there are large number of complications of pneumonia, where you have the respiratory complications, particularly pleural effusion, empyema, pneumatocysts, necrotizing pneumonia, and lung abscess. And you have these and the other systemic complications are also there. So for the outpatients, 3 months to 5 years, we need to give amoxicillin is the drug of choice. First line, 40 milligram per kg per day is the usual drug that dose that we give. And second line is co-amoxiclav or cefuroxime. Above 5 years, again, the drug of choice is amoxicillin, the same dose of 40 milligram per kg per day. And the second line will be again a macrolide. You can give the macrolide along with the amoxicillin, or you give co-amoxiclav and cefuroxime. So less than 3 months, a child with pneumonia, preferably, we need to hospitalize all of these children. So this child was followed up and this child was fine. We'll come to another case. Ayush, a 10-month-old, presented with a prolonged cold and cough, difficulty in breathing, was brought to the hospitalization, had a previous history of convulsions not related to this case. And this child had a poor weight gain, and saturation was low with oxygen, and chest recessions were there. This was the chest X-ray, which showed diffuse opacities bilaterally, and an X-ray and the CT showed interstitial pneumonia with bronchial wall thickening. Child improved, but still the recessions persisted, the oxygen dependency persisted, and a bronchoscopy was done. And this bronchoscopy showed thickened bronchial walls with thick, cheesy granulation tissue, which was suggestive of tuberculosis. So Bronchoalveolar lavage also came as CB0 positive, rifampicin sensitive. This child was started with steroids because of endobronchial tuberculosis along with anti-tubercular drugs. This child improved and child was discharged. So this is another case where we need to think of tuberculosis if this child has a problem which is not improving. And if you have this persistent symptoms, unremitting cough, weight loss of more than 5% or no weight gain in the past 5 months, and a classical typical chest x-ray, then if it's a highly suggestive, then you do the NAT, and then if it's microbiologically confirmed, then you think of the tuberculosis and follow if whether it's rifampicin sensitive or rifampicin resistant, the line of treatment. And if it is NAT negative, then look for other areas. And if you get some significantly enlarged peripheral lymph node, then we can do that again and look for mycobacterial infection from there, or repeat the NAT from there. If there are non-specific shadows, then it is better that we do not give unless we have a definite proof of tuberculosis. We give a course of antibiotics and repeat. And if the chest X-ray is negative, then we look for extrapulmonary tuberculosis in these children. Child improved, Ayush, and was gaining weight. And drug dosages, we won't go. It is there in all the textbooks that we read. And there's again the newer classification. Trishti is the last patient that will come to, 11-month-old infant, recurrent fever. Now, this is a recurrent fever, recurrent infections, recurrent pneumonia, going on from 1 month of age, no weight gain. You can see the clubbing in this child. There is tachypnea, poor saturations, diffuse crepitations and rhonchi. And these are 2 X-rays over 2 different times in this child, and which shows that this child is having pneumonias in different lobes. This child has got a hyponatremia, hypokalemia, and hypochloremia. And this is the CT scan of this child, which shows diffuse involvement. Some GGO is there. We did a bronchoscopy in this child. This child had thick mucoid secretions, and the bronchoalveolar lavage grew pseudomonas, and the sweat chloride was also higher, more than 60. Pseudomonas is actually a signature bug for cystic fibrosis. So moment you get that, even if you cannot do a sweat chloride in your area, think of pseudomonas, think of cystic fibrosis in these children. So criteria of diagnosis, it can be stamped as cystic fibrosis once you get either the sweat chloride positive, or you get the identification of 2 CF mutations or an abnormal nasal epithelial ion transport. But without the mutations, without the cystic fibrosis, you cannot stamp them as CF. But still, if you get a bug like pseudomonas in this child with this typical with this typical history, and particularly if you have a pseudowater-like feature, then think of pseudomonas, start treating as pseudomonas. Management is regular follow-up. Enzyme salt replacement is the mainstay of treatment, along with antibiotics and chest physiotherapy. That is extreme. So airway clearance is the crux of the management of cystic fibrosis. And they usually come to us as a primary care physician with exacerbations. So immediately take the cough swab or the sputum or nasopharyngeal aspirate, send for culture, and there should be a very low threshold for starting antibiotics in these children. And in an acute exacerbation, usually the doses that we start are 2 to 3 times the usual dose that we give for the normal children. And it can be 1 antibiotic, intermittent short course, to nearly a continuous antibiotic can be required if the child is over a period of time, and particularly if the child is already got colonized with pseudomonas. So once this child has got pseudomonas colonized, it takes very difficult for the pseudomonas to be removed from the airways. So identify the normal child, identify the atopic child, identify chronic underlying conditions and immune deficiencies. We must remember, as we started off with, that most respiratory tract infections are viral. They will be occurring in close succession. So you can get these viral infections one after the other, and we need to be careful and explain to them that children can have a large number of viral infections in the year. Around 6 to 8 episodes of viral infections are quite common, and they do not require antibiotics. So like as I said, the good surgeon who knows when not to operate, you should know when not to give an antibiotic in these children. And many of these respiratory tract infections are actually asthmas or allergic rhinitis. Recurrent bacterial infections are usually always secondary to structural and functional abnormalities. We should look for the spur infections, that is a severe, persistent, unusual organisms and recurrent infections. And that is a very significant marker for immune deficiency. And watch out for the red flag signs like tuberculosis when it is persistent. So a recurrent infection is usually not tuberculosis. It's usually a persistent infection is tuberculosis. And remember that we should not have a very low threshold for giving anti-tubercular drugs. All unexplained symptoms are not necessarily tuberculosis. We should try to get the bug before we try to give the drug. Thank you. Thank you very much. I acknowledge my patients for the living pages of the book. I took some help from the RTIGM module and the TB module of IAP, and those were very helpful. Thank you. Thank you very much. I think
no,
I finished on time.
Dr. Pallab, can you hear me?
Yes,
Dr.
yes,
Pallab?
yes. Yes, Dr. Jayakumar. Yes,
yeah. Thank you for your excellent presentation. You have covered from upper respiratory tract to lower respiratory tract. And as you said correctly, if you want to prescribe a right drug, you should know an intelligent guess of the right bug. So you have covered each and every aspect. And you know that it's very important that you have to prescribe the right drug for the right bug. And for that, you should have got a good idea about the right bug. And one more thing, that how long we have to use these drugs is also very important. As WHO say, in case of pneumonia, you have to use only drug for 3 days. But in some cases, you have to use drugs for years. In cystic fibrosis, in case of tuberculosis, you have to use for more than 6 months, like that. So there are two questions in this chat box. One is question is from Dr. Parvati, and she has said whether the
So there's a voice cut.
I will continue, sir. I will continue. Parvati Madam has asked with the inclusion of pentavalent vaccine in National Immunization Program, Haemophilus influenza, pneumococcal pneumonia has come down remarkably. Is it not?
Yes, sir. Yes, sir. It has, and that's why in the first slide I said that the incidence of pneumonia has come down. So two things. One is there is an inclusion of the pentavalent vaccine, and also there's an inclusion of the pneumococcal vaccine that is coming in the National Immunization Program. So with these two, the incidence of pneumonia is definitely coming down. And there's another question about the high dose amoxicillin in respiratory tract infections and strep pneumonia. Sir, what has happened is, this is Dr. Ananda Kesavan, I think. Sir, what has happened is, in our country, most of the strep pneumonia that we see are amoxicillin sensitive. So we do not need to give the high dose that is reported frequently in the Western literature. So we need to give high dose amoxicillin only when these children are coming back with a recurrent infection, or we find that this is not responding. So many times what is happening is, if these children are coming back with a recurrent otitis media, and we had given, and we still think that this is a strep pneumonia, so we can give a high dose co-amoxiclav in the dose of 90 milligram per kg per day, and that will help. But the issue is that is only in those cases, and rather than shifting to any other combination, this amoxicillin or co-amoxiclav can still be useful in these children rather than going for more costly drugs.
Thank you, sir. Thank you, sir. There are no more questions. So thank you, Pallab sir, for the excellent presentation. And I congratulate and thank IAP, Madhyakerala and chapter for this CME, and also congratulate the respiratory chapter for initiating the oration in the name of our respected and dear Sumaran sir. Thank you. Over to Nimi.
Thank you, Dr. Balendran. and Dr. Jayakumar for chairing the session, and Dr. Pallab Chatterjee for an excellent talk on antibiotic. Now we move on to the next talk. Next talk on acute stridor by none other than Dr. Vijay Shekharan. You know, Dr. Vijay Shekharan needs no introduction to the audience in Kerala. And this session is going to be chaired by Dr. O. Jose, Associate Professor of Pediatrics, IAP Medical College, and is the National Secretary of Allergy and Applied Immunology Chapter. And also by Dr. C.B. Philip, who is Chairperson of Allergy and Applied Immunology Chapter Kerala and past State Secretary of Respiratory Chapter. And I request Dr. Jose, Dr. Sipi to take over this session and introduce the topic and the speaker. Over to Dr. Jose.
Thank you, Ashok sir. Good morning to all. And as Dr. Everybody mentioned, we are eagerly waiting for our prestigious oration of Suman sir oration. So we'll go into second topic. As you know, everybody know, the stridor is a nightmare of all the practice pediatrician and general practice is concerned. As you know, the stridor may be the sign of an airway obstruction, either maybe upper or lower airways. Can be commonest cause of stridor in the day-to-day practice congenital laryngomalacia syndrome, and acute stridor is actually the real nightmare for all the pediatricians. So commonest, as everybody knows, acute laryngomalacia, and another maybe the foreign body and things. To narrate this regarding how to approach a child with acute stridor in children, our one excellent faculties. I think there's no need to introduce to this audience regarding the details of the Dr. Vijay Shekharan sir. He is a very close friend of all of us, IAP Kerala. He is one of the permanent faculty for all the respiratory chapter in this last 20 years in our physical and digital platform of IAP Kerala is concerned. So Dr. Vijay Shekharan sir is a professor of former professor of pulmonology at the prestigious Institute of Madras Medical College, Chennai, and after he is a visiting consultant and pulmonologist and bronchoscopist in the Apollo Hospital, Chennai, and Kanchi Kamakodi Trust Hospital, Chennai. And he is past chairperson for our respiratory chapter national in 2017 and 18. He got a lot of awards in the credit for the academic activities. He wrote a lot of textbooks on especially regarding the pulmonology and regarding the bronchoscopy. He's one of the trainer in the national level, the training the pediatrician and pulmonologist regarding the bronchoscopy in a simple ways. So with these words, I invite Dr. D. Vijay Shekharan sir to narrate us about update on the acute how to approach a child with stridor in children.
Thank you, sir.
Or to Shekharan sir.
Yes, sir. I'll just share my screen. Can you? Can you see this?
Any issue, sir? Not seeing.
Any screen? Can you help me to share the screen? I think. Can you see?
Ashok sir, please help me. Or
Vijay Shekharan sir, at the bottom of the screen, yes, you can see share screen.
I'm sharing the screen.
Just press that. Yeah, it will take a little time.
Okay, okay. I'll just press. It's not.
We have allowed you to share the screen. Actually, you just have to. There is a green button, share
yes,
screen
yes.
At the bottom. Of, yeah, you can just press there and select the file from this desktop.
Whether you permitted him to share?
Yes, yes.
Yes.
I don't know. I got a permission. I don't have a permission, I think.
I think Nimi,
no,
please,
sir.
Please make him a co-host.
He is a co-host.
I don't know why it's. Can you help me? Can you share that?
Whether you send it in an email to anybody regarding
no. He He hasn't sent the presentation because it wasn't ready yesterday. We had asked actually, because we had
Is
a
it?
trial yesterday for sharing. You
Sir,
can just press the
host
share.
was enabled, no, because my also host was not enabled initially. Sharing was not enabled
That's
initially,
what.
and then it's.
I am not.
No, at the time of,
Can you?
we have enabled at the time of the talk, sir.
Sir, when
Okay,
you
okay.
Vijay Shekhar is the
when
co-host.
Try now, sir. Can you
Sir,
try
when-
now, sir?
You can allow us. I don't know, because sharing, I'm sharing the screen, but it's not going up. I don't know what to do now.
Make him as a co-host.
He is co-host. All the speakers are co-hosts.
What to do now?
Sir, you can just log out once and log in again, and then see if it works.
Sir, can you send the presentation to my email where I have sent you the details? Dr. Nimi Joseph,
Okay. 1
I've
minute.
sent you morning also.
Yes, I'll see that.
Whether we can stick next.
Can we go ahead with the asthma
faculty.
talk panel discussion? Krishna Mohan sir, can we go ahead with the panel?
Yeah, only if Nagabhushana sir is ready for that.
Okay, okay.
Nagabhushana sir is there. What about other panelists?
No,
Robert, sir.
one thing, Vijay Shekhar sir, you log out.
I'm sending that. I'm sending that.
Or you send to me. I will share.
Vijay sir, when you are clicking the share screen button, what message you are getting, sir?
It is not it is not coming. That's a thing and all. But anyway, I'll send my slides. Okay,
Okay, sir.
Nimi, can you? I don't know.
Where are you seeing the green button? The bottom.
Green button is there.
Can we ask Subramania sir if he's ready, and then I'll get his presentation and I'll share from here. That might take a little time, Alay.
Sir, tell me. Yeah, I will tell. Nagabhushan calling me that he is muted. Can you unmute Nagabhushan sir? Can you unmute Nagabhushan sir? He is ready. Krishna Mohan, he is ready.
Okay. Nimi, please unmute.
Pardon, sir. So, Krishna Mohan, Dr. Subbarao sir is going to share the screen, make him as a co-host.
Okay.
Nagabhushan are ready for starting the section. He's there ready.
Okay. So,
Dr. Nimi Joseph, please make Dr. Subbarao co-host. He is going to share the screen. If he can't, I will do it. Please start with the introduction and then we will take over.
Rawat sir is also ready, sir.
Yes.
Okay.
Who is chairing the section?
Okay, Nimi madam, then we can change the plan.
We can go ahead with the panel discussion then.
Okay, sir. Nagabhushana sir, you can start.
Yeah, please make Professor Subbarao the co-host. He will share the slides.
Yeah, we have, he is the co-host. He is a co-host.
Yeah. Please start with the introduction and we will start.
Okay. So we will go ahead with the panel discussion on childhood asthma. Moderator is Dr. S. Nagabhushan. And our panelists are Dr. Sanjeev Singh Rawat, Dr. Ashwin Duresani, and Dr. Subbarao.
Sorry,
Okay.
can you see that? Nimi?
This is
Yes.
Yes, I come to this one. Now only it's allowed.
okay. Yeah.
Shall I go?
Okay.
Okay.
Okay, we can continue, sir. Vijay sir, continue.
Yes, just now only when I click it's
Continue.
Okay, continue, sir. Continue, sir.
I think I thank all the organizers, particularly my great friend Dr. Sukumaran, and I think Jose is there. All the efforts of Rafiq, Krishnamohan, and Nimi Joseph. Thank you. Without wasting, I'll go. Acute stridor, I think it's a very important topic. At least in some point of time, you would have managed like that. Many times, if you go into the division of respiratory system, it is always confusing. Okay, think about the imaginary line at the trachea, mid trachea. Can you hear me? Mimi, can you hear me? Mimi, can you hear me?
Audible, sir.
Yes. You always think about the imaginary line in the mid trachea, and anything above mid trachea is upper respiratory system, or you can also call it extrathoracic, and anything below is intrathoracic or lower. This is very, very important because unless you know these basics, managing the stridor is little difficult. Why I am telling you is upper respiratory, that is upper airway compromise, that is extrathoracic obstruction. You can call it either way. If any problem there, it may produce a sound that is called stridor. Okay, and anything lower below the intrathoracic level or below the mid trachea, that is also called lower airway or intrathoracic obstruction, that may cause these. I always mimic stridor and wheeze, make the parents to understand. Otherwise, communication might be very difficult and all. These are the days of interventional pulmonology. People who are interested to become an interventional pulmonologist, you should know what is the organs or what is the structures, what is the vessels, very, very close to the trachea and other things. Stridor can be approached as acute and chronic. And acute again divided into infectious and non-infectious causes. And I may not be touching chronic causes of stridor in this discussion. I think these are all the causes that contribute acute infectious as well as acute non-infectious one. Probably it may be more boring to give lecture on this subject. I will show 3 or 4 scenarios. You can join with me and we can go like that. We will start. Probably I may not be touching much about the chronic causes of stridor. This is a 3-year-old child, symptoms of coryza, symptoms of more in the night, inspiratory difficulty, and I think any of you can guess what should be. I think all of you correct if you say that it is a croup, or sometimes it is called as viral croup or acute laryngotracheobronchitis. And I think this is very common in fall, particularly after the monsoon and winter. And the most common organism that causing is parainfluenza. But of late, sometimes even RSV, rhino, all these are implicated. And the pathology happens at glottis or subglottic area, which is the narrowest part. Up to 8 years of age, it is the glottis is the narrowest one. And after that, probably the vocal cords. And that is the reason why when the virus affects this glottis area, there is a diffuse inflammation in and around this glottis and subglottic area. And that may cause this sort of a sign that is called steeple sign. I think I always insist that croup is a clinical diagnosis, no X-ray and all, and go with a simple X-ray. Sometimes people will say this is not a must. It all depends upon the availability, and we should not disturb the child much. But if you happen to say, and because of the narrowing of the air column, we can get such steeple sign, what is shown here. Before managing croup, we have to classify whether it's a mild croup, moderate, or severe. Why I am telling you is majority of the croup or majority of the bronchiolitis even, they fell into the mild variety. And we should know how to manage in day-to-day practice the mild and moderate one. And if you see this side, most of the mild or even the moderate or severe probe, if at all one drug that is act wonderfully acting on this situation is steroids. Why I am telling is, if you happen to make a diagnosis of mild croup, you have to give a dose of steroid, then will be you can, otherwise the child start recurring even if you give other drugs and all. Okay. And with this, people may use steroid in 3 ways, either in a budesonide or dexamethasone. In my personal practice, I used to dexamethasone in the dose of 0.2 milligram per kg, and all routes are effective. You may ask me, why all routes are effective? This is because corticosteroids act in a different way. Actually, it enters the cell, migrates towards the nucleus, and changes the ribosomal prescription, that is called transactivation, resulting in new molecules like macrocortin and lipomodulin that takes at least 3 to 4 hours and all. Actually, these new molecules are responsible for anti-inflammatory properties or anti-inflammatory actions of the steroid. And whereas what we got in a group is, I already said steroids can act both ways, genomic and non-genomic. Here, the non-genomic mechanism simply causes mucosal vasoconstriction and blood vasoconstriction that causes the immediate relief along with the adrenaline and all. This child, our child, placed in the category of severe croup, so the child should be started with adrenaline. Adrenaline is a wonderful drug, and what those days we use vapinephrin. Now what we use a racemic nephrin, that is a usual epinephrine, should be used in the dose of 0.0 ml per kg and not exceeding 5 ml per dose, and it can be given 4th hourly. Adrenaline acts very fast. You can get the relief of symptoms within 20 minutes and all. Why I am telling is, epinephrine act, or adrenaline is also called, act on both alpha, beta and beta 2 receptors. And the action that is recorded in group is because of the alpha 1 action. And what we are getting in the asthma, we also use epinephrine in acute asthma, where it is the beta 2 action is responsible for the relief of symptoms. In this connection, I also say adrenaline is a wonderful drug. It can be used in anaphylaxis or even angioedema. Sometimes angioedema can fix it as a, sometimes in severe form, angioedema itself can present with a stridor. So when the child presents with a lip swelling or urticaria, along with that drug, you have to use adrenaline. One thing, adrenaline should be stored in an amber colored bottle and a short expiry. I recommend people who practice, you should always change these drugs once in 3 months. And when you happen to have such a findings, lip swelling, urticaria, itching along with the stridor, think strongly there is angioedema. One more condition, hereditary angioedema, it tends to recur. It acts in a different, not like a histamine release. Here bradykinin is mediated, and here even most our focus should be on not on antihistamines or adrenaline. You should focus on airway management. And later onwards, you have to work on this mutation, and this found to be C1 esterase mutation. And you can try all these drugs, that is C1 esterase inhibitor protein or kallikrein inhibitor, because the kallikrein influx is responsible for hereditary angioma. And I am telling you, whenever you say anaphylaxis, along with adrenaline, focus of airway is very, very important. Oxygen, few words, oxygen can be different in several ways to minimize the cardiopulmonary work, but cardiopulmonary work, sorry. And here, the best way to give oxygen is to give through the nasal cannula. Why I am telling you is, even with that, there is a study compared about that is HHN, inflow nasal cannula along with the nasal, usual nasal cannula, and they found that even 30% of oxygen in crew is effectively maintains SpO2 of 100. So it is a very simple way. So child should be minimum with the nasal cannula because it can enjoy the oral foods also. Don't use high flow nasal cannula in this situation because of the corona. And we also observed by the WHO, when you happen to have a nebulization, you should go, all these precautions should be observed. It's already well talked and well advised and all. Okay. And most important thing is the child should be kept calm. Why? Very simple. According to Poisson's law, what they say, infant's trachea is 4 millimeter, adult is 8 millimeter. Simply 1 millimeter edema increases the resistance to 16 times, as against the adult, it is only 2 to 3 times. That too, if the child is going to cry, that flow is converted from normal laminar flow into turbulent flow, that increases the resistance to the 5th power. That is the reason why our teachers always say that when the child cries, don't do any investigation, make the child calm. Otherwise, you need to go for, I think the child's hypoxia related problem may aggravate. So make the child in a patient's lap and keep them other management in a very soft way. So these are the causes. I first covered one of the very, very important cause of stridor, that is airway obstruction, is a viral growth. Okay. And I think just now I have been, Chatterjee is telling about that hemoptysis influenza, and actually because of the effective vaccination, actually this epiglottitis is notoriously caused by HIV, and because of the vaccine, of late we are not seeing the disease at all. Sometime before, 3 decades before, we used to start with the epiglottitis alone. Typically, the child presenting with a tripod sign, that is we are not seeing nowadays. But instead of that, we widely use vaccine, that is HIV vaccine as well as corticosteroids, and there is a bacterial group is emerging. That is one of the very, even group can be caused by bacterial origin that we are going to discuss. Look at this 5-year-old child presenting, initially present as a viral group, then treated with for a viral group, and later the child, in spite of our treatment, the child not respond, the respiratory distress progressing, child was used steroids, epinephrine, but SpO2 started reducing below 90 and all. At this point, bacterial tracheitis was suspected because more than 5 days not responding and all, child is toxic, and this vancomycin and ceftriaxone is started. Later, bronchoscopy was done. The bronchoscopy shows exudates or sural membranes in the tracheal wall. Later, staph grown, and that is found to be responding to our vanco and ceftriaxone. Bacterial tracheitis is no longer very rare cause because the epidemiology is getting changed. There, sometimes bronchoscopy is very useful because it is not only a diagnostic but also therapeutic by giving a good pulmonary toilet. And sometimes it could be due to polymicrobial infection. So, as previous speakers pointed out, sometimes you have to start with ceftriaxone, vanco, and clinda. Then, depending upon the response or a culture report, you can change that. Another important scenario, it is a 7-year-old child. I think you are, please follow with me. And anyone who gets the correct diagnosis, I think he is very, very good at his practice. This is a child I have seen about 12 years before. 7-year-old child presenting with a fever, throat pain, noisy breathing, neck swelling, stridor. What you could, or these are the investigations. Can you think of a disease? If somebody thought of diphtheria, you are very, very correct. Because here, if you go into the history, the child was not vaccinated. The child is not given any primary vaccination. That is the reason. Okay, diphtheria is properly suspected. What to do next? When you strongly suspect diphtheria, don't go for any antibiotics. Simply give what is the next step? Yes, you have to give diphtheria antitoxin. Whenever there is a strong suspicion of diphtheria, we should not waste the time, because the toxin, the exotoxin is such that it will cause diffuse damage to the cells and development of X-rays and membrane, not only in the oral cavity but also in the trachea, and make the child die very fast. Actually, the child was subjected to the Albert strain and Corybacterium diphtheria is positive. We are correct, and then later the child was managed with even added with the crystalline penicillin, and child becomes all right. So what I want to say is that when a child presenting with a diphtheria or exudates on the anterior tonsils or over the fascial area, then with a stridor, we have to think of diphtheria. Diphtheria, I already said, it's a powerful exotoxin. It inactivates normally in the cell. For a cell division or a elongation factor is very important for the synthesis of amino acids. Actually, this exotoxin of diphtheria inactivate elongation factor that makes the child to die. That is the reason morning a person would have seen a normal child. By evening, you would have gone for very big, thick exudates entirely covering the tonsils and other area. So I think vaccination is very, very important. Sometimes there may be a confusion. Albert strain is suited for diphtheria, whereas even a normal gram strain is used for whooping cough. That is only for a teaching, and sometimes these are the things already forgotten. And this Albert strain we should not forget, because why I am telling is it is a confirmatory. And if you have that demonstration of metachromatic granules or velutin granules, it is almost confirms diphtheria. I think this is a last but one. 3-year child presenting with a fever, irritability, drooling, stridor, sore throat, and other things. Okay. And the child is also had a lymphadenopathy. What else? Whenever the Palak Chatterjee was saying that very nicely, when you get a child presenting with a lymphadenopathy, think of bacterial cause. That's what he has been telling and all. And the child is also, in addition to stridor, reduced oral intake and lymphadenopathy. Actually, the child was called, ENT surgeon was called, and he is able to see bulging of the posterior pharyngeal wall. So even though there is a differential diagnosis, all of our mind are focused only in the retropharyngeal abscess. I think that's correct also. Later, actually, the child was subjected into CT, contrast CT. The contrast CT shows that there is a swelling in the first, there is a pharynx that it's been widened, and retropharyngeal abscess is common between 2 to 4 years. It is rare after 4 or 5 years because there is an involution of lymph nodes that occur in the first pharyngeal area. But it may occur due to other causes like a trauma and other things. So most of the times, retropharyngeal abscess or polymicrobial, the organism could be due to strepto, staphylo, fusobacterium, anaerobes, and even hemophilus, other types. In this connection, I want to say that whenever you have a retropharyngeal, this is a very difficult area to understand. Sometimes the infection may go into the behind the pharynx, or sometimes it go in laterally to cause parapharyngeal space, and sometimes it may involve even the jugular vein. And once its jugular vein is involved, it may cause thrombophlebitis of the jugular vein, and it may even produce a lung abscess or a disseminated lung abscess that is called Linnaeus disease and all. Okay, so this is a very interesting case, last case that I am going to that. Before that, what is this? Kindly follow with me. Okay. Anybody who have been doing bronchoscopy can be seeing this. Look at the nice movement of arytenoids. You can see the vocal cord. Just below the vocal cord, can you see very small object? What is that? What is that? I think many of them, this is the area. Can you see that? And I am able to retrieve a small, initially I thought it is a peanut, okay? And actually the child has been sent, within 1 hour it came back. This is what the second one was removed. Actually the child came in the second day also, we started removing 5 pieces. Later we came to know that the entire family used to feed the child with the badam. and actually child got aspirated with too many foreign bodies. And that is the reason why we repeat bronchoscopy second time and the second day also. Periods account for 83% and requiring a prompt recognition. Actually, some periods act as a migrating one and is being pumping out from the trachea to the larynges, and it may cause a severe stridor, choking and other things and all. So even though that infectious and viral causes, bacterial causes are thing, when the child is found to be normal, suddenly developing these are acute stridor or laryngeal problem, think of foreign bodies. In this connection, I want to tell our PGs, if a child is going to be an infant, simply give back flows and chest threats about 5 times what it is being depicted here. If you do like that, sometimes if you have the foreign body in the mouth, it has been expelled out. This is a very, very important one, and it has been given the part of the pulse course, and sometimes they saved the life of the child also. Sometimes the child's age is old enough, then you can go for Heimlich's maneuver. You can give quick upward thrust by keeping your hands tight. The fist should be pressed upon the abdomen. That causes expulsion of the foreign body. I strongly advise not to scoop foreign body from the throat unless it is being visibly seen and all. So acute stridor, I think I have been covering few important scenarios, and it's a very day-to-day problem when you see a lot of patients, particularly in the hospital setup. And if the child coming with the symptoms of coryza, and particularly in the season like viral season, or if it started, then something like September, October, November and all, child suddenly getting a mild fever with a coryza, with a stridor, think of viral proof. There, the most important drug is, as I already said, steroid. Steroid can be in any form, and but better avoid the nebulization form today. You can give dexamethasone along with, sometimes child may be very requiring adrenaline nebulization also. When the child looks little older and it's also having a very high fever, toxic, or if you are able to palpate the nose and think of the bacterial group, and sometimes you need to go for further workup by taking either X-ray or even contrast CT. There, sometimes it is very difficult to differentiate from retropharyngeal abscess from the bacterial group. That's the reason why you form a team and you have to do that work. Those days we have been seeing epiglottitis, and because of the effective HIV vaccine, we are no longer seeing this typical picture of tripod sitting child presenting with a drooling and dysphagia. And I already said, any child presenting with a sudden attack of choking or sudden attack of acute stridor, think of foreign body, either even in the laryngeal area or sometimes somewhere in the above the supraglottic or even the nasopharynx. But I think properly it should be seen and all. Both don't blindly swoop, and most of the times nowadays bronchoscopy is available. If you strongly suspect foreign body, your child is subject the child for rigid bronchoscopy removal. And if the child presenting with the neck swelling, there are empty number of causes are there, starting from Ludwig's angina to diphtheria, and even look at the tonsil. We look at any X-ray. If the X-ray is there, and if the X-ray is very difficult to peel, and if, while peeling, if the child is starting bleeding, and it is a sign of diphtheria infection, and immediately go for the staining procedure, and these children can be benefited with at least 20,000 DIT, that is diphtheria antitoxin. Any child presenting with a lip swelling, urticaria or itching, think of angioedema, but it is not a usual thing to have a stridor unless the child is having a severe respiratory compromise. But if you think of a child having a repeat problem like that, think of the hereditary causes like hereditary angioedema, where C1 esterase inhibitor and mutation might be one of the causes and all. I think probably I have covered these are the things, and I think this is the last slide. Thank you for all your hearing from any questions I like to answer.
Thank you, Madhyakerala sir, for the excellent narration. I request my co-chair, Dr. CB, to take care of the question and discussion. CB, please.
Yes, sir. Thank you, Vijay sir, for that crisp and excellent talk. Actually, you have covered all the points in acute steroid infection, and especially the most common thing which a common pediatrician faces in his day-to-day practice and his casualty is about the croup. You have mentioned very clearly about adrenaline, oxygen, and steroids, and to last point, to calm the child, which is the most difficult part faced by any pediatrician. So among the questions, only one question has come up. Actually, role of HFNC in croup, high frequency nasal cannulation.
Actually, there is a Cochrane review comparing HFNC along with normal cannula, and what they find out initially, they say that 30% of oxygen given through the nasal cannula is sufficient to maintain adequate, that is SpO2 above 94 and all. I think these are the corona days. If you give there is high flow nasal, there is HFNC and all. There is I also showed that if you give that, the child may it may transmit the because of the aerosolization and all. So better go for simple time tested nasal cannula till the COVID is getting. I think there is a nebulization practice which is completely changed in the pandemic time. So, and for example, you can treat the croup either by dexamethasone or oral prednisolone. I said all are going to act only after few hours. Why you go for the very nebulization practice and all? Try to avoid till the pandemic is coming. I still bear that even the 30 to 40% of oxygen given through the cannula is sufficient, not necessary to going for HFNC.
Thank you, Vijay Segaran sir, for that reply. And once again, I thank Vijay Segaran sir and my chair, Dr. Joe sir, who is the Secretary of National Allergy Chapter, for chairing the session. Now over to Dr. Ashok sir for the next talk.
Thank you, sir, Sibi and Jose, for your excellent way of interaction.
Thank you, Dr. Jose and Dr. Sibi for chairing the session. On behalf of the organizing team, Dr. Vijay Segaran sir, our apologies for technical inconveniences. Sorry for the inconvenience, sir. Please bear with us.
Yes, sir. Yes.
Now we are moving on to the next session. Pediatric session conducted with something on something which is our bread, butter, and everything. And we have a wonderful panel discussion on childhood asthma. And the moderator is none.
Okay, it's over.
Okay, it's over.
I think two devices are on.
Okay now.
I think two devices are on.
Can I take over?
Unmute.
Am I audible?
Yeah, clear.
Yeah. Dr. S. Nagabhushna, he's the National Convener of Asthma Training Module, Editor-in-Chief, Asthma by Consensus, National Co-Convener, United Airways Module, and contributor to IAP textbooks, Atlas and Recent Advances. And our I'm not able to change the screen.
Okay.
So our panelists are Dr. Sanjeev Singh Rawat. He is the Director of Childcare Hospital Indore, Secretary IAP National Respiratory Chapter, and he is interested in pulmonology, infectious diseases, and vaccinology. One second, I'll just try again. This is a PowerPoint. Okay.
Sachi,
okay, and our next panelist is Dr. Ashwath Duraisamy. He is a consultant pediatrician at Covey Medical Center Hospital. He is a national accredited PALS instructor and a part of National Board of Examination OSCE exam setting panel. And he has published a lot of articles and journals in Indian Journal of Pediatrics, Indian Practical Pediatrics, and Pediatric Critical Care. And he was a speaker at various state pedicons and IMA meetings, has received a lot of awards during PG days and practicing years. And our next panelist is Dr. Subbarao. He's currently senior consultant at Manipal Hospital, Bangalore, former professor and HOD at St. John's Medical College Hospital, Bangalore, former president, IAP Respiratory Chapter, Karnataka branch. He has 35 publications in national and international journals, founder director of Bangalore Pediatric Academy of Postgraduate Training. So over to you, sir. Like over to the moderator and panel. Like you can actually start sharing.
At the very outset, we from the panel are grateful to IAP Respiratory Chapter Kerala for giving us this opportunity, challenge, and responsibility to share the know-how on childhood asthma. It's with pleasure and pride that I would acknowledge the presence of my very senior friend, Professor T.U. Sukumaran, who was not only the president of the IAP Respiratory Chapter, but also the national IAP president. And it was he who gave me the opportunity to take up the responsibility of being a national convener of ATM. I have, to my fortune, an excellent panel having an admixture of three tribes. We have a pure academician in the presence of Professor S.D. Subbarao, who has just now been introduced. We have a young talent, and that is Dr. Ashok Duraiswamy from Coimbatore. And we have the man, our man Friday, in the IAP Respiratory Chapter, who is the honorary secretary of the IAP Respiratory Chapter. For those of us who know the length and breadth and the depth of Dr. Rawat, you know how passionate he is in whatever he prepares. So with these three panelists, my job is very easy. And what we have decided together is to look at expert opinion on asthma in three age groups. The first age group, the most diverse and the most difficult of all of them, is the group of under 5 Vs. The second group, not so very difficult, but you see a lot of children who are diagnosed as asthma without difficulty. However, the management of asthma could be a problem in this group, that is the group between 5 and 12 years. And finally, there has been a paradigm change in the group of adolescents who have asthma in the last 3 years, starting from the year 2019 till May 2021. And adolescence brings with it unique problems which are not faced either in the under 5 or in the 5 to 12 age groups. With this brief introduction, we will have the discussion in a case scenario format. The under 5 V's case will be discussed by Professor Rao and the others would add. It's my fortune to share with you that each panelist has shared one case scenario. That case scenario will not be discussed by the panelist who has contributed the case. It will be discussed by the others who have given only the outline of the case to get the best overview from all three of them. With these few words and thanking the organizers and my panelists, could we start with the first case scenario?
My screen is visible?
Yes, sir. You can go ahead, sir. Now, before we go to the actual case scenario, it's COVID time and COVID will continue during the third wave. And I'm sure practicing pediatricians will have in their mind a number of questions about COVID and its impact on asthma. By the end of the second wave, we have realized a few truths. And quickly, I would request Prof. Dr. Rawat to answer these questions for every one of us. The first question is, parents would ask us, sir, COVID is there. My child has asthma. Will COVID worsen my child's asthma? The second question that parents would ask, sir, we are using inhaled corticosteroids. Does COVID worsen when my child is taking inhaled corticosteroids? Should I stop it during COVID times? In the same breath, they would say, sir, you are giving rescue steroids for 5 to 7 days. Will that not help COVID virus multiplication? We do not advise spirometry as far as possible, and we have given a go-by to nebulization both in our office and hospitals and restricted it only to the ICU care. The common questions that parents have is, I have a nebulizer at home. I have aged parents at home. Can I use a nebulizer? The last and the most important question would be, can my child receive COVID vaccine? And what about influenza vaccine that is coming up in social media that to take it would help COVID management? Quickly, Dr. Rawat will answer these questions for every one of us. Next slide, please. Somebody could mute themselves. Sir, we are getting disturbed, sir. Please mute yourself. Can we go to the next slide? Dr. Rawat. Rawat's up.
I think sir has been muted.
Oh, I see. Anyway, as long as he is coming, answer to question 1. We have realized.
Okay,
Dr.
fine.
Rawat, are you there?
Yes, sir. Yes, sir.
Please go ahead, sir.
Yes, sir. So, thank you very much. First of all, I'd like to thank IAP Kerala Respiratory Branch and IAP Madhyakerala for inviting us for this very important panel. Thank you, Dr. Nagabhushan, for all the preparation you have done for this panel. So we straight away come to the topic. Now, the first question which you had asked me, are the children with asthma at higher risk for COVID? The answer is no. They are not at all at high risk for COVID, and in fact, the risk of asthma getting precipitated by viral infection has gone down because of all the restrictions and the children being confined to indoor. The risk of viral infection has gone down to a great extent. That's why asthma mostly it's precipitated by viral infection. So, as a overall, the incidence of asthma acute episodes have gone down, and COVID it doesn't lead to increased attacks of asthma. But only one thing is that those children who are on OCs, oral corticosteroid, they are having a higher mortality. So the basic underlying is that you please manage your asthma well so that they don't require oral corticosteroid, because in case if you require OCS, there is a high mortality with COVID-19. Then whatever medication you are taking, you might be taking inhaled corticosteroids or you are taking oral corticosteroid, whatever you are taking, please don't stop them, because they have to be continued with the same dosage, whatever has been prescribed, because proper management of asthma is most important, because if it is an acute episode which is not managed properly, then you might land up in problems. So again, the second advice, whatever drug you are taking, it may be ICS or it may be ICS LABA or oral corticosteroid, it has to be continued in the same doses as they have been prescribed to you. Third issue of spirometry, of course, spirometry, as you know, it involves a forced exhalation, and there is a high risk of infection for the people who are conducting spirometry. It can go as high as 1 meter around the equipment. So spirometry is a strict no during COVID pandemic. Try to please postpone it and try to avoid it. In case if it is unavoidable, probably you have to have a place where there is a laminar flow, where the chances of infecting people who are doing the test, they are not there. So again, as a guideline, please, there is a no to spirometry, please postpone to some other time. Use of nebulizer, again, as you know, IAP respiratory chapter and asthma training module, we strictly discourage the use of nebulizer at home. So again, it is a big no, and even in your hospitals, in your clinics, particularly, because again, the nebulization is an aerosol generating procedure where you can infect people who are around. So again, it's a strict no. And nebulization should be used only in hospital setting where you are trying to manage a child with acute asthma who is very sick. And in that situation, probably you will have to have a good laminar flow devices which to prevent the infection from spreading. So again, the underlying advice, please try to avoid nebulization at home and at your clinics. In hospital, wherever there is acute setting with a good laminar flow, probably you can do it. Regarding vaccines, there are a lot of messages occurring in social media regarding COVID-19 and flu. Very clear message. There is nothing to do with influenza vaccine and COVID-19. Flu vaccine is for flu. COVID-19 is absolutely different. So clear message. By giving flu vaccine, definitely you can prevent acute episodes of asthma occurring because of flu, definitely, but it will not prevent COVID-19. So as a general advice, all children with asthma, they should go for the annual flu vaccination to prevent acute episodes of asthma precipitated by flu. COVID-19, since the vaccine is not still licensed for children below 18 years, so till now there are no real guidelines, but for people who are above 18, there is a clear guideline by GINA that those people, all people who are having asthma, they can get the vaccine, because definitely the vaccine is going to protect the people against COVID-19. So for all people who are above 18, they should get the COVID vaccine. There is absolutely no contact. So I think these are some important things which are important we should remember regarding COVID-19 and asthma. Thank you very much.
Thank you, sir. The only other point which should also remember is that if there is a dire need for pulmonary function test, they could do peak flowmetry at home and then message the values to their doctor. That is something that can be done in brittle asthmatics. Number two, children who are on inhaled corticosteroids, who use a rescue corticosteroids, may not be at higher risk of severe COVID, but those who are only on oral corticosteroids for other reasons, they may be at higher risk. But what is also important for every pediatrician to share is to take the COVID responsive measures, meaning don't take the child to a mall, don't go to crowded places, wear masks, particularly to avoid it. That's something that has to be done, and that the parents have to be informed again and again. With that, thanks, Dr. Rawat. We'll go to the first case scenario contributed by Dr. Ashwath, to be discussed by Professor Rao as the lead discussant. And finally, Dr. Ashwath will have his last word on how he managed. This is the scenario. And as we discussed earlier, under 5 group is a bag of surprises and challenges to everyone treating them. Prithvi is a 2-year-old boy with recurrent episodes of cough, noisy breathing, and wheeze since 6th month of age. One dictum that we follow in under 5 wheeze is to look at the age of onset of wheezing. Antenatal, natal, and infancy phases were uneventful within inverted commas, because remember, he started wheeze at 6 months. These episodes were stereotypical: fever, cold, cough, which progressed to wheeze. In between attacks, he tires very easily while playing. His sister has atopic dermatitis. the father smokes, but he says, I only smoke in the home veranda, and it is for you to take that with a pinch of salt. Next. How was he managed? They gave him oral salbutamol and antihistaminics during flare-ups. When in emergency room, he received nebulized salbutamol, was discharged after 3 nebulizations on oral salbutamol and steroids as add-on 5 to 7 days. Chest X-ray was done twice and was read as normal. The parents are frustrated, and that's why they came to us. Next. These are their questions. Is my child having asthma? If not, when will these episodes lead to asthma? Can you do some tests, blood tests, scans, allergy tests to guide us? Will he outgrow as he grows older, which is the usual dictum? We are really scared about using inhaler therapy in such a small child. Can we invest in a home nebulizer that avoids coming to you frequently? What can we as parents do to decrease his episodes and make him better? Next. What could be our answers? Quickly, Professor Rao.
Before I go to this, let us see this case scenario. In addition to what Dr. Nagbhushna pointed about the age, what I am worried is the noisy breathing in addition to wheezing. Very often we get confused that wheeze could be a noise, but these noises could be different. I'd like to keep it in mind. But however, the rest of the things have something else to worry about. So these are the questions that are posed, and let us see whether the current guidelines give an answer for these questions. Now, first question is it asthma? And unfortunately or fortunately, like Nagbhushan said, under 5 is a bag of surprises, and any damn virus that is known in the world will trigger a wheeze and not necessarily an asthmatic episode. That's what makes our job very difficult, because we cannot sort out whether it's a virus triggered wheeze or it is actually an asthma. To keep things in perspective, we should realize that in the earlier episodes of the GINA guidelines, they had 2 kinds of approaches for under 5 wheezing. One was what is called the symptom-based approach, where we talked about the virus-induced wheezer and the so-called multi-trigger wheezer. And there they said the virus-induced wheezer would be completely asymptomatic between episodes, and the multi-trigger would be continuing to wheeze with other risk factors. And then they proposed a second, what is called a time-based, on depending on the time of onset of wheeze, and they called it as early transient wheezer or persistent wheezer and late onset persistent wheezers. But these are all based on retrospective cohort reviews, and they would not stand the test of clinical medicine, and that's why they had to rethink. And currently, probably this is the best approach, at least as of today, is what is called a probability-based diagnosis. Now, what does this probability-based diagnosis mean? It relies on 3 important parameters: is the duration of cough following a viral infection, and the number of episodes per year, and what is the child doing between episodes. So in this probability-based diagnosis of asthma, if the symptoms following a respiratory infection is less than 10 days and episodes of 2 to 3 per year, and in between the child is completely all right, the chance of this child likely to have asthma is very, very less. The second category is those with have a duration more than 10 days and they have more than 3 episodes, and in between child is not doing so well, and these have got plus minus, they may go into asthma or they may become normal. But the last category is one where the prolonged respiratory symptoms more than 3 episodes, and child continues to have wheeze between episodes, and very importantly, there is history of allergic sensitization, atopy, and these are going to be definitely having asthma. But what else makes under 5 wheeze more difficult is these are not rigid compartments. They all can go from one to the other. So it is very imperative that we don't label a patient as asthmatic at our first contact. We may have to follow them over a period of time, and maybe sometimes we have to give a trial of medication to see whether they're doing well or not. So that is where we stand as for the diagnosis of asthma, and to tell this parent, especially this Pavitra, that there are some things which will make this child in the middle category. The child may go way this way or that way. Follow-up can tell, right? But there are certain symptom patterns which I'll share with you shortly, which will make our asthma suspicion a little bit stronger. And of course, in this child example, we have got risk factors like the family history of asthma and atopy, and definitely a therapeutic response with controllers. And under 5 users is very, very tricky for comorbid conditions and other diagnoses because the natural anatomy of the airway and other disorders. So, and hence, asthma diagnosis becomes also a possibility of exclusion. Now, what are the features suggestive of asthma in under 5? If the child has got non-productive cough, which is worse at night, worse than laughing and crying and running, and absence of respiratory infection, this is important when we interview a child with cough and wheeze. These questions are very important to make sure that this child is having asthma. The second symptom is the wheeze, which is recurrent. Again, nocturnal symptoms are high, and these wheeze episodes could be triggered by crying, smoke, and air pollution. The third thing is heavy breathing, again triggered by laughing and exercise, which will again make us suspect that there's a possibility of asthma. And more lethargic and more inactive when compared to other children of same age also could make us suspect asthma. And of course, like I emphasized earlier, a strong family history of atopy and asthma makes us think very strongly for asthma in these children. And lastly, there is a role for giving a trial of controller medications and see if there is improvement. And if the child improves on control medication but becomes worse on stopping, that is a fourth clue to tell us that there could be a possibility. However, follow-up is necessary before we label these patients as asthma. The second question that was asked is there indications for investigation? Of course, there are set of clinical criteria when the child is failure to thrive, early onset, associated vomiting, continuous wheezing, non-response to controllers, and there's no associated triggers, and other features like cardiac murmur or clubbing should all make us think that is there any other possibility. And that is the list of differential diagnosis all of us are familiar. I'll not go into. So when in doubt, with all this list, probably investigation comes into it. Now, very important is when parents ask us that is inhalation addictive, is inhalation dangerous? And Nagbhushan has got very good explanation how to explain. Simply said, we should tell them that when we take oral medications, we give it in terms of milligrams. And when we give inhalers, it is in micrograms. And if a wound has to be treated locally, that works better than giving systemic. So you have to spend some time in counseling them. There is going to be doubts and worries, but that has to be done. It cannot be done in one sentence. And currently and ever, home nebulizers would know, one mainly because we will not be able to assess the degree of control, because one of the main parameters of degree of control is number of times the child uses controller medications and short-acting beta-2 agonists. And if they're given home nebulizers, I've seen patients even for just running nose and cold, there is a nebulizer mistaking it for these. So we will not be able to assess the severity. And nebulizers are hospital instruments, except for those which are brittle asthmatics. We don't recommend nebulizers at home at all. So I think that will answer most of the questions. If there's any additional points, Dr. Nagbhushan will summarize. Nagbhushan.
Okay. That key slide, sir, can you please put it up?
Yeah, it's there.
Yeah. Now, the most important thing that we have to realize in under 5 Vs is that more the level of inflammation, more the severity of inflammation, more will be the symptoms. That means if a child has higher level of inflammation following a viral infection, he will cough for more than 10 days. If the level of inflammation is more, then the triggers become active and he will have more than 3 episodes of wheeze in a year. And when the level and the severity of inflammation is more, we would use a trial of inhaled corticosteroids, budesonide 100 microgram twice daily for 3 months. Now, if the level of inflammation subsides automatically, as it would do in many children, this child will be asymptomatic, and therefore we will not need another trial of budesonide. In case the level of inflammation was suppressed with our first trial of budesonide and it again increases, we may need a second or a third trial of budesonide. This is something the practicing pediatrician has to remember. Unlike other age groups, we would not use budesonide right, left, and center in all children. The reason being, a good number of children, as Professor Rao said, can change from the right box to the left box. Number two, use of ICS in under 5s has not related to final better outcome in these children. And number three, we don't know the effect of budesonide in such a small age group. That is something that we need to remember. Now, what are the key messages for under 5Vs according to experts? As we discussed earlier, if a child starts wheezing at 2 months, the chances of alternate diagnosis are much more as compared to a child who started wheezing at 2.5 years. In any situation, if a child has unsatisfactory response to bronchodilators, and all these can happen in Malaysia syndromes, and you gave salbutamol, the child worsened, think of Malaysia syndromes. Professor Rao has cogently discussed probably based diagnosis. More the merrier, more the number of symptoms, less are the chances that there could be an alternate diagnosis. And therefore, retrospective analysis is necessary. And we discussed to give a trial of budesonide when in doubt. And Professor Rao has clearly told us when to look for red flag signs. For example, a wheezing and wasting infant is a red flag sign. An infant who does not have only respiratory but other system symptoms is a red flag sign. With these few key messages, I would like to share what is new in under 5 wheezing for the sake of postgraduate students. Next slide, please. We thought under 5 wheezing, we could not do pulmonary function tests, not any longer. The postgraduates have to remember there is impulse oscillometry, which is being done in a few centers in India. You can very easily assess the lung functions of these children based on their tidal flow. For the postgraduates, it's worthwhile to read from GINA guidelines the importance of early sensitization, which may predict a different outcome. With those few words about under 5Vs, we now request Dr. Ashwath to share with us how he managed this child Prithvi successfully. Dr. Ashwath.
Good morning. My pleasure.
Okay, thank you.
IAP Kerala and Professor Raghushna for making me part of this team. As was beautifully discussed by Dr. Subbarao. Current
Will the others be muted, please?
So based on the current GINA guidelines, our understanding was that this child has had repeated stereotypical viral induced wheezing needing recurrent ER visits. He needed oxygen and nebulized salbutamol and has shown a consistent response to salbutamol and steroids. So even though two red flags were there, one was the onset at 6 months of age, and as Dr. Subbarao said, there was also a history of noisy respiration. So then these two presents are there. We are thinking more in terms of a airway Malaysia syndrome, like a tracheobronchomalacia or an upper airway problem that can very easily mimic an wheezy episode which belongs to the asthma group. Having said that, the fact that this child's sister has eczema, the father is a smoker, in between the attacks, the child would tire very easily with exercise, and the fact that the child shows a consistent response to the consistent management plan in the ER for an acute severe episode, all of this were making us to think probably the child comes under category 2 or 3, whereas many or most of them would have asthma. And it's a very important point to remember. There is inhaler phobia, and giving drugs by inhaled routes is taken by many parents, even educated parents, as a sign of something which is addiction forming. So it is very useful to spend more time, give more time than medications during the first few visits. Take time to draw pictures. You can use models to explain what a normal airway looks like and what an inflamed airway looks like, so that when you tell them that the drugs are getting delivered to the place of insult, injury, rather than going all over the system, and that the side effects are actually less when you're using the inhaled therapy, most parents will be convinced. And in Prithvi's case, we were able to convince the parents that we are dealing with a situation where there is a high probability of this being an asthma. And after drawing pictures and showing them what was going on, we could initiate this child on inhaled corticosteroids for a period of 3 months. And we could demonstrate to the parents that the symptom intervals were much better. The child started gaining weight and the child could play and be more active. They were also convinced that this medication was making the child better. We also utilized these interviews to stress upon the father the fact that he could quit smoking altogether, and that would be a very important add-on intervention to make Prithvi's management easier. Thank you.
The few other points which we need to look at in a under 5 wheezing is look at how the baby sleeps. Children who have vascular anomalies, if you put them prone, they feel much better as compared to if they are supine. Number 2 is to watch the way the baby feeds. If a baby has choking episodes, noisy breathing, when the baby feeds, you could be having an alternate diagnosis. Thanks so much, Dr. Ashwath, for the crisp and clear presentation and successful management. We go to the next case, and if there are any questions on under 5 Vs, please type it in the chat box and we will be able to answer them at the end of this 3 case scenarios. The second case shall be discussed by Dr. Ashwath. This case has been contributed by Dr. Rawat. Now, look at the age of this child. This child is a 10-year-old girl, referred for difficult to treat asthma, history of recurrent cough and breathlessness since 4 years, episodes occurring once in every 3 to 4 months. She gets up often at night due to cough and needs salbutamol puffs almost 4 to 5 days a week. Next. Treated for the first 2 years with antibiotics, cough mixtures, oral steroids, nebulizations with salbutamol, budesonide and ipratropium. Probably all were for short duration. He would respond in 5 to 7 days, and these episodes would recur again like our monsoon. She was referred to a pediatrician 2 years ago. She was diagnosed as bronchial asthma, put on budesonide, 1 puff twice daily by MDI and spacer, and salbutamol by MDI with spacer as needed. I will stop here. We'll go back to the first slide and then to the second slide for a quick analysis by Dr. Ashwath.
So this is a completely different case scenario from what we discussed in the past. First is the age group. It's a 10-year-old child, and this child's illness has been there for more than 2 years. So we believe sincerely that this child's diagnosis is right. So every time we have this category of what we call difficult to treat asthma, the ATM module and our teachers have repeatedly asked us to remember simple mnemonics. 1D is, before you label an asthma as difficult, take some time to go through the child's history and confirm that it is indeed asthma. That is, you are ensuring that the diagnosis is right. Second thing that you consider in a difficult to treat asthma is whether the drug is appropriate. So in this child's case history, 100 micrograms budesonide twice a day using an MDA spacer device is appropriate. The third thing that we need to...
Next slide, sir. Subrao, sir.
So the next important point is, having given the diagnosis and the drug, we look at whether the dose is appropriate. For a child who has got a decent degree of control, 400 micrograms twice a day will come as low dose corticosteroid. So this is an appropriate dose. The fourth is to go through the device and see whether the drug is getting deposited properly. Because it is being given with an MDA and spacer, this is probably not an incorrect thing. So your diagnosis is right, your drug is right, the dose is right, and the device is right. What we are not sure about is the discipline, which is the fifth D. We have written drugs, we are always going to tell them what to take. But like we said repeatedly, take time to effortlessly show them how the drug is to be used. Because writing them on the paper and hoping that the parents have understood what you meant in your prescription, there is many a slip between the cup and the lip. So take time to tell them that this is how the drugs are to be used. So if the discipline of a child is inappropriate or the drug delivery is inappropriate because the medicines are not getting delivered properly because of inappropriate inhaler technique, we could face a situation where the asthma is being labeled difficult, whereas the difficulty is not in the management, but in getting the drugs delivered to the space. So definitely in this child, I would like to personally verify that this child's drug system is working the way I would like it to be given.
One question to you, Dr. Ashwath. This child started having symptoms at 4 years of age. She is 10 years old now. Had the girl met you at 4 years, would it have made a difference to her final outcome? 6 years of wheezing.
Unfortunately, at this point of time, all the asthma medications that we have currently in our armament are basically anti-inflammatory, symptom control, anti-symptomatic treatment. At present, unfortunately, we do not have any medication that can significantly and meaningfully alter the natural history of a disease. So I think I would still be seeing Ms. R 6 years later. If I'm confident that my diagnosis is right, I probably take the patients along with me and tell them what the drugs currently can do. They can provide good symptom relief, they can prevent exacerbations, they can allow the child to grow and thrive well, but our medicines probably will not cure her of her complaints.
Okay, next slide, sir. The frequency of episodes did come down, but the episodes continued every 6 to 8 months. She was admitted in hospital 2 months ago for 7 days for a severe episodes and was treated with the medications mentioned there. She has consumed 4 canisters of salbutamol in the past 1 year. Now, I would like to focus on 2 issues. Dr. Rawat says that the frequency of episodes have come down now, once in 6 to 8 months. But he also says that she had a severe episode needing hospitalization. And he says she has consumed 4 canisters of salbutamol in the past 1 year. Now, I am confused. On the one hand, he says the number of episodes have decreased. On the other hand, he says she is using too much salbutamol. And he also has brought in the issue of hospital admission for a severe episode. What do we understand?
So this is a very, very important point, because in the current management protocol, we look at 2 degrees or 2 domains. One is what we call the control of symptoms domain, wherein we look at 4 criteria. Do we have daytime symptoms? Do we have nocturnal symptoms? Do we have activity limitation? And do we have a more than normal frequency of reliever, that is short-acting beta agonist use? If we went by that criteria, if this child has been using 4 canisters of salbutamol in the past 1 year, and the child is having frequent episodes, she is obviously underreporting the degree of severity of her illness. That is the first complaint as far as the symptom control. So the GINA guidelines say that we could classify asthma control into three parts: controlled asthma, poorly controlled asthma, or uncontrolled asthma based on the symptoms that we discussed: reliever usage, activity limitation, daytime symptoms, and nocturnal symptoms. If we believe that this child has been using salbutamol appropriately, I would say this child has got a very poorly controlled disease. The second part of the domain that we look at is risk for future exacerbations and worsening lung outcomes and probability of risk from drug-related toxicity. Unfortunately, by going through our history, we are able to see that she's had emergency visits, she's needed oxygen, she's needed parenteral steroids, and she's also at a very high risk for drug-related side effects because the number of salbutamol she is using in the past 1 year is not correlating with the history of episodes coming once in every 6 to 8 months. I think she's underreporting her disease.
Now the question is, what if she uses salbutamol? What's your problem?
No, if we use salbutamol repeatedly, we know that it works on the beta-2 receptors. And all the beta-2 agonist drugs demonstrate tachyphylaxis. So if she keeps using salbutamol repeatedly without the doctor's or her parents' knowledge, there is a good chance that the number of beta-2 receptors in the bronchial epithelium will get downregulated. So if and when she has an acute episode, the salbutamol that you would give by any route is unlikely to give the same amount of benefit that would give in a normal person. Two, a salbutamol, even if it's by the inhaled route, will produce a bit of tachycardia and a bit of tremors, and abuse potential is high with salbutamol.
Two important factors were brought out. It's not the symptom control alone, but how the symptoms were controlled, how much of salbutamol was used. And number two, if a child has an acute flare-up, then the control is not satisfactory. So these are issues. More severe the episode, more severe the bronchial inflammation, and I think we have failed in our responsibility in managing this child. The other issue is, if the diagnosis of asthma is certain, and if you have used inhaled steroids early in the course of illness, we might not make this child a non-asthmatic, but we would probably prevent rapid deterioration of lung functions that could have happened in this girl over a period of time. And that is something that all of us have to remember. Number two, Dr. Rawat has brought out a very important issue. If you are using 1 canister per month for 3 months, then the chances of acute flare-up is more. And if you are using 1 canister per month for 12 months, then the chance of acute death due to an acute severe exacerbation is more. That means salbutamol canister use is directly proportional to the complications of asthma, and that is something you and me have to find out when parents come. Otherwise, salbutamol is cheap. It produces bronchodilation within 15 minutes, and parents would like to use a drug which is cheap and which can work according to them. Now, next slide, sir. History of recurrent sneezing, running nose, and blocked nose during winter season was prescribed a combination of levocetirizine and montelukast for a year with partial relief. No history of skin disease, no history of food allergy. Plays basketball, often gets cough while playing. She takes salbutamol puff directly without a spacer. Obviously, she is in the playground. She won't carry her spacer. She gets some relief, but she has to interrupt her play frequently. Dr. Ashwath.
So this slide is also full of options for us as to understand why at 11 years she's got such a miserable control over her disease. Looking at the first point, the history of recurrent sneezing, running nose, blocked nose during season is a very, very strong pointer towards what we have always been stressing as the united airway concept. One airway, one disease. So when you have allergic rhinitis, screen the patient for coexistent asthma. Vice versa, if you have a patient with asthma, whether it's poorly controlled or optimally controlled, take some time to evaluate the upper airways. A coexisting allergic rhinitis will make management of asthma simpler and easier. So probably in this child, there is a coexistent allergic rhinitis, albeit a seasonal one, which is also contributing to the poor control of the asthma. Having said that, the best way to manage according to guidelines, inhaled nasal steroids are the way forward. India is one of the few countries where we continue to practice the scientifically unsound principles of giving levocetirizine and montelukast in the same pill or same syrup form, which is not an appropriate medication. And she is an 11-year-old girl. She will tend to become very embarrassed if she is seen to be carrying a spacer device to the playground because there is a stigma associated with asthma. So she is trying to use a salbutamol puff and not expose her usage of the drug with the delivery system to her peers. So one way we could do this is to help her to warm up or to prepare herself before she starts playing a basketball match, or we could advise her to take a short course of ICS LABA combination, which could give her a better control even before she goes to the playground, so that she can complete her play without any interruption. These are two additional points which tell us that her asthma plan is something we could improve upon. One is management of allergic rhinitis. Two, preparing herself to prevent this exercise-induced bronchospasm by doing some simple home maneuvers.
Dr. Ashwath, some people speak of united airways. I don't understand.
So I just briefly touched upon that point. So when we are talking about the typical allergic asthma, we believe that it is a manifestation of atopy. So we have eosinophil mediated IgE driven process, which is starting from the pseudostratified ciliated epithelium from the nose, going all the way down to the lower airways. So nearly 70% of people with confirmed physician diagnosed asthma have some degree of allergic rhinitis. If you look at 100 children with allergic rhinitis, nearly 1/3 of them will have some objective evidence of lower airway disease. So that is why we stress that if you have an asthma, take some time to look at the ARIA guidelines to see whether this child has got a coexistent allergic rhinitis, and vice versa. If a child has come to you with predominantly upper airway symptoms, also see whether this child has got a disturbed night sleep, disturbed exercise tolerance, whether this child has got frequent cough during the nights and early mornings. Always screen the patients for the other part of the untold story. Upper airways, ask for lower airway. Lower airway complaints, please screen the patient through history and a simple physical examination for a coexistent upper airway allergic disease.
Thank you. And we should all remember that a good, effective management of upper airway inflammation is the key for managing the lower airway inflammation, that is childhood asthma. And that has been not recognized in this child. So you need to treat the airway inflammation in both places in order to be successful. And number two, as Dr. Ashwath said, she could take salbutamol via spacer at home 15 minutes before. Then come to the playground, do gradual warming up, and then do the basketball game when she is less likely to develop bronchospasm. So that's something they could really do. Travel home to the playground after taking 2 puffs of salbutamol. Number two, in a child like her, exercise-induced symptoms are clues to say that asthma is not controlled well, which means she needs a higher dose of controller medications which can take care of her day-to-day symptoms as well as exercise-induced symptoms. Because she is a conglomeration of asthma allergic rhinitis. So that's a clue to say the inflammation needs to be better controlled. Next slide, sir. Family history, 2 younger siblings healthy, no pet at home, house well ventilated, no obvious dampness in the home. Father is an asthmatic and on inhaled medication. Next slide, sir. Now, what did the doctor do? She was demonstrated once by clinic staff on how to use the MDI with spacer. However, the technique was never rechecked, and on subsequent visit by the doctor, probably he was very busy. She also takes puffs directly without the spacer as she feels that she is confident about the technique she has learned on YouTube. Parents also are confident about her technique. However, this fact was never disclosed to the doctor as the doctor never asked for it. This is a day-to-day situation. Next slide. We have done our assessment so far, and Dr. Ashwath has very clearly brought out the issue that every time a child comes to the clinic, we request the child and the parents to bring with them the child's own inhaler and spacer device. If it would be prudent if the doctor could check it on his own, or at least train his assistants to check the technique. What we do in our clinic is to record the child's inhalation with our mobile and then play that mobile to the child to show her and her parents where she is going wrong. And we always keep a recording of a perfect technique by another child, and we share that video with this child to say, look, this is how you should be doing this. And if the child comes back next time and does it the way that we have told the child, a smile and a pat on the child's back to say, look, you have done extremely well, boost the confidence of the child and her parents. In studies on adults, they have noted that more than 50% of adults were unable to do a proper inhalation technique during the very second visit they came to their physician. If adults cannot do it so well, then how can we expect the child to do it? Next slide. On examination, Dr. Ashwath, 20 kg, a child who is 10-year-old. Look at her pulse, look at her breathing. Fortunately, there are no red flag signs as clubbing, pallor, etc. She has a prominent Harrison sulcus, Dr. Ashwath. She has bilateral air entry, vesicular breath sounds. Now, what is the importance of Harrison sulcus in a child who has been wheezing from the past 6 years? And I would like to share that IAP Kerala has brought out videos on proper inhalation techniques. Those viewers who are listening to us can contact IAP Kerala Respiratory Chapter for those excellent videos. Over to Ashwath.
What are the most important red flags?
Yeah.
Here are the fact that this child's growth is faltering. That is yet another point to show that this
meeting mugdilla.
So that is another point which tells us that poorly controlled.
Unmute, please, others.
Yeah.
The other important finding is the prominent Harrison sulcus. What we do know is in the past 1.5 years since the COVID lockdown has been in place, most children are not getting any outdoor time. They do not engage in sports to the extent that we recommend. So sunlight exposure, contact sports, stepping out are all very less, and they're all sitting glued in front of screen most of the time. So there is a good chance that this child has been having hypovitaminosis D. The prominent Harrison sulcus also could be the result of repeated episodes of wheezing wherein the diaphragm has been contracting and relaxing and has been overworked over nearly 6 or 7 years. She started wheezing from 4. She's 11 years old now. That is another point to tell us that the child's disease has been suboptimally controlled. Her weight is altering. She's got a Harrison-Sulcus, and these are troubled and very atypical times.
Thank you. I think we should remember that an uncontrolled asthma can cause growth faltering. Because many times parents will ask us, sir, you are giving inhaled corticosteroids. Will it not affect our child's growth? Dr. Rawat has given us a cogent example where uncontrolled asthma has caused growth retardation, both of weight and height. And this is something we should be telling parents, that an uncontrolled disease can cause much more growth faltering than the expected growth faltering of 1 centimeter in the only first 1 year of life when we use inhaled corticosteroids. So this is something which can be used as a practice parent education point. And the postgraduate should remember that a Harrison-Sulcus indicates chronic respiratory disease. Next slide, sir. Next slide. Should we investigate this child, Dr. Ashwath? If so, why?
I personally would want to do only one investigation in this child. She is old enough to cooperate for a spirometry. Now we have seen there is a reluctance on the parents' aspects to accept, because the slide very clearly says child is very confident, parents are very confident that the inhaler technique is right. So now they are under the impression that the drug is being delivered properly. We have to demonstrate objectively to the child and to the parents that this disease is poorly controlled, and therefore some corrective measures need to be instituted. So what I would want to have on this child is probably an ENT colleague to evaluate the upper airways, especially the adenoids. 3, I would like to do a spirometric evaluation to look at the child's FEV1 and FEC to get an objective evidence of how poorly the airway inflammation has been suppressed.
Thank you. Now, the spirometry would help us in 2 ways. It will serve as a baseline, plus if the child improves further, it will be a positive evidence to say that the child has made objective improvement. And the expert opinion now is to do lung function test sans COVID whenever possible. Once the 3rd wave of COVID is over and we are all having normal life as before, it would be prudent to do the spirometry as and when possible. If you can't do a spirometry, at least teach this child to do a peak flowmetry. She is a 10-year-old and she could do it. Next slide, sir. I think we will go ahead. And Dr. Rawat, as you have seen, has done even the serum vitamin D level, which Dr. Ashwath was alluding to. Now we know that children who have difficult to treat asthma sometimes could have hypovitaminosis D, and it would be prudent to correct it as and when it is found. Next slide. Now, what we have summarized this, and I think all of you are aware of this child. Eosinophilia in the CBC indicates that this child has a atopic disease, and this should not be treated with hetrazone. Next slide. Next slide. Now, that's the final diagnosis. Now, what has Dr. Ashwath done so far? Dr. Ashwath has told us cogently that give your time more than your prescription, check for the 3 Ds, look out for comorbidities, document lung functions always. Frequent flare-up means the child is not well controlled. Activity-induced symptoms like exercise, better management expectations, involve all family members, particularly if it's a joint family, involve the grandparents and the parents in child care. Next. What's new? The newer guidelines tell us this cycle of assess, adjust, and review, and look at the heading that not just about medication, one size does not fit all. So the same severity in a different child with a different parents and their outlook, we may have to modify the type of medications which we use in these children. And let us all remember that only use of salbutamol, even in the age group between 5 and 12 years, is now no longer recommended. And whenever there is a situation you will use salbutamol, it may be at least worthwhile to use a low dose budesonide 100 microgram following the salbutamol dose. And that's the most important change that is happening in the 6 to 12 years age group. Next. And this is called the combination therapy. Now, in the age group of 6 to 12 years, people have used what is called the MART therapy. That is one medication for maintenance and reliever, and this has been extended to the age group of 6 to 12 years. That means you have a combination of budesonide 100 micrograms and formoterol 6 micrograms. This one inhaler could be used as a reliever even in this age group instead of using salbutamol and budesonide, because we now know that if you use 2 inhalers, compliance is an issue, and therefore you can use one inhaler both for reliever and maintenance. However, alternate salbutamol with ICS does exist. Now, this alternate use of SMART therapy is only for children above 6 years. It is not in the under 5 age group. Next. Now, there is a video. Viewers will put your answers in the chat box. The video, sir. This video is contributed by Professor Rao. Sound, please. This is a child who came with recurrent episodes of coughing, and the parents would nebulize this child at home, though the child would not get better. Look at that child. This question is not for the panelists. This is for the audience. Type your answers in the chat box, please. If you have seen the video, as you are typing, we go to the last case scenario to be discussed by Dr. Rawat. Simple case scenario, 16-year-old boy with wheezing and breathlessness since 3 days, weighs 56 kgs. Look at the age and look at the weight. History of eczema in childhood was well till 2 years ago and has been wheezing on and off and going to the hospital 8 weeks ago for severe wheezing. Was prescribed inhalers but has not been taking regularly. I will take only one inhaler. That's it, he exclaims, this adolescent. He evades answer to questions on personal smoking. Father has COPD and he smokes even 1 to 2 packs of cigarettes per day. He is interested in outdoor sports but has difficulty to perform, and that annoys this adolescent. Dr. Rawat, over to you, sir.
Thank you, Dr. Nagbhushan. Again, as we have discussed in the past case, this child who is about 12 years, he has got different issues and a different way of management. Now, with the first look, the child has history of recurrent breathlessness and wheezing, and he has been on cannulas off and on with some partial relief, with an history of eczema, and so definitely this child has an asthma, although it has never improved. So one thing which I want to emphasize upon you is that whenever you, the thing has come as that whenever you diagnose or suspect asthma, please do spirometry, because spirometry is one of the diagnostic tests to confirm asthma, and then only probably you can go ahead and start the treatment. So first thing is that this child, although with history, it looks like he has got recurrent cough and wheezing, and there are some markers of allergy in form of eczema, and father could be asthmatic or probably he's smoking COPD, but definitely child has symptoms of asthma. And first thing I like to confirm in this child that the child has asthma by doing a spirometry and showing that he has got a low FEV1 and low FEV1 and FVC, because I have some objective way to prove that you are having asthma. Then the second most important thing is that in this child probably I like to know the level of control, because I have to basically put him at what step you want to put him in, step 1, 2, 3, 4, because whenever you institute a treatment, probably you'll have to know the level of control, and then only you can start the treatment. So this child, although I like to have more history, like how many times he has been suffering, what is this canister use, and his nighttime awakenings and number of acute, definitely you have told that there is one acute episode. So again, I want to emphasize that even a single episode of acute exacerbation which requires hospital admission, that is enough to categorize that asthma into a severe category, and this child is going to go straight away in step 4 therapy, where you start with an higher dose, probably you start with a medium dose of ICS and formoterol. Okay, so this child on assessment, probably he has an uncontrolled asthma, probably with an acute attack, and probably he's going to go to step 4. Then we assess probably comorbidity. Again, this child is an obese child. Again, obesity is one of the very important comorbidity, where these children are known to respond to your inhaled corticosteroid in not the way in which you expect. So probably along with your medication, this child would require a lot of advice regarding his weight reduction, and very important, exercise, because only trying to emphasize upon diet therapy to decrease weight probably will not do good to the child. This child would require an exercise training program where he would do exercise along with diet therapy so that he cut down his weight. Fourth important thing is that inhaler technique. Again, it has to be very emphasized that a child who is not responding, as Dr. Ashwath had discussed past in that previous case, the technique may be wrong. This child is not complying with the drugs. Like if he has been told to use 2 inhalers, probably he's not doing it. He's using only one, probably he's using only SABA, and probably he's not using his ICS. So this is a child whom you require to sit down, try to give your time, and try to tell him that whatever drug has been prescribed, it may be 1 or 2 inhalers. First of all, he has to use a spacer, because he's an adolescent child. There are a lot of issues regarding compliance with adolescent. Probably they think that probably they can use inhaler directly, and they are expert, and probably why do you want to use a spacer? So this child would require a lot of counseling with the doctor, giving him time and telling him why using a spacer, the amount of drug going into the lungs would be about 30%, whereas using directly it will go about 5 to 10%. So this thing has to be told to the child clearly by using diagrams and by using charts, making him do the things in front of you, trying to correct whatever mistakes he's doing, and be sure that he is doing the technique in a proper manner. Then again, now as you know, there is an advancement that in children about 12 years and in adults and adolescents, there is a thing known as track 1 and track 2 therapy. So in track 1, we are using a combination of formoterol and budesonide as a deliver. So this is more preferred. Why? Because this
I
combination is going to decrease the number of
because I can't
like
stop his
if you try
train
to
of thought.
So if you try to if you try to compare the use of ICS and budesonide and formoterol versus ICS and LABA, or using of salbutamol and ICS, the acute attacks, they are much less with the use of budesonide and formoterol. So it has to be very clearly, this child requires to be shifted to a MART therapy, where he uses a maintenance budesonide for formoterol. Probably since he has an acute episode, probably he'll go in a moderate dose of ICS formoterol combination, and you'll use this budesonide formoterol as and reliever as and when needed. So this child has to be clearly told that, okay, I understand that you are having problem in 2 inhalers. Okay, I will give you 1 inhaler, but use it with a spacer. And this is the way how you have to use it. There's only 1 inhaler. You can use it as a maintenance therapy. And whenever you get cough, probably you require, you'll probably use this inhaler only for your symptom relief. And then again, exposures. This child has been smoking and he's not accepting it. His father is a smoker. Probably you'll have to counsel the family that smoking again is one of the very important factor which leads to uncontrolled asthma. It will lead to long-term morbidity and permanent reduction in the lung function. So it is very important that the father should quit smoking, and the boy itself, he should be told that if he smokes, probably whatever effort we are doing, it is going to fail and he is going to get a permanent damaged lung. So he needs to quit smoking and understand why it is important that not to do these things which are injurious to the health, and stick to the therapy which has been prescribed to him. So I think these are all things probably I like to discuss with this child, and probably he should do well. Thank you.
Thank you, Dr. Rawat. Dr. Rawat brought out a very important issue of marked therapy. 1 inhaler for control, 1 inhaler for relief, and we have enough evidence across the globe now to use this definitely in adolescence. And adolescence is a different ball game where we have to involve the adolescent much more than his parents, because he is the decision maker there. With those things in mind and with those key messages that you see, what have the panelists done? The panelists have done an excellent job to say that most often the solutions to difficult asthma is most often simple. And how is it simple? It is by understanding the disease, taking a thorough history, examining the child, and giving your time more than your prescription. With those few words, we would, as a panel, thank the organizers for the opportunity given and the opportunity to learn and share with you. Over to the organizers for the next activity. Thanks once again to the organizers and my esteemed panelists who have successfully taken up the challenge and delivered.
Thank you, sir. Thank you. Thank you, Dr. S. Nagabhushan and the panelists, Dr. Sanjeev, Dr. Ashwath, and Dr. Subrao, for such an excellent session. The chat box is actually full of appreciations for the panel discussion. Now, the next session, for the next session, I invite Dr. M.N. Venkateswaran, past State President 2017 and State Representative of IAP BPS, and Dr. Riaz I, past State Secretary 2017-18 and National EB Member of 2020, to chair the session on acute and post-COVID in children. Acute post-COVID pulmonary issues in children by Dr. Dhanya Dharmabalan. Over to you, moderators.
Good morning, most respected teachers and my dear colleagues. We are having a very important topic, that is the post-COVID issues, especially the pulmonary issues, and that is the need of the hour. To speak on this, we are having Dr. Dhanya Dharmabalan. She is working as the consultant in pediatric infectious diseases in Apollo Hospitals, Navi Mumbai, and also in Dr. Chevalier's Multi-Specialty Hospital, Navi Mumbai. Fourth, she is having lot of achievements. She is a national and international speaker. To name a few, she is the co-lead of Global Antibody Stewardship Committee of the Pulmonary Infectious Disease, National Coordinator of Apollo Antimicrobial Stewardship, COVID-19 Task Force member of the IAP and Apollo Hospitals. She is a national convener of the National Antibiotic Practices, national record of youngest editor of pediatric textbooks, Young Academician Award by Apollo Hospitals, editor of 16 pediatric textbooks, books, and has over 60 publications. It is only a very few we have just mentioned. She also was invited as speaker by various international organizations, even WHO and various forums at the international. So now I request Dr. Dhanya Tharmapalan for this very important topic. Over to you, ma'am, for the presentation. Thank you very much.
Thank you very much for the kind introduction, and thank you for this opportunity and inviting me here. So I'll just start straight with the presentation, and I shall be focusing on the pulmonary issues in the acute and post-COVID management in children. So on the left side is the figure of the SARS coronavirus, and as you can see, the S protein of the receptor binding domain of this virus attaches to the ACE receptor of the respiratory epithelium. And majority of the individuals contain infection right here in phase 1, and either they have no symptoms at all, or they may have very mild symptoms. And the actual symptoms of respiratory infection start when this virus starts migrating to the upper respiratory tract and then to the lower respiratory tract. And then in phase 2, when it reaches the alveolar epithelial cells, it causes local inflammation, which presents as pneumonia to us. And in phase 3, due to rapid replication of the virus, there is cell apoptosis and release of pro-inflammatory proteins, downregulation of the ACE2 expression, vascular leakage leading to pulmonary edema, cytokine storm, and this can result in ARDS or even death. So phase 3 is what presents as severe COVID pneumonia or critical COVID pneumonia. Now, fortunately for us, COVID is mild in majority, and majority is about more than 90 to 95% of our children. And various postulations have been made for why it is mild. And these are, there is predominance of innate immunity in children. They develop a very good immunological memory against defense for respiratory pathogens. And they have more intact vascular endothelium in relation to adults, and they have less expression of the ACE2 receptors in the lower respiratory tracts, which have less affinity to the SARS coronavirus, and thereby they are kindly spared of the severe lung involvement, which is seen in the adults. This is a very familiar image for all IAPNs. This is from the IAP COVID-19 protocol, which was released in April 2021, revised in June. And it has, the COVID-19 in disease has been classified as per the presentation of the child as mild, moderate, and severe. In mild, you have non-specific respiratory infection presentations such as fever, sore throat, cough, etc., but no fast breathing. In moderate, you see tachypnea with presence of hypoxia, but above 90% and without signs of severe disease. And in severe disease, the saturation can drop below 90% with respiratory distress and other signs of involvement of other systems, and also complications such as acute respiratory distress syndrome, shock, multi-organ dysfunction, and acute thrombosis. So the management has been nicely put up in the IAP protocol as per the presentation of the child. So mild disease basically requires only symptomatic management. With those who have comorbidities, that requires to be a close monitoring because of the risk of progression to a severe disease. Moderate disease is usually treated just like we treat community-acquired pneumonia. So for children who are hypoxic, that is saturation is less than 94%, steroids are recommended. Remdesivir may be used, I'll be talking about it later. Antimicrobials are plus minus if you feel that you are unable to differentiate between viral and bacterial pneumonia. And in severe critical disease, you have more set of investigations to look at ventilation status, or requirement of or the D-dimer status, and prone positioning is recommended with restriction of fluids. And here anticoagulant enoxaparin is recommended, and then severe patients are managed in ICU. So the dosages are also put up on this protocol, so you can refer to the dosages. And the antimicrobials which we use usually are those which are used in community-acquired pneumonia. So fortunately for us pediatricians, 90 to 95% of our children belong to this category. And basically, we just need to give them symptomatic support. So I shall talk a little about this management of mild cases. Preferably use paracetamol to control fever, avoid mefenamic acid or ibugesic. It has its side effects, as well as if they suppress fever for a very long time. Basically, paracetamol is the safest antipyretic in children for any infection. Plenty of liquids, normal healthy diet. There is no diet restrictions. Use saline nose drops in children for nose block. Avoid steam inhalation because we have seen accidental burns happening, especially in young children because of aggressive steam given by parents. Explain the red flag signs and what to be monitored. Pulse oximeter monitoring can be tricky in young children because the meter does not snugly fit into the little fingers, and there can be situations where the parents rush to the emergency service or give you a panic call in the middle of the night because the saturation is seen as 80% while the child is absolutely normal. This is because of the erroneous reading of the pulse oximeter machine, which does not fit well into the little finger. And no antibiotics in mild illness, please. And this is a very different from influenza, where influenza, you can have secondary bacterial pneumonia in 15 to 20% of children. But COVID, fortunately, is not known to predispose like influenza to secondary bacterial infections. For moderate to critical illness, antibiotics may be given, but as I said, they are more which are used in community-acquired pneumonia, and because it becomes difficult to sometimes differentiate bacterial co-infection. And I repeat, there is no role of azithromycin or ivermectin as a COVID-19 specific therapy. And in June 2021 was released a systematic review and meta-analysis of randomized clinical trials, which included important trials, including recovery trial, which concluded that azithromycin has had no benefits whatsoever for COVID-19 infection, and actually should be discontinued because of increased risk of bacterial resistance. So it is not at all recommended in mild cases. It's an IV formulation for hospitalized patients, and its role is actually controversial, and especially in critical patients. Though in IAP guidelines, you will find a mention of remdesivir, but it actually offers no benefit rather on those who are critically ill with high flow oxygen or invasive ventilator or on ECMO. But there are few trials which have shown some benefit in moderate cases requiring low flow oxygen. So the use is controversial, though there are certain guidelines which recommend in critical patients because you don't have any other antiviral to offer. But please remember, the benefit could be more for a low flow oxygen. So the hype around remdesivir has come down with time. And if given, it should be given within 10 days. The dosage, you can refer to the IAP protocol, but please remember that emergency authorization has been given for less than 12 years, and it is FDA approved mainly for 12 years and above. And it is administered via infusion. The duration of treatment is 5 to 10 days. And there are adverse effects with remdesivir. So you cannot use it when the liver enzymes go up more than 10 times the upper normal limit. And there could be QT prolongation, and we should use it with caution in those who have renal insufficiency. Steroids is the life-saving drug in COVID-19. There is no doubt about that. And the indication is for those who require oxygen or invasive ventilation. So judicious use of steroids is also extremely important. Please use it only for hypoxic patients. You have seen the nasty outbreak of mucormycosis in our country because of injudicious use of steroids. Secondly, it may also be used in COVID-19 for continuation for underlying conditions which require chronic steroid treatment, like say nephrotic syndrome, etc., and or in conditions where there is additional diagnosis for which steroid therapy is appropriate, for example, MISC. And in adult physicians usually prefer dexamethasone, but actually there is no known superiority between dexa and methylprednisolone in children. Please also watch for the sugars and blood pressure when you're using steroid, and especially in diabetic patients, you must keep a close watch on the sugars, and preferably avoid in first 3 to 5 days, because the optimal timing is actually after that, after the viral replication. But if you have to use it, you might use it under cover of antibiotics and antivirals, but preferably the ideal timing is beyond 5 days, and it is given for about 7 days and should be tapered for up 14 days. Now, the dosages are again mentioned also in the IAP protocol. Please note that hydrocortisone is what is recommended for preterms who have age less than 40 weeks of corrected gestational age. I have picked up this first case where we had to use remdesivir. This was during the first wave on 2nd August 2020. We had a 14-year-old who was a known case of type 1 DM with fever and who came with COVID positive report and presented as clinical pneumonia. And this was his X-ray, though there was haziness and obliteration of the angle. It was due to the breast shadow. This child was obese with little gynecomastia, and this child had near normal counts and not very marked inflammatory this reports, and it was managed then with a combination of antibiotics, ceftriaxone, azithromycin, remdesivir, dexa, and enoxaparin. This was our first child who had a comorbid condition who presented with hypoxia, and where we for the first time used remdesivir. And a year later, I picked up another case. This is a year later, 31st May 2021, during the second wave, where a child who does not have any underlying comorbidity, a 12-year child, presented with low saturation and respiratory distress, pneumonia, was admitted in ICU, and we treated with the same combination minus the azithromycin and antibiotics, but the same for COVID-19 specific, we gave the same things like remdesivir, IV dexamethasone, and IV enoxaparin. And this was the X-ray and the CT image where you can see the scattered ground glass appearance, the shadows and consolidation. But what I want to say with these two cases is actually the management protocol has not changed very significantly from last year to this year. We are almost, it's just that the maybe we have had a better understanding of the limitations of remdesivir, and the role of steroids has become more clear, that it is what is life-saving for the hypoxic COVID patients. And let me talk a bit more about the latest updates on other medicines like tocilizumab, that's IL-6 inhibitor. So what the role is that it can be added to standard care in those who have worsening levels of respiratory support despite the steroids. And this is the pediatric dosage as a single dose. And it is also contraindicated when there is liver dysfunction lower than 500, or there is thrombocytopenia less than 50,000. Now, tocilizumab can cause serious infection. So you should be very careful that there is no active bacterial infections, no active tuberculosis. And at least the adult intensivists at our hospital have seen many bad serious bacterial co-infections occurring with tocilizumab. It has also caused GI perforation among adults. So these are the serious adverse effects, and CRP and IL-6 is not reliable post-dose. And a bit about baricitinib. It is a Janus kinase JAK inhibitor. Now it is available as oral formulation. So what is its role in pediatrics? Its role is very limited. It has emergency use authorization, but FDA has not approved it because we do not know its safety profile in children. It has been approved for children about 2 years of age and requiring supplemental oxygen, invasive mechanical ventilation, or ECMO. But presently, all the Western countries' guidelines, they have reserved it for children in situations where corticosteroids are contraindicated. So please remember that corticosteroids continue and is the first line agent to control the inflammation. And baricitinib, when it was approved first, it was in combination with remdesivir. Very recently, it has been approved as without combination of remdesivir by the emergency use authorization. And you cannot use it if you have used tocilizumab. So this is the dose that has been given. Dose adjustments are required for renal insufficiency, hepatic failure, similar to tocilizumab. And this also can cause serious infections, and you need to monitor CBC, LFT, and kidney function tests very closely. But recently, that was just 12 days back, on September 1, 2021, came this publication in Lancet Respiratory Medicine about baricitinib. And this is in adult population. And what they have suggested is that baricitinib has synergistic effects with other standard of care treatment modalities, including remdesivir and dexamethasone. So since pediatric data many times is extrapolated from the adult data, so this is still a dynamic field, COVID-19 management, and we'll need to keep a closer watch about what is the outcome in adults and look at more studies about baricitinib safety in children before we can have any clear ideas about how to use this. Now, regarding monoclonal antibody, it's much talked about for COVID. This is casirivimab. Indevimab is the only monoclonal antibody which has been approved for children about 12 years. What it does is it directly binds the virus and neutralizes the infected host cell. So the indication for this is, please remember, it's for non-hospitalized SARS coronavirus infected child aged 12 years and above, and weighing 40 kg, and who are at high risk for progression to severe COVID-19. And when we talk about severe, severe risk, these are the usual conditions we think of: is sickle cell anemia, diabetes, immune compromised conditions, obesity, chronic lung diseases. As we saw in the earlier panel, it is not asthma, but other conditions such as COPD or pulmonary hypertension, cystic fibrosis, etc., chronic cardiac conditions, and CNS conditions. So the dose is as a single dose, and preferably should be given within 72 hours of positive test. It cannot be given after 10 days of symptoms. But it is to check COVID antibody because its benefit is more likely in those who are seronegative. And it does have side effects. It does have hypersensitivity and infusion-related reactions, and thereby children need to be monitored closely during infusion and also at least up to 1 hour post completion of infusion. And these are the vials, but please look at the MRP. It's very costly. It's around 1,20,000 for 2 vials. So it is a very expensive medicine. So to be judiciously used only in certain situations where you are very certain that the child about 12 years old may progress into very severe COVID-19. Now, this I have colleague, intensivist in Wadia Children's Hospital, Dr. Rekha Solomon, and she has kindly shared me this case because we have not seen any child who required ventilation for COVID pneumonia. Fortunately, we did not have any such serious COVID pneumonia. So, but she has seen few in her hospital, and this is one of them, that a 13-year-old who had cough since 2 days, breathlessness since 1 day, and was COVID positive. This child required prone invasive ventilation for 2 days, followed by non-invasive ventilation for 5 days. She was also treated with remdesivir and methylprednisolone, and she was discharged well. Now, two more cases I would like to talk about. This is an interesting case. A 5-year-old male child who came to us on 20th May was referred to the hematologist for hospital because she was known case of T-cell ALL post-induction and had received DEXA just 1 week prior, and was referred on 20th May for fever and cough since 2 days, was COVID-19 positive on 12th May, so about 8 days back. And that child had pustules over the finger, and the referring hospital had given flucloxacillin. But in our hospital, this child was tachycardia was present and required 5-liter oxygen by mask, and there was a reduced air entry on the right side. The inflammatory markers were not very high, CRP 29, D-dimer 0.52, and COVID antibodies were negative. And this child was started like what we give for COVID pneumonia, except that ticoplanin was added for this immune-compromised child because of the pustules still present on the fingers, and was also given fluconazole prophylaxis. So what happened is this child was given steroids because of the hypoxia, the dose 1 milligram per kg. This was the image, X-ray. You can see the CT scattered patchy consolidation as well as ground glass appearances. And there was a, though the 2-deco was normal, the team suspected early MISC, and this child was given IVIG. Now, what I came to the scene because the Aspergillus galactomannan came positive, and also positive beta-D-glucan was positive. Now, steroid, we have to be cautious when you have a suspicion of a severe fungal sepsis at the same time. This child was immune compromised. Fortunately, this child was not very hypoxic, and the hypoxia had settled down, and we could stop steroids early. That was a time when amphotericin was in acute shortage because of mucormycosis outbreak and was just not available. And we had to decide whether we can give voriconazole, but as you know, voriconazole is another risk factor for mucormycosis. And we started this child on oral posaconazole because that seemed to be the only option we thought was for this fungus, Aspergillus. Stopped ticoplanin when the cultures came negative. Fortunately, through special requests, amphotericin got available after a few days, and this child was referred back to the hospital which had referred to us, and this child is presently doing well with minimal residual disease. Now, so there have been concerns raised about distinguishing severe COVID-19 pneumonia from early MIC, as we saw in the earlier case. So please remember that MIC usually occurs in healthy children, while COVID-19 pneumonia occurs mostly in those with comorbid conditions. And you have more of the cutaneous, mucocutaneous markers such as conjunctivitis and rash in MIC as compared to COVID-19. Also, the MIC can present with more of inflammatory markers, and of course, the cardiac involvement is there in MIC than in COVID-19. This paper mentions that COVID-19 has had higher lactate dehydrogenase levels, LDH levels, but actually it is more a clinical diagnosis whether it is MIC, and the issue comes about whether to give IVIG or not, because that's where the differentiating becomes important of a severe COVID-19 pneumonia from MIC. Those steroids remain common for both of them. Now, this is the last case I would like to present. This is a 2-year-old child who presented on 30th June this year with fever, cough, and since 1 week with rapid breathing since 2 days. Now, this child was referred to me a month earlier for blood in stools, not responding to antibiotics. This child had undergone colonoscopy, which suggested multiple ulcers, query TB, calprotectin was high. TB workup was negative, and the gastroenterologist wanted to wait for TB culture because of the young age of the child presenting with Crohn's. And this child also was born of second-degree consanguineous marriage with elder sibling having died at 10 years due to neuroblastoma. And this child, when came in emergency, had severe oral thrush, respiratory distress, bilateral crepitations. COVID TrueNAT was negative, and thereby started on IV ceftriaxone and fluconazole. And this was his X-ray on presentation. And you can see on the CT, we did the CT because of the query of tuberculosis in this child because of the ulcerative colitis. And this, the radiologist called up and said, this is COVID unless proven otherwise, because of the peripheral ground glass opacities that you see. So this became a very big moral dilemma for us, where to care for this patient because his COVID test was negative. Now, the problem was this child was looking immune compromised. We didn't want to unnecessarily expose to a COVID-19 ICU because this child is immune compromised, and it would be ethically wrong if he did not have COVID. At the same time, what if he was COVID-19? Based on the CT report, he would be dangerous for other children who are COVID negative in normal PICU. Then finally, we shifted to an isolated ICU. We repeated swab, another technique. Earlier it was TrueNAT. We repeated PCR, it was negative. But still, because of the condition of the child, we treated like COVID. We gave steroids also, and also since the other differential in an immune compromise could be pneumocystis carinii, we also started on oral cotrimoxazole. Unfortunately, we could not do BAL nor convince the relatives for BAL. And surprisingly, his blood culture grew Streptococcus pneumonia. Again, whether it was a co-infection, because strep pneumonia doesn't present as ground glass opacities in the CT. Now, this child was worked up for immune deficiency, and it turned out to be ZAP70 mutation and T plus B plus NK plus KID. And this child has been consulted for HSCT and put on itraconazole and cotrimoxazole prophylaxis. So this is a dilemma again about whether it is COVID, whether it is COVID, non-COVID. So I thought I'll just share this interesting case. And we have not actually followed up all our patients who have had COVID pneumonia. And we do not generally get a CT scan done unless really required because of the problems of exposure to radiation. So, but I picked up this paper from the literature from China, who has done this study, who have looked at pulmonary sequelae of pediatric patients discharged after COVID-19, where they found that 9% had some sequelae of pulmonary fibrosis at 30 days of 21 days post-discharge, but others had shown complete resolution. They also found that sometimes you can have fibrosis occurring at a different location suggesting some progression even after discharge, but most of them had recovered. So my take-home messages are: pediatric COVID-19 reassuringly is mild in over 90 to 95% children, only requiring symptomatic care. Please do not give antibiotics in mild cases. We are having enough of antimicrobial resistance. Careful monitoring needed in high-risk children. Monoclonal antibody is an option to consider in high risk and above 12 years, if not requiring oxygen. Remdesivir is the only antiviral available presently for COVID-19. Its role is controversial, but certainly no role in mild cases. Most benefit in moderate cases requiring low flow oxygen. Corticosteroids is the first line in children for those requiring oxygen. It is life-saving. Tocilizumab role is in worsening situations despite steroids. Baricitinib role in pediatrics is not clear yet due to unknown safety profile, presently reserved in those who have contraindications to steroids. And majority of the children have complete resolution of fibrosis at 1 month of post-severe COVID pneumonia. But in those who are suspected to have sequelae clinically, maybe pulmonary function tests can be used for monitoring, especially in older children. Thank you very much.
Thank you. Thank you, Dr. Dhanya. It was a very lucid talk, as well as reassuring too, to know that there are less number of cases with fibrosis post-COVID pneumonia. There are a few questions in the chat box. Before that, one question like, is it necessary to start all children on steroids who needs oxygen? Because sometimes we see that COVID is positive, still we believe it is not a pneumonia or a bronchiolitis due to COVID itself. We think it's a secondary infection only. So is it necessary to start all children on steroids?
That's an interesting question. Actually, if the child is admitted per se as COVID infection and COVID pneumonia, then it becomes kind of imperative for us to give steroids for hypoxic children. But you may, I mean, it's not kind of you immediately start, you can even observe after, if you feel suspicion of a bacterial co-infection, starting steroids and, antibiotics and see a couple of hours later. It is not something that you start right at first hour of admission. So you can do that. I mean, look at the lab reports, and if you feel the CRP is just 5, those CRP rises in COVID pneumonia also. But if you feel the child is less of a bacterial co-infection, then if it is COVID pneumonia, it's better to start.
Thank you. And another question connected with the same. What is the threshold for giving anticoagulants, especially enoxaparin? Because sometimes we see children are having associated thrombocytopenia also. So can we have some threshold of starting enoxaparin in such children?
So anticoagulants are usually advised in the severe category. It's not for moderate cases. And in the severe category also, you can assess the risk for, I mean, if it is severe COVID, yes. Secondly, if there are no contraindications of bleeding, etc., you can consider that. You can consider any kind of underlying health comorbidity situations like nephrotic syndromes, or I mean, if there's a family history of thrombosis, and all those factors you can consider. But generally, it is given for all children who have had a severe COVID-19 course. And yeah, but now it's whether you give prophylactic dose, whether you give therapeutic dose. There are different schools of thought. So at least prophylaxis can be offered for those.
Okay. Thank you. So that is clear. And the question is, do we need to follow up children with COVID for development of MASC, like some mild cases and all, or clinically at least? Like
every child who is COVID-19 positive, who comes to your attention, whether through physical consultation or through teleconsultation, I make it a point to prime the parents about MIC, saying that if after few weeks there is high fever with red eyes, red lips, rash on the body, you need to seek medical attention. So the parents are primed right when they are infected, and also assure them that it is rare. It occurs only in few children, nothing to be anxious of, but you should know about it. So you don't need to clinically follow up. I mean, parents, when you tell this to parents, they themselves are on a watch for these symptoms. So that is how I go about.
That is give an awareness to the parents that there is such a condition, and look for the signs and symptoms.
Yeah.
And the question is, because in adults, sometimes we say that RT-PCR is negative and CT just gives more information. So are there any reports in children like that, whether we should evaluate children with a CT scan?
So CT scan in general is completely discouraged in pediatric practice because of the high radiation exposure that children have. Like even in adults, they have now become more cautious about ordering CT scan. Earlier, it used to be in a drop of hat, but now they have also become a little cautious. But in children, especially, we do not need this. But at the same time, if clinically the child is deteriorating and you are suspecting COVID-19 despite the negative report, those are the situations, or you are suspecting some complication, or there is a severe comorbidity and CT can give you additional information. Those are the situations where you go for CT, not in all cases.
There are a few more questions also in the chat, but we are running a little behind the schedule. So we'll close with one more last question. It is any role of these vitamins like vitamin D, zinc, vitamin C, like that in the progression of the disease? Can we make it mind?
Okay, so multivitamins I generally do not aggressively promote, but if a child is on multivitamin or the parents ask for multivitamin, I do not object to that. I'm not very strict about if it makes parents happy. I prescribe multivitamins. But if you ask scientific role, no, there have been papers about vitamin D, but vitamin D in general, there's no, I mean, it has been used for almost all infections as an immunomodulatory agent. But, and in the lockdowns, children have been confined to homes, so they are a bit vitamin D deficiency, but deficient, but it's not very clear whether you need to supplement vitamin D for every COVID patients. I would say that it may or may not have a role. You can, if you feel that could be, you can give the dose of vitamin D, you can check vitamin D levels. That is all I can say for this.
Thank you, Dr. Danya. So the discussion was also very active. If time allows, please answer the rest of the questions in the chat box. Over to the organizer. Thank you.
Thank you very much.
Thank you, Dr. Danya, for a wonderful presentation and being with us for the wonderful session. And thank you, Dr. M. Venkateswaran and Dr. Riaz for chairing the session. Now there is a slight alteration in the program. Now we are moving straight away to the oration. We cannot wait the oration, prolonging the oration. And thanks, Dr. Subramania, for allowing us to do the oration before his talk. Now, this is the IAP respiratory chapter oration installed by the respiratory chapter in the name of our beloved Professor T.U. Sukumaran. In the name of Dr. T.U. Sukumaran, it is I invite Dr. Krishna Mohan, the chairperson, IAP Respiratory Chapter, and Dr. Gigi Joseph, Secretary, IAP Respiratory Chapter, to take over the session and conduct the oration, the Dr. T.U. Sukumaran oration. Over to Dr. Krishna Mohan.
Am I audible, sir?
Yeah, yes, come on.
Screen is visible?
Yes, visible.
Okay. Thank you, the organizing committee. So, respected State President Dr. T.P. Jayaraman, sir, respected past national presidents of IAP, President-elect Dr. Ramesh Kumar, all other state OBs, national OBs, senior pediatricians, and all our dear members. So, as Ashok Kumar sir has said, we have instituted, as per the unanimous decision of IAP Respiratory Chapter and IAP Kerala, we have instituted this T.U. Sukumaran oration from this year onwards. So let us start the proceedings. So Professor T.U. Sukumaran, sir, an internationally renowned pediatrician and pediatric pulmonologist, was born in a remote village in Ernakulam district on February 18, 1952. Hailing from a simple and humble background, he reached uncomparable heights through his hard work and perseverance. He acquired his undergraduate and postgraduate degrees from prestigious government institutes in Kerala, and he also took PhD on asthma and environment and MPhil in behavioral sciences from Mahatma Gandhi University, Kottayam. So Dr. T.U. Sukumaran is one of the senior most pediatricians in Kerala with more than 4 decades of teaching experience in various medical colleges in Kerala in various positions. He also served as an examiner for many years at various medical colleges across the country. He retired from government service as professor of pediatrics from Government Medical College, Kottayam, and he further continued as a professor and HOD of pediatrics department at Pushpagiri Medical College till recently. He worked as the principal investigator for many international and national study groups and presented many advantageous clinical studies, including the famous ISAC study and the GAN. He published 3 books and contributed many chapters to numerous textbooks. He edited more than 10 books, including the IAP textbook of pediatrics and the recently published textbook of pediatric allergy and applied immunology. Dr. Sukumaran designated many administrative positions and was a superintendent of ICS Kottayam and PIMS Tiruvalla. He was instrumental in starting the state respiratory chapter in Kerala, which was inaugurated way back in 1995. He organized 3 national Respicons in Kerala, twice in Kottayam and once in Trivandrum. He became the national chairperson of NRC in 2000 and national chairperson of the ECAG in 2005. Presently, he is the national chairperson of Allergy and Applied Immunology chapter. And in Kerala, he was a state president of IAP Kerala in the year 2000 and state NNF president in 2005. From a grassroots worker of IAP, Dr. T.U. Sukumaran rose to the highest position in Central IAP with his relentless and sincere hard work. He was elected as the national president of IAP in the year 2011. He was the master brain behind the many well-appreciated academic programs like ATM, ARCTM, IAP ADEX, sleep modules, etc. And about the awards that he received, considering his outstanding performance, Government of Kerala awarded him with the Best Doctor Award in the year 2002. He also received numerous other awards like Best Doctor Award from the World Malayali Council, from the Indian Junior Chamber, and Outstanding Leadership Award from the American Biographic Society as well as the Lions Club International. He was awarded numerous orations from different parts of the country, including Dr. M.R. Shena Memorial Oration, P. Alexander Memorial Oration, Satyadas Memorial Oration, and a lot more. And as you can see, he was not only into the academic and professional activities, he was a great good family man also. He is blessed with 3 children, and sir's wife is the professor of medicine at Kottayam Medical College. And with his own life, he portrayed how well you can blend family, profession, and academics together. So in honor of this great, multifaceted, dynamic personality, an oration in the name of Professor T.U. Sukumaran is instituted at state level in the annual conference of IAP State Respiratory Chapter. This oration will be delivered every year by an eminent scientist at the annual state conference of Respiratory Chapter. So with these few words, I invite Dr. Jijo Joseph John, the State Secretary of IAP Respiratory Chapter, to invite the orator and introduce the orator. Over to you, Dr. Jijo.
Thank you, KM. It is a great privilege for both Krishna Mohan and me to be chairing the first oration for Dr. Professor T.U. Sukumaran. And to deliver us this oration, we have with us the Dr. Meenu Singh. Ma'am is a professor of pediatrics and she is from PGI Chandigarh. She has held many posts and she has been instituted many awards, including the International Women's Day Award, V. Raju Award for Senior Scientists. She has been a well-known faculty, well-known face in the field of research. She has been part of multiple projects by ICMR, WHO, and international trials. She has been well-versed in administration and innovation. She has been the first person to have the first pediatric flexible bronchoscopy service in the public sector as early as 1995 in North India. She has had multiple national and international collaborations. She currently heads even the telemedicine department of PGI Chandigarh. She is also has multiple talents, including organizing yoga camps, and also she's an avid painter. She has her own book of The Crackle of Leaves, which talks about her paintings. She has been awarded multiple awards, and she's also started a new center in the Center for Advanced Research in Evidence-Based Child Health at Advanced Pediatric Center in PGI Chandigarh. She's been known even in the field of Cochrane for publishing various reviews. We have a very excellent orator who's going to talk to us regarding the past, the present, and the future of tuberculosis. Over to you, Meenu ma'am.
Thank you, Jijo, and I am indeed honored to be delivering this prestigious oration, which has been set up in the name of Professor T.U. Sukumaran, who's been our worthy colleague as well as our guide for various projects in respiratory medicine that we have been conducting. And it gives me a lot of pleasure, because while he was the president of IAP and he led so many projects in IAP respiratory chapter, so many conferences, we interacted with him. He was always very humble and brought out the best in others, who were there. So I would like to deliver this oration, which is on tuberculosis, evolution of tuberculosis, its past, present, and future. And I would like to share my screen. Can you see my screen?
Yes, ma'am. It's visible.
Okay. So my talk will be centered around TB, and we know that TB is a major problem with us in our country. And the sequence will be that the past is never dead, because we can always keep learning from the past. The present is here, and we must continue to live in the living present, because that is what is going to mold the future. And the future here, is now clouded by COVID, which has happened to all of us in the country. And it has led to disruption of medical sciences as well as science as such. And we have had so many alterations in the path, which otherwise seem to be a bit smooth to us. Now, as far as the past is concerned, I don't want to start with the Egyptian mummies for tuberculosis. We know that TB was discovered in Egyptians' mummies also once the genetic diagnosis for TB came up, and somewhere even in mummies which were 1500 years before Christ, this particular DNA was discovered, and people even tried to explain and correlate the disease which were present in the spine or in the lungs of these individuals. Actually, what is actually citable and which is indeed a very important landmark in the history of TB, and that is discovery of this bacillus by Robert Koch on March 24th, 1882. Now, this is the day which is celebrated as the World TB Day. And at the Berlin Physiological Society conference, the discovery of this bacteria proved that TB was infectious disease and not a hereditary disease. And I'll show you towards the end of my presentation what people think of this disease even now. So we know that with the discovery of TB and later on with the estimation of burden of this disease in our country and the introduction of various TB control programs, which was still recently was the revised National Tuberculosis Program, because the earlier tuberculosis program was the National Tuberculosis Program, and which got then converted into National TB Elimination Program. And I think one cannot start about this modern era of tuberculosis in our country without mentioning pioneering work of Dr. Swaminathan and again helped by Dr. Sachdeva, who at the Center TB Division and the Department of Health Research initiated a lot of research into TB and brought in several new technologies which were available to World Health Organization. And even now, the World Health Organization continues to guide us in our various strategies which are being adopted for control of tuberculosis in our country. We know that the burden of TB in children is enormous, and South Asian region actually reports a large number of patients of tuberculosis. So after the National Strategic Plan, which was introduced in 2017-2025, and this National Strategic Plan came by the Government of India about how the control of TB could be achieved. And in this strategic plan, the emphasis was going to be on reaching patients seeking care from private providers, because we felt that the government sector alone could not handle all the cases which are there. And it is the private sector which also needs to be harnessed for treatment of patients of tuberculosis. And that happened even for childhood tuberculosis. So this National Strategic Plan built on the work which was already done with the new NTEP, which is National Tuberculosis Elimination Program Operating Guidelines. And this period actually outlined a key governance interventions and structures that needed to be in place, because TB was to be eliminated by 2025 in India, as per the announcement by the Prime Minister of India, although the WHO had kept this target at 2030, but I guess we did think that we would be able to do this. And now let us see how we have been, we are likely to fear. So the story till 2019 was that we had a great start to NTP. We had Prime Minister's declaration. We had, for children, we had this TB group which was set up, and they had new pediatric TB guidelines, which came out in 2019. And only in the morning, actually, I discussed with Dr. Varinder Singh and Dr. Sangeeta Sharma, who were involved in drafting these guidelines, and of course, Professor Kabra, about the pediatric aspects of guidelines, that the new edition has been done in 2021, July, and which is more related to treatment of latent tuberculosis. And as far as this program is concerned, this is now aiming at elimination of tuberculosis. But let us see how we do that. So this is the childhood TB guidelines. I will just be giving you a little brief about these guidelines, because this is the present actually. And this is something which is going to be followed by the residents, by the doctors in the government sector, the private practitioners for treatment of TB. We know that in India, we have about 3.5 lakh children who get treatment every year. And about 31% of the global burden is there in India. And 6% of the cases which are reported to NTP are amongst children. And there is a huge detection gap, overall of about 56% and about 74% in children who are less than 5 years of age. So it basically, and this detection gap, as I'll show you later, is increasing. Pulmonary TB is the most common, but extrapulmonary TB is also there in a large proportion compared to the adults. So now these were the free services to TB patients, which have been introduced to the private sector as well, which are there in the government sector. And for diagnosis, we had microscopy, which was anyway there all over. There is nucleic acid amplification test, the NAT, the line probe assay, which is there, and the culture and drug sensitivity testing. And this is actually the revised diagnostic algorithm, which all residents and doctors are familiar. It is available from the site of Central TB Division. It's in a small font, so I'm not going to talk about it, but this is a main strategic approach which is there now for treatment of tuberculosis in children for detection. Gene Expert has become a very, very important landmark in which can help us detect TB bacilli, and even if they're present at a low concentration. And it also gives us idea about the rifampicin resistance, if that is present. And if it is present, we take these patients to be multi-drug resistant, because we feel that if an organism is resistant to rifampicin, would be resistant to INH as well. Now, this particular Gene Expert actually has also now what the government has added is the TrueNat, which is an Indian product from Goa. And the only problem is that that particular equipment, although it can be carried as a suitcase to the point of care where this diagnostic is required, it also needs separation of DNA. And I was told that there is a separate kit for that in which one can separate the DNA, and then it is unlikely to prolong the labor, which we thought is a likelihood in when we are trying to diagnose tuberculosis with the TrueNat. But another machine which is available is UltraNat, which is something which can detect TB bacilli at a much lower concentration. But the problem with this is that it doesn't give us about rifampicin resistance, and sometimes because it is oversensitive, it may also pick up. Can people mute their mics because that is a big disturbance. So the purchase of these services in the private sector can be done for microscopy, for CBNAT, and for other lab techniques. And TB notification is another thing, which a system which has been set up, and we know that TB notification is extremely important when we are trying to pick up these patients and then treat them. And we are now collecting information from these patients and parents about their bank accounts, their Aadhaar seeding, and because direct benefit transfer of money is also involved in the new program which has been introduced by the Government of India. So the free services to TB patients in private sector would be linkages to access from public health facilities. Program provides drugs at private practitioners, in their clinics. Program provides drugs at chemists and empanel private chemists for this treatment. And some incentive and honorarium has also been given to these patients. Another very important landmark has been introduction of NICSHARE. And NICSHARE is an integrated ICT system for TB patient management. And this is something which has been put to use, and we all are entering patients into the NICSHARE portal. It's a real-time case-based web portal surveillance tool. It's a unified interface for public and private sector healthcare providers. The web page is given here, and many of the residents would have seen that because the patients are getting entered into this particular portal. There is an Android mobile app also which is available, so you can enter patients even on your mobile phones. And the demonstration site is for the beta NICSHARE is also available. Now, the modalities of notification are that you can report via a NICSHARE Sampark, this is the phone number on which you can dial, and there will be a call center agent who can enter the patient. Or we can report into NICSHARE web portal with the help of a mobile application, and or we do it on a computer. And these patients would then be entered into the program, and one can follow them up, and one can follow up their treatment, how the treatment is going on in these patients. And all these copies are also given in the hard form, that means in the paper form, to the district tuberculosis officer. And, there have been, this used to be discussed a lot, that people are likely to be penalized if they don't report cases into the NICSHARE portal. But this certainly is extremely important thing to do once we start a patient on treatment for pulmonary tuberculosis. So what are the incentives which are given to patients for social protection? So there is a NICSHARE Poshan Yojana, which is providing nutritional support through direct bank transfer of 500 Indian rupees to these patients. And for all patients on TB treatment, throughout the duration of TB treatment, it has to be done. And the patient needs to be registered on a NICSHARE portal. And if the patient belongs to a tribal community, then it is 750 rupees per patient, which can be transferred. So this is actually to cover the cost of travel, the cost of treatment, the cost of diagnosis, lost wages and nutrition. And this is all because it is all out of pocket expenditure for the patients, so which becomes quite an economic burden to these patients. So the incentives to the providers are also there, and for private providers, incentive is 500 rupees at notification and 500 on reporting treatment outcomes. And for an informant incentive is about 500 rupees again to informant for notification of patients. And incentive for treatment support for new cases is 1,000 rupees at completion of treatment, and drug-resistant cases, it is 2,000 rupees at completion of intensive phase, and 3,000 for completion of the treatment. And now what is happening to these transfers and these financial incentives is something where, because a lot of money has been diverted after COVID has happened. So we don't really know how the program has been progressing. But in any case, collaboration with child health programs to reduce morbidity and mortality associated with TB in adolescent population through prevention, early detection, and prompt management of TB through the Rashtriya Kishore Suraksha Karyakram and Bal Suraksha Karyakram is something which has been carried on. Now, we were going great guns and we were feeling that territories are becoming free of TB. And we had this report somewhere in 2018-19 that Union Territory of Lakshadweep and Budgam district of Jammu and Kashmir have been declared free of TB. DU had managed to bring down the incidence of disease by 60%. Lahore Spiti, which is a very remote region of Himachal Pradesh, and Kolhapur district of Maharashtra, in the ward of Mumbai, and the West Tripura also had brought down TB by, a large percentage, by about 40%. Now, so that is what was happening. But then COVID happened. Somewhere in the end of 2019, we started having cases of COVID. And we are continuing to have it, and I can see that Kerala is still reeling under the second wave, and we have a large number of patients which are coming, and a whole lot of resources have been diverted towards the diagnosis and treatment of COVID, and which has really impacted the diagnosis and treatment of COVID patients, of the TB patients, because it really affected the TB control program. So this is anyway the estimate of patients which have been there, and the maximum is in Southeast Asian region. And COVID brought down TB detection by 25% in India in 2020. This was the analysis of the Health Ministry. And one can see that in 2019, there were 24 lakh patients which were reported. And then there was about a 25% decrease, and about 18.2 lakh patients who were reported. So it is not that the TB disappeared. There were a lot of people who said that once the patient will wear mask and they will have social distancing, there will be less TB in adults and less TB in children. But it actually has not happened. It has basically led to disruption of the program, and a lot of patients who were already on treatment, they could not complete their treatment because there were lockdowns and they were not able to travel. There were several other restrictions which were there. And so there's possibly an increase in the number of patients who have been there. Now, this is what happened to the routine BCG immunization in India, in the National Health Mission Health Management Information System, shows that the January to June 2020 period, you can see this red marks are 2020. And in March to June, you can see that there was a decline in the number of BCG immunizations also in comparison to 2019. So and this particular thing was very significant in April 2020, because this was a period when a large number of patients got affected by COVID infection. So this again is the monthly TB cases in lakhs in 2019 and 2020. And this blue line is 2019 as it was progressing, but you saw a great fall in TB notification in the month of April, which improved a little bit, but continued to be much lower than what it was in 2019. And this is the data from Nikshay, which is the TB notification system. As I told you earlier, that in month of April to August 2020, again, there was a great decline in TB notifications in our country because of failure of the system, which was occurred because of overpowering COVID epidemic, which happened. Now, in order to address this dual morbidity of tuberculosis and COVID, and it also became important that patients of tuberculosis, if they got COVID, they had a very poor outcome. So the following activities were supposed to be carried out, and one is that there is bi-directional TB COVID screening, which should be done. And then TB screening for influenza-like illnesses is also been projected. Then TB screening for severe acute respiratory illness cases also has been suggested by the program now. So the guidance note on bidirectional TB COVID screening and screening of TB amongst influenza-like illness and SARI cases was given because both are infectious diseases. They present with similar symptoms of cough, fever, difficulty of breathing, although TB has a longer incubation period. The prevalence of TB amongst COVID-19 patients has been found to be about 5% in different studies. And studies have shown that the history of active or latent tuberculosis is an important risk factor for SARS-CoV-2 infection. Tuberculosis is associated with 2.1-fold increased risk of severe disease. And in addition, TB patients also tend to have comorbidities. For example, malnutrition, diabetes, smoking, HIV, all this happens in TB patients, of course, in adults. But the disease in children is actually a reflection of disease in adults, so one can extrapolate that data. Now, COVID screening for diagnosed TB patients has been recommended. If you diagnose a patient of TB, you will be testing these patients for COVID-19. If they're COVID-19 patients, their management as per the government protocol. And if they're COVID negative, you continue the treatment for tuberculosis. Then for COVID patients, you again do screening for TB. Now, this is important because the previous one, in any case, any patient who comes to hospital these days, they get COVID test done on them. So, but these are the COVID patients. Their screening for TB has been recommended. And upfront, you are supposed to do a chest X-ray, which anyway you do for COVID. And upfront CBNAT also has to be done. Now, CBNAT availability has become a problem because it is also being used for COVID these days, and it is also being used for tuberculosis. And we are finding that the resources are getting divided. And but again, if we diagnose a patient with TB, then linkage with NTP program has to be done, and the patient has to be treated. And of course, COVID also has to be treated. But if he's not diagnosed, then follow-up and management as per the ministry guidelines. Now, TB screening for ILI cases is also somewhat similar, in which if COVID test as per the ministry guidelines and then treat them like COVID, and also do screening for TB. And again, if they're not diagnosed with TB, then follow up. If they're diagnosed, then you treat them. Similarly, for SARI cases, you screen them for TB, that is chest X-ray, and upfront CBNAT. I don't know how many people are doing CBNAT in these patients who are coming with SARI, because we usually think that, these patients have acute illness, so why rule out TB in them? But the government guidelines at the moment are that we should be ruling out tuberculosis even in these patients. So the pandemic impact is that TB case notifications have dropped to 41% from January to April in Maharashtra. And the recent surge of COVID-19 cases during the second wave has actually impacted the TB control program. And several thousands of cases of TB have been, notified and seen in this particular time. So what are the efforts to regain this lost ground? So the government plans to start population level screening again, especially amongst vulnerable categories, such as people living with HIV or other immune compromised states. The TB services are now being decentralized through the Ayushman Bharat program. The government communication on TB will also emphasize the importance of COVID appropriate behavior. Additionally, COVID negative patients are also being tested for TB. Notification by private sector will be incentivized, as was told earlier, and there would be both tracking of cases, which will be done, and development of drug resistance will also be seen. So these are the key results for India from a large civil society-led survey on impact of COVID-19 on TB epidemic. And you can see that in 85% of the patients have been shown that there is a significant decrease in TB testing during the COVID-19 pandemic and during the lockdown periods. So what is happening to clinical cases? This is a case which we saw 20 years ago. And this was a 12-year-old girl with persistent wet cough, fever, and blood in sputum. This was a chest radiograph. There was a cavity here, which is shown better on a CT chest. This was the bronchoscopic finding, which showed an endobronchial tuberculosis on flexible fiber optic bronchoscopy. This patient was IAP positive. The father also was a contact, and he also was carrying the germ. This was the picture of the fundus, which again showed involvement. There was some retinitis which was there, and this is what the secretions of this patient showed. There was massive positivity by AFP. and the MTB came positive. Now, this is a patient which has just come to us, which is admitted with us right now. And this is a 12-year-old female from Ludhiana. This is an area where there's a lot of industrialization and business in Punjab, and it presented with 2 months of cough, insidious onset, spikes of fever, weight loss, loss of appetite. And this is the chest X-ray that you see. There is marked opacification of the left side of the chest. Probably there's a little bit of effusion, as well as there are some nodes which are present on the right side and some reticulonodular pattern in the left upper lobe, which is present. So the ultrasound chest and abdomen showed multiple mesenteric lymph nodes in this patient. Gastric aspirate for Zeal-Nielsen smear was positive with 3+, more than 10 AFPs per field. Gastric aspirate for MGIT culture came positive for MTP. All 3 samples were positive. So what I mean to say is that the quality of patients that we are getting today is the same as we were getting 20 years ago. Of course, we are a referral center and we do get patients, but the number of patients that we have started getting off late has actually increased. So this patient anyway was enrolled under Nikshay and was started on fixed dose combination. So now this is the scene, in some of these hospitals. This is the news from Ludhiana, again from where this child had come. There's a huge rush which is seen in TB wards as OPDs reopen, and because till such time the outpatient departments were closed in many of the hospitals because of COVID problem, and patients were not able to come. But you can see the number of TB patients who are coming to TB centers now. So, this is a very important aspect which one has to see. I shall now talk of some recent advances which have occurred, which are more of scientific nature. And what I was talking to you till now was socio-epidemiological effects, and mostly effects of COVID as they have impacted the TB control program or the TB elimination program in our country. So some of the recent advances which are there, one is something on which we have been working in PGI, that is about role of MRI in thoracic tuberculosis of children, in which there was correlation on 40 patients in which we did CT scan as well as MRI in these patients, and we obtained a good correlation. And Dr. K.S. Sodhi, who is our colleague from radiology department, has pioneered this kind of work, and MRI is actually now shown to be a very important investigation which can pick up adenopathy, which can also pick up other lesions in the CT scan, in the MRIs of these patients. And these are the chest X-rays, and these are the radiological findings which are seen on MRIs in these patients. So lung MRI is now being shown to be a very important investigation for these patients. It's like a game changer which can happen in the diagnosis and follow-up of these patients. So another point which is now becoming very important is precision medicine. Now, precision medicine is something in which you direct therapies towards the genetic makeup of an individual. And we know that in our communities, there are patients who have different genetic makeup and they have different enzymes which deal with these anti-TB drugs. And, there were these slow acetylators, fast acetylators, which were there, and they used to modify the metabolism of INH in these, while being treated for tuberculosis. So this NAT2 genotype is actually something which now is being recommended that people should look for this polymorphism before even the start of treatment or at the start of treatment. And because these patients are likely to metabolize the INH in a slow pace, and these patients are likely to develop drug toxicity because of INH, and they have more of hepatitis related to INH. So this is also something which is coming in, and there are many other gene polymorphisms which are responsible for, say, Mendelian susceptibility to mycobacterial disease, MSMD as it is called. And these patients, especially girls, adolescent age, get severe forms of TB and sometimes drug-resistant forms of TB, and they have to be looked for when we are treating these patients. So the treatment is becoming more and more personalized as far as TB is concerned, and that is something which has to be kept in mind when we are treating these patients. Then we have the diagnostic algorithm for drug-resistant tuberculosis. I'm not going to go into a great detail of this, but we know that this algorithm exists, and drug-resistant tuberculosis has to be dealt with line probe assay, which gives us the sensitivity of the organism, and we have to use drugs which are appropriate for a particular organism which is infecting these patients. Another advancement in bronchoalveolar lavage, which has happened in tuberculosis, is that now we are becoming more and more invasive in diagnosis of patients. And sometimes if you perform a large number of bronchoalveolar lavages, you may get the organism which is positive. And it's very important to get the organism because that gives you drug sensitivity and you can treat the patients in a more accurate way. And then there are other additions to BAL, which is like ultrasound guided FNA, which can take place because of endobronchial endoscopes, EBUS as they are called. And they can also help us get to the organism and to the definitive diagnosis in these patients. So these are the initial regimens for drug-resistant TB. And we know that for children, drugs which are available are moxifloxacin, kanamycin, ethionamide, clofazimine, and of course, pyrazinamide and INH. In continuation phase, you're using moxifloxacin or other, even levofloxacin sometimes. And in children over the age of 6 years, we have these drugs which are diloxanide and budecillin, which are available, and they can be used in children as well. So that shortens the treatment of multi-drug resistant organisms, infections. And we can expect that these drug-resistant organisms are going to increase in the community because of this disruption in the program, which we have seen. And we should be prepared to treat our patients with DOT plus strategy. And we should teach our students about how to combine these drugs for the use in these patients. Moreover, even in latent tuberculosis, now the emphasis is on treating all household contacts which are there. And of course, if the patient is symptomatic, you try to rule out the disease. But 6 months INH have to be given to at least 2 children less than 5 years of age. And another regimen which has been introduced is not yet available, and that is INH and rifapentin. Now, this is a 12-dose regimen in which for 3 months every week, patient has to take this treatment, and it is recommended for children more than 2 years of age. So that's another advancement which has occurred and which will be introduced into the program very soon. They are just making purchases, I'm told, for these drugs which are there. So another point which really will help in TB control is the use of artificial intelligence. We know that with the Nikshay portal being there and all the patient data being collected, this digital health and surveillance, program management, training and communication, and even e-learning will be helped by the digital tools, and artificial intelligence can be applied to all the data which is coming along these portals, and one can really have diagnostic algorithms and decision support systems which can come out of this data. So it can help in program management by handling the diagnostic data. It can also help in connected diagnostics, which will become a flagship concept in TB program management. And something in the near future, a huge capacity of digital tools to compute and store data has profound implications, where massive amount of data is generated, and that can be handled by this deep learning and by machine learning. And one can have these programs to predict how a patient will behave or how a community will behave as TB is introduced. Another very important part, in which I alluded to you earlier, was that effective communication in tuberculosis control is very, very important. And this was a study which was on health workers' perceptions and experiences. And you can see that even in patients who were, in situations, about 40%, about 60 to 57% thought that this was still a hereditary disease. So you can see what is the amount of misinformation which is there in the minds of people. And people, also consider TB due to their past sins. Women are more prone to it. That is what some people think. Women are anyway not taken to the hospitals. That's another problem which is there. So even eating beef meat cures TB. That was thought by 43% of the participants in the study. So, these are the degrees of misconceptions which are there. And hence we need to, counter all this. So our education program, as is being run for COVID, also needs to be carried on for tuberculosis also. And to conclude, I would just say that TB resurgence is imminent, and especially after the COVID. Diagnostic armamentarium needs to be strengthened. We need to provide gene expert, TrueNat, ultra expert, whatever is available to us, to the community. We should be ready for treatment for drug-resistant TB. More trials need to be done in children about these new drugs which have come up. We must follow new guidelines for TB prophylaxis to achieve TB elimination. And precision medicine and artificial intelligence is actually the future. But another concurrent things which must go on is the interpersonal channels, such as face-to-face communication, regular health checkups, then information in health workers and patients, public gatherings, etc., discussions, and consumer provider meetings, and television could be very effective for increasing the awareness for this particular disease. With this, I really want to thank the organizers for inviting me for this very important lecture and oration, which I'm really honored to have. And thank you very much.
Thank you so much, Minu Madam. That was a great presentation indeed. We are really happy and proud to have materialized the inaugural oration with the best topic and the best faculty available. Now with this, we will continue with the oration proceeding. I invite Dr. Jijo Joseph John, the Secretary of the chapter, to confer the oration award to Madam on the virtual platform. Thank you once again, ma'am.
Thank you. Thank you so much.
Thank you, ma'am. Just a second as I confer it.
It's become so easy nowadays, to give an oration, get an oration.
So, ma'am, it is with proud privilege that we at the Indian Academy of Pediatrics Kerala and Pediatric Respiratory Chapter Kerala present to you with this honor. Dr. Meenu, you are an inspiring personality among your students and co-workers. You started your postgraduate you started your journey in the field of medicine from HP University Shimla and complete your MD from Postgraduate Institute of Medical Education Research and Chandigarh. You received training at the Children's Hospital, University of Pittsburgh, USA as a pediatric pulmonologist. You began your eminent medical academic career at PGIMR Chandigarh, where you ascended the hierarchy right from residency to professor over 32 years, both as an academician and an amazing teacher. You have done an excellent job as in charge of pulmonology clinic at Advanced Pediatric Center, PGIML Chandigarh, and in guiding generations of young pediatricians and pediatric trainees. You played a pivotal role in making the institute one of the top destinations for young graduates wishing to pursue DM pediatric pulmonology. Today, you are also heading the Department of Telemedicine at PGIML Chandigarh, using technology-based application to provide teleconsultations in North India under the Ayushman Bharat program. Your pioneering work on evidence-based child health made the institute the first ICMR advanced center for evidence-based child health in India. Your contributions to the development of methodology for systematic reviews has led to several Cochrane review publications. Your immense knowledge and understanding of clinical and basic mechanism of respiratory diseases, tuberculosis, and cystic fibrosis in children helped to establish the first pediatric flexible bronchoscopy service in the public sector in North India. Your association with the IAP is also a special one. Having worked as the member of IAP for several years, you have been an active participant of various committees of the IAP. You conceptualized and participated in many modules of the IAP. You also have been a consistent and leading speaker at several conferences held by IAP. You continue to contribute academically and have published more than 230 scientific papers in renowned national and international journals, and have also authored several book chapters. Dr. Meenu, you are an exceptional and remarkable teacher, and your work has been appreciated by everyone. You're always easily available for your students and colleagues, and whenever they need your help. It gives all of us at IAP Kerala and Pediatric Respiratory Chapter of Kerala immense pleasure in conferring the prestigious Professor T.U. Sukumaran oration on you for your outstanding contribution in the field of pediatric respiratory medicine. Thank you, ma'am.
Thank you so much. Thank you very much.
Thank you so much, ma'am.
Indeed humbled and honored, for at the same time to get this oration, and really thank Dr. Sukumar to act as a role model for all the pulmonologists in this country, and orations are not instituted every day about people. And it's indeed an honor to have that done.
Thank you, madam. Thank you very much for the excellent oration. Thank you.
Thank you so much.
Thank you so much. Dr. Nimi, we'll move forward with the next session, ma'am.
Yeah. Thank you. I actually have to leave, so.
Thank you, Dr. Krishna Mohan and Dr. Jijal. Thank you, Dr. Krishna.
Okay. Yeah. So thank you, Dr. Krishna Mohan and Dr. Jijo for moderating the session, and thank you, Dr. Meenu ma'am, for such an excellent oration. Now we're actually running late. We're moving on to the next session. Is recurrent respiratory infection, when should the alarm bell ring, by Dr. Subramania NK. I invite Dr. M. Vijay Kumar, State President-elect 2020, and Dr. M. Narayan, immediate past President IAP Kerala, for to moderate the session. Over to you.
Good afternoon to you all. We all had the privilege to listen to the first Professor T.U. Sukumaran oration. And now we stay back for another important session by a speaker whom you all know, who had inaugurated our Palmacon today. He is none other than Dr. Subramania NK, MD, and he has got a degree in MBA also. Chairperson of IAP National Respiratory Chapter, past Secretary of IAP National Respiratory Chapter, and he has been in the EB for 2 terms, 2012 and 2020. And of course, he has held various posts in many chapters in the association. Also an excellent faculty in modules, conferences, orations, and he has bagged a lot of awards, written a number of books, and numerous publications are there in his credit. And the topic he is dealing right now is recurrent respiratory infections. When should the bell ring? I think the bell should ring at the earliest. Over to Dr. Subramania NK, please.
Dr. Narayan sir and Dr. Sukumaran sir, my dear teacher, and my friends Krishna Mohan, Jijo, Rafi, and the awardee of the first oration, Dr. Meenu Singh madam, and all my teachers and friends from Kerala Heartland. So let me share my presentation, given that you have been listening to all the faculties from morning. So straight away, let's go to the presentation on recurrent respiratory infections, when the alarm should ring, or when you should ring alarm. What's that makes a recurrent respiratory infection a recurrent? Is it too great in number? Is it less in number but too severe? Is it that an episode is too long lasting? Or is it that the episode has some unusual complications? Or is it that they do not resolve with standard therapy? And I think have laid down first dilemma of defining the recurrent infections. Often we are bogged by the numbers only. Sir, this is the 5th episode of tonsillitis. This is the 2nd episode of pneumonia. But what if the first pneumonia took longer to recover? It may be telling us something inside. Am I clear with the first very concept? It's not just a number. There, on the contrary, there could be a child which has very frequent infections, but otherwise it could be a benign in nature and may not affect the child at all. Child can have all 365 days in a year and up to first 5 years running nose, yet the child can be normal. So my first confession here is that really we need to properly define the recurrent respiratory infections in children, which is the need of the hour, although we are going by some kind of norms. Therefore, way back in 1988, the recurrence per year has been defined as more than 6 respiratory tract infections in general. Now, further hair splitting would be like more than 12 respiratory tract infections of upper respiratory tract and more than 3 in the lower tract. I think there is, are you able to now get into the point, like it is not that one shoe doesn't fit all, and recurrent respiratory tract infections has to be defined as recurrent URTI and recurrent LRTI. And again, there are some hair splitting as far as the number, severity, and duration is concerned. Let me take you through a small scenario that happens in practice, and all of us are in this pitfall. An acute infection is the one which goes severe in a couple of days and comes down. This is what we have seen in most of the acute infections of the respiratory tract, be it upper or lower. In contrast to that, a recurrent infection means it should have episodes well separated by an interval, which is symptom-free and sign-free, which is very, very important. And I think the history is that we need to elicit this interval, which is very important. Often when you ask the mother, she will tell whole of July and August, the child was having cold, cough, sir. If you ask further, she will tell on 1st of July and 31st of August, the child would have had cold and cough. So, but the mother will always tell you that whole 2 months it was miserable. Did you understand? So therefore, we are having some barriers. And whenever you want to define pneumonia, whether the previous pneumonia recovered or not, we will not have interval evidence. Therefore, we often see that the same pneumonia repeats, and the interval period is the most difficult thing in practice to define. In contrast, I will come back to some of the cases which in disguise appear as recurrent. Actually, they are persistent. If you take asthma, for example, chronic inflammation is persisting, whereas the presentation to your clinic is acute flare-ups which are recurrent. Therefore, is asthma a recurrent disease? Answer is no. Asthma is a persistent inflammation with recurrent symptoms. So that's very, very important for us to understand the subtle difference between recurrent and persistent. And in textbooks, often we see recurrent bar persistent, they will write, so that, you know, all causes will come there. Many often there could be overlapping syndromes. Even in acute infections, often we see there is overlapping syndromes. Often it is difficult to separate the interval. Can I give the best example of a child which is going to nursery school syndrome, where one after another colds will overlap in such a way that we may not have separation of the episodes. And this is very, very difficult for us in practice. Now, let me take you through some of the facts. Most of the children, by nature and naturally, they have recurrence of infection. This is how they grow. They grow with infections. And you can recollect in your OPD practice, one mother coming to you frequently 7 to 8 times. In second year, she comes 3-4 times. In third year, she doesn't come at all. Fourth year, she doesn't visit. Then you may be wondering, has she gone to the neighboring pediatrician? Can you recollect all those? Close your eyes for a while and recollect. Do you remember some of the parents who frequently visit you? Suddenly they disappear after, when the child becomes 3rd or 4th year old. This is normal recurrence. And actually you will recollect the same mother when she comes back with the second child with again such infection. So therefore, my friends, around 80 to 90% of recurrences are normal. Make sure that there is a normal growth and development in them. Majority are URTIs. And this recurrence which I am talking, benign nature, is more viral than bacterial. And there could be an element of allergy, which you have to dig it out and find out, are we referring to asthma, allergic rhinitis, or adenoids? And all of you are experts in this by now. In contrast to this, there are abnormal recurrences which are characterized by failure to thrive. More often, they are lower respiratory infections. And mind you, even upper or lower infections, they could be bacterial in nature than viral. And often, they appear recurrent, but they could be chronic diseases. Am I clear with these two categories? And if you could separate them in your clinic, I think I can even close down and tell you my talk is over. This is most important for you as a message. Now, can I go further and tell you, apparently normal child with some kind of recurrence can happen with all these category, anxious parents, overgrow with age, you have seen epidemics, seasonality, often viral. You need to evaluate the environment, particularly the issues which I have shown you, the hand hygiene practices, overcrowding, and then first of all, I brought out one important kindergarten or play school problems, bottle feeding. These are the issues which we have to ask in our office practice. But I have seen that people pay you more fees for asking these questions. But they are very, very important for the mother to understand why my child is having frequent OPD visits. What is also important is at the general practitioner level, allergy is often mistaken for recurrent infections because for every cough, cold, and fever as a presentation, somebody would indulge in giving an antibiotic. And once the antibiotic is given in a prescription, the record goes to tell you that it is probably an infection. You understand? So if you see the prescriptions, do you recollect? Once they come to you with a frequent visitor, if you go back to the past prescription, there'll be azithromycin, there'll be amoxicillin, amoxiclav, some salbutamol, this, that, etc. Do you remember? So this is how the slip goes, and therefore the problem is that you have to separate allergy from infections. This is a skill. You have to ask for risk factors for allergy, parental asthma allergy, child, and the other risk factors like exposure and late sensitization, so on and so forth. There is always a pattern for allergy: early morning cough, nocturnal coughs, exercise-induced symptoms, triggered symptoms, seasonality. There is a syndromic presentation. Do you agree? They shift from syndrome to syndromic presentation, a pattern, and they often respond to steroids or bronchodilators. Basically, in a recurrent infection, you need to separate severe from non-severe. This is when the bell, I was asked to concentrate on alarm bell. If there are severe episodes and they are recurrent, they are very, very important versus non-severe but recurrent. And then the recurrence is again not yearly. Remember, yearly is not there. At least monthly visits, weekly visits, and daily visits would make it chronic. Do you agree? And persistent. So I think this layer has to be separated in your clinics whenever you are approaching the patient. The age of onset of the first symptom which recurred is important. Let's say a cough recurred in a child from 3 months onwards versus a cough recurred in a child from 3 years onwards. These two are different. The later one could be asthma and earlier one could be congenital aspiration. Congenital anomaly leading to aspirations. Do you all agree on this point? Or it could be a congenital heart disease which starts with a cough or breathlessness or feeding difficulties from 6 weeks onwards. So age of onset, whether it is adolescent, a child, an infant, or an immediate postnatal period is very, very important. And this is, please don't ask the history of current symptom onset. Please ask the age of onset of the first symptomatology. That's very, very important. And please also separate them. They may say URTI is in the beginning. Actually, what was the onset of beginning of LRTI episodes? That's important. When I say age of onset, it's not the age of onset in general. Age of onset of the pattern of symptoms that is currently there is the most important factor that would decide actually when the pathology actually started. There are two questions that you need to ask. Is it a respiratory recurrence or is it a multi-system disease with respiratory involvement, and that symptoms are recurring along with the recurrence of the symptoms in other systems as well? And sometimes you may have a multi-system disease, but a predominant respiratory, for example, a cystic fibrosis. It's actually a generalized disease, but a special affection to the respiratory system. So therefore, it's very, very important to find out whether it is purely respiratory. Respiratory is part of a multi-system disease. And if it is part of the disease, it's a predominant respiratory symptom. And often we forget to ask these questions. Please, we may be bogged by the main complaint and we need to ask them were there diarrheas and so on and so forth. Even in immunodeficiencies for that matter. Now I'll come to some of the experiences that I have in the past. Now it will be a quick run through for you, a rapid fire kind of thing. So my regards to our scientific chairperson, when he was told, He was visiting OPD for recurrent colds. Everything was normal. In fact, this case happened to meet me in my earlier days of practice. And do you remember how many of you examine the nose for recurrent colds? Often we don't examine at all, isn't it? Let me also confess. 50% of the times I forget to examine the nose. And in this particular child, which was 8 to 10 years back, which I saw, I'm not having the same photograph here, but I did not take any photograph. This was, the father was an Ayurvedic doctor, and the child had put lot of sponge from the pillows and put it inside the nose, and he was running from pillar to post. When I just examined the nose, I could see white, and when I pulled it, it came out this. I had to pull out the whole sponge. What I was, nothing should be left short of examining the nose. This is important. Often this is a good habit in all of us to, in a recurring colds, to examine the nose. Recurrent infectious rhinitis is defined as more than 5 episodes per year. This is not viral infections. I'm telling you recurrent infections. Now, 5-year-old Krishna, after visiting OPD for recurrent otitis media. Now, recurrent otitis media is only possible only when we diagnose otitis media by otitis. And if there are 3 or more episodes in 6 months or 4 episodes in 12 months, it's important. Recurrent otitis media can happen because if there's any obstruction at the outlet of eustachian tube. Eustachian tube opening, if it is obstructed by adenoids, you will get recurrent otitis. Whenever you get recurrent otitis media, adenoids, number 1. Number 2, a subtle sign of a mucociliary defect, and often primary ciliary dyskinesia. History will be multiple discharging years, multiple times, and also sinopulmonary infections. So it's very, very important for you to pick it up. 6-year-old Sachi came to OPD for recurrent tonsillitis, no allergy. Now the problem of tonsillitis is it is the crypts in the tonsils that get infected. And tonsil is like multifocal. See, follicles are there. I'm showing you my tips of my fingers. You can imagine the follicles. So when they grow into the crypts, ultimately they end up with multifocal abscesses. Each abscesses pinpoint to a follicle. So that's why it's called as follicular tonsillitis. If you rupture the follicle, you can drain the pus. Am I clear? Therefore, when you press the tonsils, it is painful. When you want to swallow, it's painful. There is a localized lymphadenopathy. And because it is the end, and there is stasis and bacterial infection, multifocal abscesses, you require antibiotics. Otherwise, it could have been viral, like any other respiratory epithelium. That's why when you have recurrences often, so much so that it is difficult to eradicate in the crypts an infection, you may have to subject a child for tonsillectomy. Am I clear on the refractory cases? Not just go by number, more than 5 per year, 5 in 6 months, 3 in 6 months, 8 in any time in the life. All these are definitions, which I also agree as an academician. But mind you, please select the cases where you think it is difficult to eradicate the bacterial infection, encrypt inside the tonsils, and recurrent tonsillitis or pharyngitis is therefore more than 3 episodes in a year is good enough to start looking at the cause for recurrence. 6-year-old Jijo of visiting OPD for recurrent URTI, he's on multiple antibiotics, hospitalized for IV antibiotics. How often you see an upper respiratory tract infection asking for an intravenous antibiotics and hospitalization? Will you admit for sinusitis, otitis media, tonsillitis? You don't admit. Suppose a child is sick enough to require admission. That means this is the child which has to be investigated. Be immunodeficiencies. Please, we miss them because we don't investigate them. So any upper respiratory tract infection, bacterial in nature, severe enough requiring hospitalization or IV antibiotics. Anyway, if it is a lower respiratory tract infection which is severe, you will anyway investigate for immunodeficiency. That's why I didn't bring out that point. So the message here is URTIs which are severe. 5-year-old Deepthi visiting OPD for recurrent URTI, multiple antibiotics, decongestant. Is it allergic rhinitis? Yes. The only issue which I have got with the pediatricians is that please separate the allergies from infections and don't overtreat allergies with antibiotics. So this is all the small message that I wanted to give from here. Please separate allergic rhinitis. We have got different forums in which we discuss this. Here I won't discuss it for want of time. Croup is an acute illness. What about recurrent croup? Recurrent croup can be of two things. One, it could be a telltale sign of an allergy. And second thing is there could be sometimes missed foreign body, subglottic or otherwise, and then there could be croupy symptoms and therefore evaluate them. 1-year-old Nisha visiting for recurrent colds. And if you find such children where there is an obvious reason for recurrence, like what you see in the picture, there is no need for me to explain to you the reason for recurrence. Is that clear? Sometimes it could not be, it may not be obvious. It could be submucous clefts, so on and so forth. And they are very, very important for you to pick up. 1-year-old Sukumaran was admitted for 3rd episode of bronchiolitis. So is it that bronchiolitis can recur? The bronchiolitis generally don't recur. 1 or 2 episodes can happen, but 3rd episode onwards, you must suspect probably an asthma. And this is all I can tell for my teacher who has taught me that recurrent episodes of wheezing has to be evaluated for risk factors for allergy and asthma in future. 3-year-old Ramesh was admitted for recurrent cough and fever, going to play home. Do you agree? There is a reason here. If you have a reason like smoking, if you have a reason like play home, the problem here is not diagnosis. I don't know. I will swear and ask you, how many of you could stop them from going to play home? I have failed. All parents will say, yes, sir. They'll come back to you again, demand antibiotics. But I will tell you, none of them will stop them from play home because this is what we have adopted to modern lifestyle. Remember only one message. If it is a nursery school syndrome, your antibiotics do not work. Please don't prescribe, because you will have to prescribe all 30 days in a month. Number 2, bronchodilators do not help. You'll go on prescribe bronchodilators for running nose. 3rd, your antihistamines don't help because all 30 days you have to give antihistamine. Only counseling, clearing the nose, giving paracetamol is all that is required as a message, because this is something which every pediatrician sees day in and day out. 3-year-old Joe's recurrent wheezer, no fever, afebrile, no risk factors. So is it asthma? So when you are in doubt, give a trial of inhalation corticosteroids and decide about asthma. 3rd year PG Balachandar asked under 5 wheezing. All conferences have confused me, and it's not asthma, but tell me, how will you respond and when the alarm should bring and how should you manage under 5 wheezers? You had a big session, so I'm going to tell you in 3 lines. If the trait that you are seeing is an airflow obstruction trait patient, that means small children, low birth weights, frequent wheezers, that means they have small chest, small airways, fixed obstruction or a variable obstruction. If you have, give them bronchodilators. Am I clear? These are the children who will get salbutamol prescriptions. They will visit you next year less and less. They outgrow the wheezing by caliber and by immunology. Is this trait clear to you? Most of them. Number 2 in under 5 wheezing. If you have an inflammatory prototype, for example, child with eczema, family history, they get frequent infections also. You understand my point? Inflammatory prototype. You can comfortably give them steroids. 3rd, you have 3rd category where they don't fit into obstruction or inflammation, but they fit into recurrent infections and impaired host responses. You can give them antibiotics. So my dear friends, everything under 5 years is just whether you decide to give a bronchodilator, a steroid, or an antibiotic, or none of them, or any 2 of them, or any 3 of them. It depends on how will you take the call on the physiology. You can straight away take the call on physiology and anatomy even without making diagnosis. And what I have learned over years is all these nomenclatures are confusing. They will tell this transient wheezers is outdated. No, it is renamed as viral associated wheeze. You remember so many changes in terminology. In another 5 years, another 5 terms will be added. So therefore, my dear friends, treat the underlying physiology rather than trying to treat the names. Narayanan, 8 months with repeated episodes of cough, SpO to 98%, was put on budesonide. There is no good response. So when somebody at 8 months was put on budesonide without response, you must always ask and evaluate and look for bronchomalaccias. This is often missed because whenever you have somebody not responding to bronchodilator, please be on the guard. It is something that where bronchodilation don't help. Often they have monophonic wheeze. This is a small video which show you how the bronchomalacia would look. And usually it will be like floppy airways. 9-month-old Sebastian was brought with wheeze since 2 months of age and repeated episodes of cold and noisy breathing. Now the problem is very simple, happening from 2 months of age. I told you in the beginning, any recurrence which starts at very early part of infancy, please be on the guard. Don't treat them as asthmatics, evaluate them. You may have to do many things. I have shown you only barium. You could do 2D echo, you could do bronchoscopy, you can do CT scan, you can do studies involving cystic fibrosis, so on and so forth. But remember, are you referring to wheeze? Are you referring to wheeze and cough? Are you referring to wheeze, cough, fever? So based on which of the limb is more, you are going to evaluate them. 3-year-old Abraham was treated for repeated cough and fever for 6 months, and X-ray shows some fluffy shadows, MAN2 positive. Please beware of MAN2. Everything that is repeated, TB is generally a persistent disease, not a recurrent disease. In this child, can you see left lower lobe collapse? And in fact, it was a foreign body. Foreign body is something which can be a differential diagnosis from rhinitis to alveolitis. I will tell you, if you think of foreign body, it will be there. When you don't think of foreign body, also it will be there. So foreign body will not be there when foreign body will not be there. That's the only thing I can tell you. Any amount of history and digging, all of us have failed in many a times. And if you diagnose late, then it's a problem. Remember, the child can incidentally have URTI and then sudden onset of cough. See, every day the child will be having running nose. So don't say it's an infection. Chest X-ray is not a point of exclusion. 1-year-old Jayaraman, 6 kg at 1 year with a birth weight of 2.8 kg, underwent tracheoesophageal fistula repair, now has feeding difficulties. Now what is the problem? Now he has undergone tracheoesophageal fistula repair, all right. Now also he is symptomatic, frequently requiring antibiotics. What does that mean? When you have a congenital anomaly in the past, even if it is repaired, let it be diaphragmatic hernia repaired, congenital heart disease operated, tracheoesophageal fistula repaired, a repaired airway is a repairable airway. Frequently, you require nourishing, nurturing, and support for the airways. Am I clear on this concept? Please understand, they are prone for recurrent aspirations, feeding difficulties. They need a lot of counseling. Please watch out for clubbing and progress to suppurative lung disease, which is preventable now. So I would say protect and the airways and prevent separation. That's the message you may have to do. Go ahead and get a bronchoscopy done, whether there is still leak, some fistulas are formed again, so on and so forth. You need to evaluate further. Let's come to last couple of slides. Riaz, 2-year-old boy, was having spitting of blood following fever of 3 days duration. This is the X-ray. Often don't go by X-rays. This is just a thymus. Remember, when I asked the postgraduates in this quiz and all, they may tell some pneumonias that can cause hemoptysis. Please always don't treat X-rays, treat the child. He spitted the blood all right, but is otherwise fine. So he may have recurrent symptoms. Don't go by past hemoptysis and therefore make a big story. So this is again a pitfall. 7-year-old Elizabeth, no cough and fever, but only breathlessness, which is recurring. What can be the problem? Only breathlessness, but no cough. So fever, that means no infection, no airway involvement. This is an interstitial disease. So recurrent symptoms, but now later it becomes persistent. Initially, it may be like recurrent symptoms. You do understand? Mothers will always tell in the beginning frequently the visit your OPD, but later on it will be persistent. Mother of Parvati with 2 episodes of pneumonia already is worried whether there will be 3rd episode. Now, how will you predict whether there will be recurrence of pneumonia from a given one episode of pneumonia? I will tell you, out of 10 pneumonias, one will recur. Remember. So, therefore, whenever you are treating, 9 out of 10, it will not recur. So, therefore, if it has already 2 recurrences, chances of recurrence will be proportionately higher. That's why when it is 3 or more episodes, we define recurrent pneumonia as 2 in a year or 3 in a lifetime, because this is the cutoff for us to evaluate the cause of recurrence, not go on treating recurrent pneumonia with recurrent antibiotics. Am I done with this simple message? This is most important. You should know why you are doing. And recurrent pneumonia, in one slide, let me complete for you, telling that age of the pneumonia is important. Recurrence young could be reflux, aspirations, congenital heart disease, cystic fibrosis as the age advances, foreign bodies in toddler age, but airway anomalies at any age, mediastinal neuropathy in older children, bronchiectasis, tuberculosis as the age advances. You can also approach by, is it in the same lobe or the segment, so that there is a local pathology like an endobronchial obstruction, stenosis, foreign body, so on and so forth, versus recurrence happens in multiple lobes, then you look for generalized causes like immunodeficiency. So let me come to my conclusions, because I have only 10 or 20 minutes for recurrent symptoms. So please ask, whenever there is recurrent symptoms, please ask the first question: is this a normal variant of recurrence in childhood? What are the features? Child's growth and development are normal. The symptoms are non-severe. They don't require hospitalization. Drugs fail to act. Your antibiotics fail, your cough syrups fail, your decongestants fail. Only counseling helps in majority of them, and they outgrow their symptoms with age. And there are environmental factors and issues which you can address. Am I clear with the first 90% of the cases of recurrence? This is when the alarm bell should not ring for you. Please check the growth. They will have normal growth or failure to thrive. This is when the bell rings. Normal growth and URTI, and often their atopy is hidden in infections and we miss them. And when you have failure to thrive, generally it may not be URTI, there will be LRTI. Am I clear with this first flow? Very, very important. Recurrent lower respiratory tract infections, don't accept them. URTI viral is all right, but if you have recurrent bacterial upper respiratory tract infections, again the alarm should bell. Atopy, asthma and allergy, I don't discuss much here in this platform. I wanted to just tell you is that allergy is often mistaken for infections. Recurrent LRT is pretty simple. Once you know that it is recurrent because of failure to thrive, that job is over. Unilobar, airway anomalies, foreign bodies, adenopathies, cardiovascular anomalies, ectasias, tuberculosis, multilobar, recurrent aspirations, reflux, immunodeficiency, tuberculosis, bronchiectasis, etc. It's very, very simple to diagnose recurrent infections. My dear friends, we are in poor country. Large number of causes of recurrence are not necessarily anatomical or functional or physiological. They can be social. Overcrowding, poverty, malnutrition can all cause recurrence. We pour antibiotics and cough syrups in all these people, where it is not going to help you unless you treat the underlying socioeconomic cause. Mind you, the stethoscope doesn't permit you to write multiple antibiotics. We are Black India because of our approach to recurrence, where we think that by over-investigating them, by over-prescribing them, we are done with the job. We should stop smoking, we should stop spitting, plant trees, and teach health to our healthcare administrators. They have not understood health, we have also not understood health. That's the problem. Mind you, immunizations are very, very important in preventing the recurrence, but it has become the luxury of the rich. Intensive care support may be required in a couple of them to save and then evaluate for recurrence. Again, it has become luxury of the rich. But rich are not spared because they bottle feed and their lifestyle practices will again pose them for recurrence. So nobody is spared from recurrent infections. That's the point which I wanted to tell you. Mind you, always plot the growth. and the child which is nice on the track, you can relax for a while. Nothing on earth is going to happen. Even asthma, if you delay diagnosis by a year and then start MDI with the inhalation corticosteroids, it's all right. But if a child is flattering on the growth curve, you must pick up early, and the alarm should bell. The bell should be strong bell at very early part of the life. And greetings from myself and IAP National Respiratory Chapter on this occasion. I hope that in given 20 minutes or so, I could do justice to a broad topic like recurrent respiratory tract infections. And thank you very much, Dr. Vijay Kumar and Dr. Narayan, over to you.
Thank you, sir. Thank you, Dr. Subramania. It was an informative, lucid, and practical presentation. And I think everybody is enriched with new knowledge. And I'll just go to the chat box, but I don't see any questions or queries in the chat box so far, sir. So I think everybody, only one comment, that is an excellent presentation as usual. So there are no other questions. So over to Narayanan, sir.
Yeah, thank you, Dr. Subramania, for diagnosing recurrent infections in most of the IAPs here, right from Dr. Sumaran sir, Parvati ma'am to Jijo and Disha, everybody. You spared none. So thank you for diagnosing that too, without collecting any consultation fee. So it was an excellent session. If there are no queries, let us close this session. Thank you.
Thank you, Dr. On recurrent respiratory infection. And thanks, Dr. Vijay Kumar and Dr. Narayan, for chairing the session. We will move on to the next session. Next session is on acute severe asthma. The only one probably a difficult or emergency situation we come across in asthma is an acute severe asthma. And we have Dr. B. Sharath Balaji is going to talk on the topic. And in the chair, we have Dr. VNN Pisharadi, past president of IAP, and Dr. M.R. Nair, past president of IAP Kerala, and our own member of Madhyakerala branch. Over to Dr. Pisharadi and Dr. Nair to take over the session.
Hello.
Yes, sir.
My dear friends, we are coming to the flag end of the state Respicon 2021, and the subject is difficult asthma, and the faculty which is going to be talked on this subject is Dr. Sharath Bajaj. And the subject, as you know, it is also called an asthmatic, status asthmaticus. And many of the practicing pediatricians may meet this type of episode in their life. So you must know this being discussed by Dr. and he is an eminent speaker and is coming from Chennai, working as at ICA, and he is a pediatric pulmonologist, and he got the gold medal in MD Pediatrics in 2016-10 batch, and he received best paper Respicon 2010-19, and he received best paper for Respicon 2019. And he is associate professor of ICH Chennai. He has authored many articles in various textbooks in pediatrics. He has conducted workshops in bronchoscopy, and his passion is always medical teaching, interest in primary immunodeficiency and rheumatology, and he has many publications in his credit. And Dr. Sharad, over to you.
Thanks for the nice introduction, sir. Thank you, teachers, and thank you, my dear friends. Can I share my screen?
Yes, sir.
Yes, sir.
Is
Yes,
it
sir. Please try sharing the screen.
Okay, as usual, is it visible and audible?
Yeah,
Yes.
Okay.
Yes, sir.
So almost at the fag end of the program. The topic for today is acute severe asthma. So before starting this session, there are so many unanswered questions so far existing. So can I use pressurized meter dose inhaler with spacer along instead of nebulizer? Can I use intermittent or continuous nebulization? Is there any need to use levosalbutamol instead of salbutamol? While giving steroids, what should I use? Hydrocortisone, prednisolone, dexamethasone. Which one is superior? Is there any role of subcutaneous adrenaline? When and where to introduce magnesium sulfate? Role of nebulized adrenaline, steroids, magnesium sulfates in acute settings. Is there any role of aminophylline in this modern era? These are all the questions we are going to discuss in the next 20 to 30 minutes. Before going to the discussion first, who are all prone for severe asthma exacerbations? As it is given in many books and many articles, when you have poor control with respect to admission, with respect to compliance, with respect to technique, and whether you are from a poor socio-economic status and you are constantly being exposed to indoor and outdoor allergens, not using your controllers properly, your technique is improper, getting admitted on and off in the past 1 year are all risk factors for asthma exacerbation. Among all, the one which stands first is the return action asthma plan. Whether the child who had a single episode of asthma exacerbation given the details about asthma action plan. So how to identify whether he is having mild exacerbation, moderate exacerbation, and severe exacerbation, and how to handle and when to come to your emergency room and when he need to be shifted to the E room or all of the concern. So the first and foremost thing that should be given importance is whether the child is having return asthma action plan. Each and every child with even a single episode of these exacerbation should know when to come, where to come, and what to take medicines. Right. So while dealing with the treatment of acute severe asthma, we all know that asthma is a disease with a triad of bronchoconstrictions, which can be dealt by bronchodilators, inflammation, which can be dealt by means of steroids, and hypoxemia, which can be dealt by means of giving oxygen therapy. But when need to be given at what time is the matter of question. Right. Let us learn about each and every armamentarium that is present in our treatment right now. First point, we all know that salbutamol, whether it is a levosalbutamol or salbutamol, what need to be given. As far as the availability is concerned, salbutamol is available everywhere, wherever you go. Levosalbutamol is available in some places. While dealing with the evidences with respect to levosalbutamol or salbutamol, what is superior? Neither levo nor salbutamol is superior. Both are one and the same. You can use salbutamol. It doesn't mean that you need to search for levosalbutamol. Levosalbutamol is indicated only when the person develops extreme tachycardia or extreme palpitation while giving salbutamol. As such, the treatment is concerned with respect to the benefit that is concerned with respect to either levosalbutamol or salbutamol, both are one and the same. So salbutamol can be used. Point number one. Second point, nowadays we are living in the era of meter dose inhaler. We are living in the era of nebulization, that too in the presence of COVID. What we need to do? For mild exacerbations, definitely pressurized meter dose inhaler with spacer, with or without mask, can be used. There is no need for any nebulization. But when you come to moderate to severe exacerbations, along with hypoxemia, nebulizer has to be given. Your bronchodilator has to be given along with the nebulizer with an oxygen driving force. Which one is superior? Is it intermittent or continuous nebulizer? Intermittent is indicated in mild exacerbation, whereas continuous is preferred in moderate to severe exacerbation. If it is not possible, that can be given in the form of back-to-back nebulization. Right. With respect to inhaled beta-2 agonist, that is salbutamol, as we discussed, mild exacerbation can be dealt with a pressurized meter dose inhaler along with a spacer with or without mask. Severe acute episode should be dealt by means of a nebulizer along with an oxygen driving force. So what is the dosage that should be given while using a nebulizer solution? So for less than 4 years, 0.5 ml of solution which contains 2.5 milligram, and more than 4 years, 1 ml of solution which contains 5 milligram, that can be used. But please remember, you need to have a minimum fill volume of 4 to 5 ml in the chamber. It should be diluted with a normal saline, and oxygen with a minimum of 6 to 8 liter, because it is the driving force which is not only able to disperse your nebulizer solution into the distal airways, but also it is going to correct the ventilation perfusion mismatch that is going to be caused by your inhaled bronchodilator. In case, if you want to use pressurized meter dose inhaler in office procedure, that too in a pandemic, what can be used? The same salbutamol can be used along with a spacer, valved chamber. Spacer can be used 6 puff every 20 minutes for about 3 times can be given. Yeah, so how 6 puff has to be given? So each and every puff should be separated by a time period of a minimum of 1 minute. 6 puff is equivalent to a nebulizer solution of about 2.5 ml given in every 20 minutes. So what does it mean? Whenever you use nebulizer solution every 20 minutes, you need to give 6 puff every 20 minutes. Both are one and the same. What about ipratropium bromide? It is also a smooth muscle relaxant. When it has to be used at the end of 1 hour, if you don't find any good response either to a nebulizer solution or your pressurized meter dose inhaler, then it's the time to introduce ipratropium bromide. Can I use ipratropium bromide even at the outset? Even upfront, can I use along with a beta-2 agonist? Yes, you can use. No issues with respect to that. Both ipratropium bromide and the beta-2 agonist from the start itself. That is, it both can be used in the same solution because both are compatible with each other even upfront. Dose less than 10 kgs with respect to respiratory solution, 125 microgram, 10 to 20 kgs, 250 microgram, and more than 20 kgs, 500 micrograms. But when you want to give in the form of pressurized meter dose inhaler, right now we are not getting enough supply of ipratropium bromide inhalers. So if it is available, the same can be tried. 6 puff every 20 minutes along with salbutamol can be given. What is the other demerit with respect to that? It can be used to a maximum of 24 to 48 hours. Beyond its use, even if it is an acute severe asthma with a severe exacerbation, taking time for resolution, the usage of anticholinergics along with all other drugs is questionable. So usage beyond 24 to 48 hours should be strongly discouraged. What about rescue steroids? So what are all the indications for rescue steroids? For all moderate and severe exacerbations, you need to add a rescue steroid. But with respect to mild exacerbation, is there any need to add a rescue steroid? The answer is yes. if the child requires more than one inhalation, or if there is ill-sustained response to nebulization within 4 hours after the first response, then you need to add a rescue steroid. What rescue steroid do I need to give? Should I prefer for an enteral or should I prefer a parenteral? If the child is able to take orally, an enteral route is as effective as a parenteral route. So it doesn't mean that you need to search for an IV or IM route. Oral route is preferable. What about the dose and duration? The most commonly available drug is prednisolone, 1 to 2 mg per kg over a period of 3 to 10 days. But dexamethasone, 0.6 milligram per kilogram once daily in 2 days is as equivalent as prednisolone, even more superior than prednisolone. What is the caveat? Shall I use an inhaled corticosteroids, high dose inhaled or nebulized corticosteroids during periods of exacerbation? The answer is still not clear. We don't say it is of no use. Right now, we don't have a clear-cut randomized controlled trial to support the evidence for high dose nebulized steroids. So what is the carry-home message with respect to any rescue therapy? Any steroid, any route is the mantra. Plan as per the availability, but give steroids. That is the carry-home message. Oxygen should be given, particularly if your saturation is less than 92%. Whenever you use a nebulizer solution, even if the oxygen saturation is normal, better it should be given along with an oxygen flow meter with a flow of around 6 to 8 liter per minute, because beta agonists are paradoxically prone to produce hypoxia. As a result of which, whenever you use a nebulizer solution, even when the oxygen saturation is normal, use oxygen to avoid that paradoxical hypoxia created by ventilatory perfusion mismatch, along with as a driving source to push your inhaled beta 2 agonist further inside the lung. Magnesium sulfate, yes. If you don't find any response to 3 doses of salbutamol and 3 doses of salbutamol and ipravent in the second hour, then you need to go for a magnesium sulfate, but strict monitoring should be of the rule, because it is prone to produce tachycardia, hypotension, and hypotonia. Indication usually indicated more than 4 years of age. We don't get much of acute severe asthma in children less than 4 years of age. So when to be given? When there is poor response to a combination of first ever SABA, second ever SABA plus ipratropium bromide along with steroid. If it doesn't produce any response, please give magnesium sulfate. So what is the dose that should be given? Intravenous is the preferable route with a dosage of 50 milligram per kilogram, a maximum of 2 grams IV infusion in normal saline, 50 ml normal saline over a period of 20 to 30 minutes. Can I use nebulized magnesium sulfate? Even though there are sporadic reports with respect to the usage of nebulized magnesium sulfate along with the SABA, along with the ipravent, whether can we use nebulized magnesium sulfate? Sporadic reports are there, but full telltale evidence or a randomized controlled trial to say whether to add this in guidelines is still lacking. If you want to use, you can try a bit on your hand. No issues, but RCT is still lacking in favor of a nebulized magnesium sulfate. IV magnesium sulfate, it is done and dusted. Its role is definitely there. Yes, we know salbutamol can be used. Everyone knows. Ipratropium bromide can be used. Yes, rescue steroids can be used. Magnesium sulfate can be used. I am not talking about IV terbutaline or IV, I am not talking about IV terbutaline or IV adrenaline. I am talking about subcutaneous adrenaline or subcutaneous terbutaline, or intramuscular adrenaline or intramuscular terbutaline, particularly with respect to subcutaneous adrenaline or intramuscular adrenaline. Whether it can be used, yes, it can be used. Whether do we have any evidence to support, even though many books says that the role of subcutaneous adrenaline in acute severe asthma not responding to SABA is questionable value. Definitely in our day-to-day practice, in our E-room, in our ICH, as well as in your pediatric emergency unit, we have been seeing a very good dramatic response for subcutaneous adrenaline, whether it is associated with or without anaphylaxis. Whenever you have an asthma with anaphylaxis, invariably adrenaline has become the drug of choice. And also with severe exacerbations and silent chest, your salbutamol, ipravent, and magnesium cannot reach through your nebulization route, as a result of which, in order to achieve an initial bronchodilation, subcutaneous or intramuscular adrenaline can be used. Both adrenaline and terbutaline are of the same dosage. It is available in 1 milligram per ml solution. It can be given in a dosage of 0.01 ml per kg, a maximum of 0.4 ml per kg, a maximum of 3 doses at 20 minutes apart can be given. Remember, terbutaline is at risk for causing myocardial ischemia and arrhythmias, and it is not easily available in many places. So please do consider subcutaneous adrenaline. Definitely it has got a magnificent role in a country like India, where there are resource poor settings still present. Even in resource good settings also, subcutaneous adrenaline has got a tremendous role in reducing the exacerbations of acute severe asthma. With respect to intravenous beta-2 agonist terbutaline, that is, when you have the child is at a risk for intubation, the child is at a risk for silent chest, then after magnesium sulfate, if nothing works, so the role is like that. You use SABA, no, it doesn't work. You add ipratropium bromide, doesn't work. Add your rescue steroid, doesn't work. You add magnesium sulfate. When everything fails, then comes the role of intravenous beta-2 agonist. But remember, whether it is magnesium sulfate or it is terbutaline, that should be done in a PICU setting. Particularly, the terbutaline is prone for myocardial ischemia and more prone for arrhythmia. So it should be done under strict continuous ECG monitoring in a PICU. Aminophylline, people used to say aminophylline doesn't have any role. It is not like that. Again, in a country like India, where terbutaline is not available in many places, aminophylline still has got a profound role, and it is as equivalent as your terbutaline. In some countries, instead of aminophylline and instead of salbutamol, particularly instead of terbutaline, IV salbutamol still has a role in some countries like Singapore. So whatever it may be, whether it is salbutamol, terbutaline, or aminophylline, after magnesium sulfate, whatever is available to you, please use that. Do not think twice, thrice about side effect. You need to monitor the patient continuously. What are all the non-standard therapies? Heliox, but in many places it is not being used. Even in abroad, they are not using Heliox therapy. Ketamine, yes, ketamine, not only during intubation. Each and every person here knows that ketamine has got a brilliant bronchodilatory effect, and also it increases the cardiac output and the BP. Okay, so as a result of which, ketamine not only need to be used to doing intubation, but also a low dose ketamine infusion has been used in many PICU settings to break the bronchoconstriction cycle. What is the role of montelukast during acute setting? No role, absolutely no role so far, whether it is an IV or oral, no role at all. Okay, now you know what are all the drugs that are available to you. Then what are all the questions that they need to be asked whenever a child is presented with acute severe asthma? So what are all the questions that need to be asked to a child? Since when you are getting this episode, whether had you released your relievers or not with is available with you? Is there any rapid worsening? Are you on controllers? Is there any trigger point in and around your house? Whether controllers are being used regularly, whether there were any previous admissions in the recent past, whether are you provided with a written asthma action plan, because this is going to determine whether he is going to get a mild, moderate, severe asthma exacerbation. All depends on these questionnaires. Okay, now you are going to face cases of asthma exacerbation. The first and foremost question is it an asthma? Still, there are so many cases of a migratory foreign body presenting as intermittent stridor bar, intermittent wheeze, still it is there in many parts of the world. So rule out asthma. Second point, whether this asthma is a manifestation of a generalized anaphylaxis. Second point. Third, in a case of adult with the suprasternal retractions and the inspiratory stridor, is it a case of vocal cord dysfunction? So please make sure before starting your treatment, make sure that you are dealing with a case of acute severe asthma, nothing else. And what about severity, and what about then assess on what severity is having, because based on which you are going to give the treatment, whether risk factors for death present or not. Even though there are so many scoring are in cards right now, as per our asthma action plan given by our respiratory society, we can follow the pulmonary score index. Instead of going for so many questions, just simply ask 3 questions. Your respiratory rate, whether wheezing is present or not, whether accessory muscles of respiration are acting or not. So respiratory rate, as per the increase in severity, you can give a score of 1, 2, 3. And when you hear wheeze, whether it is heard only during end expiration or full expiration, or it can be heard even without a stethoscope. Whether your accessory muscles of respiration, particularly your scalene or your sternocleidomastoid, whether it is not acting, doubtful acting, apparently acting, maximally acting. Based on these scores, you can give a score of around 0 to 3, and it is a mild severity that can be treated on an outpatient basis. If it is a moderate severity with a score of 4 to 6, that has to be treated in ward. But with a score of 7 to 10, it is a severe exacerbation. That patient has to be managed in your PAC. Case scenario. This is a 6-year-old, respiratory rate of 30 per minute, mild increase in accessory muscle activity, terminal expiratory wheeze, able to speak sentences. So what is the pulmonary score index? So the respiratory rate is around 30, the terminal wheeze and the questionable, doubtful accessory muscle activity increase. So score of 1, 1, 1 given, as a result of which your pulmonary score index comes around 3. So this patient can be managed at home. If the child is having a meter dose inhaler just such as salbutamol, along with your spacer, you can use this salbutamol with pressurized meter dose inhaler along with the spacer, as we described already. 6 puff every 20 minutes, a maximum of 3 times for about an hour. Okay, then it can be continued in the next remaining 3 hours based on the level of the improvement. But remember, at the end of 4 hours, if there is an ill-sustained response, or if the child requires more than 1 cycle, that is 6 puff after 20 minutes, first dose rescue steroids can be started at the home itself, because when you start rescue steroids within 75 minutes of acute asthma exacerbation, definitely it is going to reduce hospitalization, morbidity, as well as mortality. Case 2. What is the 6-year-old non-wheezer brought to casualty, respiratory rate of 40 per minute, wheeze throughout expiration, retractions are obvious. When you put a score, it comes around 6. So anywhere between 4 to 6 is a moderate exacerbation, and how it has to be treated. So this has to be treated in your room. So give oxygen. Can I use a meter dose inhaler or salbutamol nebulization? Whatever it may be, please make sure that the child is able to do a meter dose inhaler with the spacer. If he is able to do, well and good, you continue your salbutamol nebulization, salbutamol through inhalation, through meter dose inhaler with valved chamber. But when the child is having hypoxia, when the child cannot do that kind of inhalation and exhalation during that exacerbation, do not think about anything. Go for salbutamol nebulization, as we discussed, 20 minutes into 3 times. So at the end of, immediately, whenever your index score is between 4 and 6, do not wait for response to therapy. Start rescue steroids. What next? When there is good response to your nebulization, yes, well and good, taper and stop your salbutamol nebulization. When there is poor response at the end of 1 hour, you need to add ipratropium bromide. Can I add ipratropium bromide even at the outset? Yes, along with salbutamol nebulization, ipratropium can be added at the outset itself as soon as the patient gets admitted in case of moderate to severe exacerbation. Right, at the end of 2 hours of SABA, ipratropium and rescue steroids, still the child is having a respiratory rate of 50 per minute. Now you are assessing at the end of 2nd hour, you have given salbutamol, ipratropium, rescue steroids. But at the end of 2 hours, still your respiratory rate is 50 per minute. Wheeze during inspiration 2, maximal retractions are present and your pulmonary index score has become 7 to 10. Here it is 9. Then what does it mean? The child is progressing for severe exacerbation. So you have utilized the following armamentarium: SAB, ipratropium, rescue steroids. What else can be used? 2 things. If there is an availability, please use subcutaneous adrenaline. Definitely it has produced many very good results as far as our center also concerned. Okay, so you can consider a subcutaneous adrenaline, a subcutaneous terbutaline can also be considered. But as far as the guidelines are concerned, if there is poor response to this trio, the trio means the SABA, ipratropium and rescue steroids, you need to go for a magnesium sulfate. Whether it is a magnesium sulfate, the dose was discussed 50 milligram per kilogram in 50 ml normal saline over 10 minutes. A maximum of 3 doses can be given. Right. So when magnesium sulfate is not available or the child is not responding to magnesium sulfate, shift the child to PICU, start terbutaline infusion. If it is not available, aminophylline infusion. What is this? This is a 10-year-old boy with severe retraction, cyanosis, not able to breathe, not responding to SABA, absent breath zone. So what does it mean? It is a life-threatening attack. That child has to be started on subcutaneous or intramuscular terbutaline because he is having silent chest. So as soon as possible, start either IV Dexa or IM Dexa or hydrocot or methylprednisolone, magnesium sulfate, and based on the availability, aminophylline or terbutaline. And the pre-intubation strategies, I am not going deep into it. The one thing that makes sure while intubating them, as far as possible, try not to intubate the child because intubation itself can aggravate bronchoconstriction. If at all you want to intubate, make sure you use ketamine and avoid atracurium and avoid morphine because they are prone to cause histamine release and which in turn cause exacerbation. What about you use nebulizer in a moderate to severe attack? Amidst COVID pandemic, is it right to use a nebulizer? Yes, in case of mild, you can use a pressurized meter dose inhaler. But with respect to moderate to severe attack, you need to shift the patient to a separate room. You need to switch to nebulizer, but make sure you wear an eye protection, gloves, gown, and N95 mask. Yes, there is a role for non-invasive positive pressure ventilation, whether it is HFNC, CPAP or BiPAP. Definitely it is going to give some relief for the muscles that are already undergoing fatigue. As discussed, avoid atracurium, morphine. As far as possible, use ketamine, isoflurane or sevoflurane. When to take an X-ray chest? When there is a persistent focal crackles, not focal crackles, persistent focal crackles indicates there may be an underlying pneumonia. A temperature of more than 39 degrees Celsius to look for pneumonia. Persistent focal reduced air entry. It can be due to atelectasis or it can be due to a onset of pneumothorax. Uncertain diagnosis. Chest pain, again a pneumothorax or pneumomediastinum. In all these cases, you can take a bed X-ray chest, right? You have treated the child. You have gone up to terbutaline. What needs to be done? last come first out basis. So first discontinue terbutaline or aminophylline drip. Once you got the response, then you need to taper your ipraven, then you need to reduce your salbutamol, and then finally replace IV steroids to oral steroids at the time of discharge. Make sure at the time of discharge in these exacerbation, better you need to start an inhaled controller therapy with the pressurized meter dose inhaler, because the adherence and compliance will be good whenever you start an inhaled controller therapy during this setup. What is the discharge criteria? The patient should have a good sleep in the previous night, should have a good diet in the previous night, comfortable, able to speak, an index score of less than 3. It doesn't mean that you are not supposed to have a complete absence of wheeze. You can have wheeze, but the requirement of salbutamol nebulization should be 6 hours and more. If it is so, even in the presence of minimal wheeze, you can discharge a child, provided the child should have a SABA at the time of discharge, provided the child has started on inhaled corticosteroids, a controller therapy at the time of discharge. How long you need to follow your SABA? A minimum of 2 to 3 days, 6 hourly has to be followed. Return action asthma plan is a must. How to identify mild, moderate severity by the parents or by the patient themselves, and when need to start your pressurized meter dose inhaler with or without oral steroids by themselves, provided they are taught properly. Discharge plan, as we discussed, a maximum of 7 to 10 days of rescue steroids, oral steroids can be given. Pressurized meter dose inhaler 24 to 40, 48 to 72 hours. As long-term education and asthma action plans is the must. Please remember, the child has to see you after a week or 2. Finally, what is the carry home message? Step 1, in any case of acute severe exacerbation, 3 doses of salbutamol through either nebulization or pressurized meter dose inhaler, 20 minutes interval for an hour. If there is no response, add ipraven 20 minutes to complete the second hour along with SABA. Third step, always, if there is suboptimal response in the first hour, add a steroid, whatever it may be. Make sure that has reached the blood. If there is no response to salbutamol and ipraven and rescue steroid, try considering intravenous magnesium sulfate. Step 5, no response, add intravenous terbutaline if there is no response to magnesium sulfate. What are all the 2 caveats from my side? Caveat 1, consider subcutaneous or IM adrenaline along with step 1 or step 2 if the child resists inhalation or silent chest. Caveat 2, consider aminophylline in case of non-availability of terbutaline. With this, I am completing my session. Thank you. Once again for all for providing this beautiful opportunity. Thank you, one and all. Over from my side, sir. Over from my side.
Thank you, Doctor. The excellent presentation. And Dr. Pisharadi, please take over.
Thank you, Dr. Sharath Balaji.
Yes,
for
sir.
Hello. Thank
Yes,
you,
sir.
Doctor. Beautiful, clear, and basic presentation. And some of the seniors have also expressed their views with nature of the presentation. I think we have one question. That is from Dr. Vijay Kumar. That is, should we combine inhaled salbutamol plus inhaled corticosteroid while discharge?
As we discussed, high dose inhaled corticosteroids either through pressurized meter dose inhaler or through nebulization is still of questionable value right now. If you are planning to start, there is not a contraindication to say, no, you are not supposed to start an inhaled corticosteroid. The role is questionable. You can start if you want. The role is still questionable. Maybe in future, we may get some of the good papers or RCTs in support of it. Right now, we don't have a good evidence. If someone wants to start, there is not a contraindication at all.
Okay, I don't find any more questions, some except some comments. So thank you once again, and thank you the organizers for having me given the opportunity to chair the session. Over to the organizer.
Thank you, Dr. Pisharidi and Dr. Nair for chairing the session, and thank you, Dr. Sharad Balaji, for an excellent presentation on asthma, how to manage in a day-to-day practice. Thank you, sir. Thank you very much. And now we have crossed the limit of our conference also. Now we are reached 2:20 p.m. Till more than 100 delegates are available in the platform. That means something different is going to happen. Something new is going to happen. And that is nothing other than the postgraduate quiz on respiratory pediatric pulmonology. And I hope that we will have a very good show with more than 20. Actually, we have limited it to 20, and we have 20 teams participating. And it is going to be handled by our young dynamic member, Dr. Bipin Jose, who is an intensivist in the Rajagiri Hospital, Alvi. And over to you, to Dr. Bipin. Bipin will explain the modality of the program, and we will go on to the quiz. Please be with us with fingers crossed and who is going to win the prize. We have excellent prizes in the available. Over to you, Dr. Bipin. Dr. Bipin,
Dr.
unmute,
Bipin, please unmute.
Oh, sorry. Am I audible now?
Yes. Carry on.
Yeah, thank you, Ashok Kumar sir, for that wonderful introduction that nicely summarizes, as I can also see that it's almost, more than 100 participants still, including the teams who are participating and probably their colleagues. So shall I take over the screen now, Nimi?
Yes. You can share the screen.
So basically, we have actually done a trial run yesterday. So for those of you who are new to this platform, though, this is an online gaming platform, online quiz gaming platform, where at least 20 teams can at the same time come face to face in a quiz competitions. So the best part of it is that we have almost 20 teams registered from all over India. Apart from teams from India, we have teams from Tamil Nadu, Telangana, Rajasthan, UP. So that was a very overwhelming response. I think we, in fact, ourselves at the organizing team were not expecting this participation. So thank you once again, all of you have found time to chip in and be part of this fun learning exercise. So Nimi, I thought like yesterday we had a few teams who were left out for the mock session.
Yeah.
So I'm planning for a brief 2-question mock session because I've made one change as I have updated. Yesterday, the second device was not displaying the questions and the answers. So I've changed it to another platform where you can actually see the questions in the other device also.
Okay.
And then to all of those who are viewing other than the teams participating, I strongly urge and request you to keep the speaker in the mute mode, because any distractions would be actually very difficult for the team members. So so shall I go to this? So we'll start off with a 2-question dummy quiz, and then we'll go to the proper quiz.
Yes.
So the teams, as we have already discussed yesterday, can you log in with your respective institution names rather than the per participant name? For all of those who are watching us, you must be seeing these are the, so initially we started off with like one team from one institution and relaxed towards the last 2-3 days. So we have 2 teams from SAT and 2 teams from Stanley Medical College. So we have 15 participants, 16, 17. So this is actually a platform where the marking is done automatically. Marking is done automatically in that way. It is not only the accuracy of the answer which matters, but also the promptness with which you come up with that answer. Yeah, I think that is explanatory. That means like if two teams come up with the right answer, still how fast they come up with the first, the first team to come up with the right answer would actually be scored more than the team who got it right on the next occasion. So that is how the whole thing works. And the marks are updated after every question. So I'll try to have a brief discussion on the options also, so that it could be some learning experience for the teams.
Okay.
Why can't you go to the trial run?
I was just waiting. We have actually 20 teams participated. Now I'm getting 18. I think we can wait for 2 more minutes, sir.
Yes.
Now we are at 18. So if we get the full participants on board, then that would be nice. Yesterday also somebody missed it out. Yeah, 19. So we are having one more team to join us. Nimi, any idea which is our missing team?
I'll just check. Yeah, SAT 1 is missing.
SAT 1.
1 is there. SAT 1 and 2 is there. One second.
Yeah, 1 and 2 is there.
ICH Chennai is there. Teni Medical College, Stanley Medical College. Stanley is there. Stanley, only one team is joined, right?
Okay, they had actually registered for 2 teams. So
yes.
Yeah, now we have the full set of 20 teams.
Okay, so let's go ahead with the trial.
So just go to a 2-question dummy round. And Nimi, participants, please let us know through your chat box or anything, like if you can see the answer and question in the options in the second device. So the commonest cause of stridor in infants. So the teams would have 20 seconds to answer.
I'll just check.
Cool. So that is how it is. 19 of them have got it right. And then we go to the next slide. We can see, although 19 teams have got it right, as you can see that TMC Nizamabad is the team who got it first. So that is why they have the highest mark. So that is how it works. Teams, can you just confirm that you could see the question and the answering options, right? Can anybody just unmute and let us know?
Yes, sir.
Perfect. Thank you so much. So we'll have just one more question before we go into the proper quiz. So daily day symptoms and at least once weekly night symptom is graded as what severity in asthma? Perfect. So 19 teams have got it right. So this is how it works. So this is it, 3rd, 2nd, and 1st. So that was just so Jipmer is the 2nd position and 1st position is SPMCB Canada. Okay. So that was just the
Within 1 minute.
Yeah.
1 minute.
Yeah.
I have seen 2 SAT 2. I think one is Stanley Medical College. That you have to correct it. I think you have to identify which is Stanley and which is there are. You check the name.
So there are two teams from both Stanley Medical College and SAT Trivandrum. So
no, both are given SAT 2. You check that.
Is it? Okay. Anyway,
I have read like that. You just check it. Otherwise, that will be confusion.
Oh, one second. Thank you for pointing it out. So let me just clarify it straight away. So team SAT 1 will be Dr. Atul and Akash Nair. So when you log in for the next proper round, I hope Atul and Akash, you are hearing me, right? So when you log in for the proper quiz, team SAT 1 would be Dr. Atul and Akash Nair, and team SAT 2 will be Dr. Ashim and Dr. Neetu. I hope it is clear.
Okay.
Okay, perfect. So now we come to the proper round. So this is going to be a 20 question round, and all the best. I think you have already waited for so long, so I don't want to waste any more time. So you'll have to log in with a fresh. So the first 3 positions will be having a certificate of appreciation as well as a cash award from the IAP Madhyakerala. The first position would be getting 3,000 rupees, second 2,000 rupees, and third 1,000 rupees. Ashok Kumar sir and Nimmi, can you just make sure that the participant's video is on? So there will be some external surveillance going on.
Participants, kindly turn on your videos. I can see few of your videos are not on. I'm not able to see you. So kindly turn on your videos in the Zoom.
And kindly make sure that only the 2 participants who are the team members are in the room.
Two more to join.
Last team. I think team SAT 2 is missing here.
SAT 2.
SAT 2 is missing.
Yes, sir. Hello.
Yeah, speak up. Is it team SAT 2?
Yes, sir. My net is a bit poor, sir, so we're not able to.
Okay, Dr. Neetu, I'm very sorry to tell you, we can wait for a couple of minutes, but then these are things beyond our control. And even during the course of this quiz, if you happen to lose connectivity, then I'm afraid to tell you that we can't go back and reattempt that question, which has been already mentioned.
Sir, SCT2 we have already joined, but our name is not displayed in Kahoot.
Is it?
Yeah.
Dr. Hashim and Dr. Neetu.
Yes, ma'am.
Okay, probably then it is because of the space constraint. Then shall we start then? But then the participant showing is only 19. So I'm just really wonder whether you have been able to make an entry.
Sad to, can you just retry with this pin again?
Just give it one more try, Ashim, because we can't see your name in the list and also
In the Kahoot.
Oh, okay, sir.
Can you just go back and then re-enter the game pin?
Yes, ma'am.
Yeah. Yes,
yeah,
there you go.
I can see. That's great. Super. Oh God. I think I pressed.
You can just
sorry. I think sorry again. So that was a lot of time wasted. So I mean inadvertently I pressed the original
mock run again.
Sorry. So we'll have to go back again.
That's okay.
Just a second. I think I'll have to close the whole thing. I think better I start off from the beginning.
Yeah.
Just give me a second.
Sure.
Sorry about it.
No, it's okay, sir. Like, happens. Chipmore, Ravina. IMCH team camera is not on. Dr. Belvina, camera is not on. All participants kindly turn on your camera so that I don't have to call up the names. Aparna. No, Aparna is not a participant.
So here we are finally. Thank you so much for your patience.
Can you display the Kahoot pin once more?
Yeah, we are going to that page again.
Is it visible now?
No, you haven't shared your screen. Share screen.
Okay, one second.
Yes.
Now, is the Kahoot screen visible now?
No, it's your desktop. Yeah, now the Kahoot screen has come.
Now?
Yeah. Yes.
Perfect.
Yeah, teams can enter the game pin and log in again.
Much faster this time, at least.
Got used to 4, 6.
Perfect. Good. So now we have 20 teams. Shall we go straight?
Yeah.
So we'll start with the first question. So a 15-month-old baby with barking cough started after a history of coryza and low-grade fever. The likely auscultatory sound is. Wow, that's so cool. Everybody has got it right. So brilliant start. Great. Super. So I think it's self-explanatory. There's hardly any need for further explaining on that question. Go to the second question. The total number of bronchopulmonary segments in the right lung. Cool. So 14 teams have got it right. I hope you must be aware that the right lung has 10 bronchopulmonary segments while the left has 9, because instead of the apical, anterior and posterior for the right upper lobe, we have the apical, posterior and anterior for the left lung. So 9 on left and 10 on right. So 14 teams have got it right. So here is the updated one. So Jipmer is still going strong. We have got 2 questions right. So there are a lot more to go, 18 questions. So you have plenty of time. Just calm. Here it goes, the third question. Regarding management of acute severe asthma, not true is. Okay, 12 teams have got it right. So you know that low PEEP and long expiratory time is the norm in asthma ventilation. Magnesium sulfate, as you have just heard, is a very important drug. Aminophylline has a very narrow therapeutic index and has to be given only in an ICU setting, preferably with the drug monitoring. And relative hypercapnia, although you keep listening to this term over and again in ARDS ventilation, which is not true in asthma, because whenever you get hypercapnia in asthma, you take it as a sign of impending respiratory failure and you need to act immediately. So that is the catch there. Hypercapnia is not acceptable in asthma, unlike in ARDS. Good. So now we have a change of position there. The ICH team has come up. Cool. We go to the next question. True about epiglottitis except. Okay. Surprised. I thought most of them would be getting it right. So actually, croup, the treatment of option is IV dexamethasone. Epiglottitis being mostly bacterial, you cannot say like dexamethasone is the treatment of choice. Maybe at times, very rarely, when you have a risk of losing your airway, you may give, but then among the options, this is the false statement. Okay. Cool. Again, change of position. GMC Nizamabad has come on top now, followed by AIMS Jodhpur, then Little Flower, GMC Thrissur, and fifth position is Jippa. Okay. So not true about allergic bronchopulmonary aspergillosis is not true. Cool. That's good. 10 teams have answered it properly. BAL examination as diagnostic is the wrong choice here. Here you must be familiar and you must clearly understand that ABPA is actually a fungal hypersensitivity, which can coexist with asthma and usually can cause uncontrolled asthma. But then unlike invasive aspergillosis, which you find in immunocompetent state, you rarely do a BAL examination to prove that it is ABPA. It's mostly an immunologic diagnosis where you can have an elevated serum Ig or a specific IgG precipitin against aspergillus antibody. And steroids are in fact the choice of treatment. So BAL examination as diagnostic is actually not true about ABPA. Perfect. Okay, AIMS Jodhpur has come to the top position now. Great. So we'll go to the next question. AIMS Jodhpur, followed by GMC Thrissur, followed by JIPMER, ICH, and IMCH. That is what we are at. Sixth question. False about chronic granulomatous diseases. False about CGD is. Super. Again, 10 teams have got it right. As you know, CGD is a primary immunodeficiency which results from the NADPH oxidase deficiency, resulting in recurrent pneumonia with a catalase positive organism. So hypogammaglobulinemia is also a part of primary humoral immunodeficiency, but usually is a feature of Bruton or common variable immunodeficiency. The rest, all three, like X-linked, recurrent pneumonia from catalase positive, these are all true statements about CGD. So AIMS Jodhpur still going strong with ICH in 2 and JIPMER in 3. It's very close competition actually, neck to neck. Perfect. Seventh question. True about managing COVID pneumonia in children is. True about. Oh, I'm surprised because if you had listened to that lecture from Danya Dharmapalan, you would have got this answer. So maybe the deterrent here was the first choice. Remdesivir is not approved, but then you must clearly know that this is an FDA approved drug for an emergency usage in children more than 12 years. So Remdesivir is not there in the national guidelines for usage in COVID-19 in India, but then it can be used on an emergency usage compassionate background. But then a very clear statement which is true is dexamethasone. Dexamethasone is definitely from the recovery trial in COVID has been clearly stated that steroids are to be used in hypoxic children. That has the largest body of evidence. So that statement is definitely right. So we see some change in positions now. We move to the next question. We are at the 8th question now. Identify the pathology. Cool. So 12 team members have got it right. So that was a actually a sleep study pattern which shows us an obstructive nasal flow suggestive of an obstructive hypopnea. Actually, the immediate differential diagnosis would have been a central apnea. So I hadn't kept that option. So if you could have just identified it to be a polysomnogram, then you could have actually got the answer. The choice would have been between obstructive hypopnea or an apnea versus a central apnea. But then central apnea was not there in the option at all. So it was actually a straightforward answer. So now JIPMER has moved to the top position with ICH second, IMCH third, AIMS Jodhpur and Government Medical College Thrissur in respective positions. So we are at the 9th question. All are causes of bronchiectasis in children except. Wow, that's good. That was one of the relatively easy question there. 18 teams have got it right. I don't think there is any need for an explanation there. JIPMER still maintains the first position. Cool. So we are at halfway through. True about bacterial pneumonia is. Okay, I think that was a bit difficult question, but okay. So community acquired MRSA cover is actually not needed in all admitted patients unless you are thinking of MRSA infection in the form of a bad hemodynamically unstable patient. Otherwise, you will not add vancomycin in a hemodynamically stable child who is coming from community with a pneumonia. Actually, if you had seen the other option, staph pneumonia is typically bronchopneumonia. Fisher bulging sign is seen in Klebsiella. Mycoplasma pneumonia, as you know, is not a very easy diagnosis upfront because you will not get a high IgM antibody on first go. You will have to have a paired serum at least 4 or 5 days apart, preferably 1 week, to see for the increasing titer. So only 5 teams have got it right. So JIPMER still holds good at first position, followed by ICH and AIMS Jodhpur. 11th question. All are causes of opaque hemithorax in X-ray except. Yeah, so 10 teams have got it right. Actually, yeah, the other 3, massive pleural effusion, unilateral agenesis, complete lung collapse, are all causes of opaque hemithorax. And Swire-James syndrome, as you know, it's better known as the Swire-James-McLeod syndrome, is actually a cause of unilateral hyperinflation or emphysema. Rather than giving an opaque hemithorax, it gives hyperinflation in X-ray. So 10 teams have got it right. So ICH has actually moved front. 12th question. About latest pediatric TB guideline, not true is. Yeah, that's good. So almost 16 teams have got it right, as you can clearly understand that the bread and butter of pediatric exam will be tuberculosis. I think it doesn't need much explanation. So newer molecular diagnostics like NAT is recommended. In a continuation phase is 10 months for CNS, osteoarticular, spinal TB. Molecular diagnostic methods like NAT and GeneXpert have more sensitive than smear examination. And there is no empirical category 2 treatment now, which is all based on drug sensitivity testing these days. And Dr. Meenu Singh was nicely elaborating on this method. So happy that 16 teams have got it right. Yeah, Chipmer has moved again to the top position. So, which is false about FeNO? False about FeNO. Cool, that's good. 9 teams have got it right. So it is FeNO is a non-invasive method of assessing the airway inflammation, especially the eosinophilic phenotype, and can be even used as a marker of ICS compliance in children who are coming back with frequent exacerbations. And the difficult to perform in less than 7 years is a main drawback. And primary ciliary dyskinesia, this is one thing PGs should know, that this is one condition where you classically get low FeNO. And it is even used as a screening test for if you're suspecting PCD and you're getting a very low FeNO, then that could be suggestive that it could be PACAD. So almost 50% of the teams have got it right. So IMCH has moved to the top. 14th question, which is true about bronchiolitis? Very good. So almost 50% of the teams have got it right. As you know that RSV is the commonest cause. All patients with tachypnea need not have admission. IV steroids have no consistent benefit in bronchiolitis. Palivizumab is a humanized monoclonal antibody for RSV, which can be given in a selected choice of patients, which is used in Western world before the onset of RSV season. So 50% have got it right. IMCH maintains the first position, followed by Chipmer and James Norwood. Strongly request other teams to keep, other participants to keep your speaker in a mute mode. The next question, which will be 15th question. Identify the procedure performed. Very good. So 11 teams have got it right. So it's the impulse oscillometry procedure, which is actually can be considered as a substitute for conventional spirometry, especially in younger children, where you directly measure the impedance and resistance of the airway using a pneumotachometer, which sends impulses in frequency ranging from 5 Hertz to 30 Hertz, and thereby measuring the resistance from the central and peripheral airway. So the most important advantage of IOS is that it can be used in tidal breathing. You don't have to have a forced expiratory technique as you do for a conventional spirometry. So that has been considered as a gold standard of pediatric PFT in less than 5 years. Very good. So more than 50% have got it right actually. Oh, sorry. Only 3 teams have got it right. May not be very familiar with this. So it is actually IOS. Good. So IMCH still holds the first position now. We are going into the last quarter of our quiz. Thank you for staying tuned with us. All are true about cystic fibrosis except. True about cystic fibrosis except. Cool. 16 teams have got it right. So that means I don't have to explain further on this. The commonest screening test in newborn is not a genetic testing, but is something which is called as a immunoreactive trypsinogen, IRT. Cool. We go straight away to the next question. Still, the first three positions remain unchanged for the last three questions, although there is a very close competition for the next between team 4 and team 5. So IMCA, JIPMER and AIMS in 1, 2, 3, Stanley and GMC, Thrissur in 4 and 5, which has been there like for the last three questions now. So coming to the last four questions now. Mepolizumab used in severe uncontrolled asthma is oh, surprised. 12 teams have got it right. I thought it was going to be one of the toughest questions. So the recent GINA guidelines have, advised mepolizumab, which is an anti-interleukin 5 inhibitor of the eosinophilic pathway for uncontrolled asthma in age group more than 12 years. So that is it. So 12 teams have got it right. So there is a slight change in the team order now. Cool. Last three questions. True about pulmonary artery hypertension in children. True. Okay, 7 teams have got it right. So left to right cardiac lesions are always not necessary, which happens only for the high flow lesions. That is the secondary pulmonary artery hypertension. ACE inhibitors are usually not used. This is a calcium channel blocker which is used. Cardiac catheterization is definitely a part and parcel of children in whom it can be done because it gives you very valuable information about the vasomotor reversibility. So if you find that your pulmonary artery hypertension is reversible with inhaled nitric oxide, that means the patient is all the more likely that the patient would respond to a calcium channel blocker. So in all those patients and where facilities exist, cardiac catheterization is an essential investigation to look for the vasomotor reversibility. So 7 teams have got it right. It was one of the so-called tough questions just to. Okay, so it hasn't done much to the team status except that 1 and 2 remains same. And we have a close competition for the 3rd, 4 and 5. Okay, last 2 questions now. Not significant about interstitial lung disease in children. Yeah, I thought that was a very straightforward question. So most of the other investigations are done part and parcel of interstitial lung disease, and ANAS, connective tissue disease workup, spirometry to assess for the restrictive pattern. Hemosiderin-laden macrophages are usually done to see for the diffuse alveolar hemorrhage syndrome. So the alveolar bleeding. So it is considered as a marker of pulmonary hemorrhage. Bronchoprovocation test, as you know, is a test which is usually done for asthma, like the metacolin challenge test and all. So we'll go to so it's very interesting. So JIPMER has actually come to the top, followed by IMCH, and then 3rd position is ICH, and 4th is Stanley, and 5th is GMC Thrissur. So if you see, it's just a matter of hardly 1,000 points separating first 3 teams. So anything can happen in the last question. So all the best. Hope you had a nice time. So this is going to be the last question. Here it comes. Most appropriate diagnosis. Yeah, so almost 75% has got it right. So what you were seeing was a thick-walled cavity with an air fluid level, and the best description which goes with this is the lung abscess. So that concludes our session. And now we come to the podium, and I invite our branch president, IAP Madhyakerala branch president, Dr. Nadir Shah, to do the honors to declare the team 1, 2, and 3.
Hello.
Hello. Yeah, you're audible, sir.
Yeah, audible. Yeah. Yeah, finally, it was a wonderful quiz, Dr. Vipin. I think all the teams have done very well. Maybe
Yeah, it was very close.
Yeah, Rafiq. Can Rafiq take over? Announcing the
I invite our scientific committee chairman, Dr. Rafiq, to announce the prize. IMCH, can I have the names of the doctors team?
Yeah, exactly. If they can identify the team with the team members' name, then it will be useful so that we'll write down.
Good afternoon.
Dr. Labib and Dr. Sudhiraj.
Dr.
Labib and Dr. Sudhiraj.
Okay, Subiraj, right?
Rafiq sir, the stage is yours. Can you just announce the...
Yes.
Chitmar is Agashandran and Sachi. IMCH is Labib and Subiraj.
So congratulations to all participants. It was a wonderful quiz program, and congratulations to the quiz master also, and Dr. Baby. And first prize go to Jipmar.
Team Jipmar. Yeah.
Yes. Dr. Akash. Dr. Sanjeev.
Yeah, Dr. Akash Chandran and Dr. Sanjeev.
Congratulations.
Come in video.
Second prize goes to IMCH. Dr. Lahi and Subhaj. Congratulations. And third prize goes to
Screen sharing stop.
hello.
Yeah.
Third prize goes to Stanley Medical College, Team 1.
Dr. Divya and Dr. Praveen.
Yeah.
Can the
Dr.
team
Divya and
members
Praveen.
please identify and confirm that it is Dr. Divya K and Dr. Praveen S?
Yes, sir.
Can you close the share?
Yeah, sure.
So that we can see the participants. They can come and introduce themselves. I request the first vice president.
Is that Dr. Divya K and Dr. Praveen S?
Yes, sir.
Please introduce yourself.
I think Nimi, it would be a good idea if the first 2-3 team members can come, and is it possible for them to
Let their photos come.
Yeah, exactly.
Yeah, they can just start talking, unmute themselves and start talking so that they'll be on the screen.
Yeah, Akash Chandran and Sanjeev, can you just come online and then tell us how was your experience? Did you enjoy it? And you have some
Yes, sir. Am I audible, sir?
Yes. Yeah, this is Akash and Sanjeev.
Yes, sir.
Congratulations.
Thank you very much, sir.
Thank you, sir.
How do you feel?
Did you enjoy the session or?
Yeah, sir. This was some different experience. First time, like we are using 2 devices for attending a quiz, and it was different experience. And questions were also very good, like mostly like clinical based, rather than we were expecting some history based, some vaccine, which would be some more difficult. But it was more of clinical questions. And it was well organized.
Thank you for the feedback. Team ICH. IMCH, sorry.
Good afternoon, sir. It was a very nice experience and very different experience also using Kahoot. Thank you, sir, for giving such an experience.
Not seen.
They prefer to be behind screen, it seems.
Can you see?
Yeah.
Yes, they can be seen.
So this
Yeah,
is Dr. Sutiraj and
Yeah.
Nimi, what is the second participant's name?
Dr. Labib.
Dr.
Labib.
Labib. Okay. So thank you so much. And
Thank you.
Team Stanley Medical College,
Stanley 1.
Dr. Divya and Dr. Praveenas.
Thank you, sir, for this opportunity. It was a different experience, sir, and we really enjoyed it, sir, and it's a well-organized episode. Thank you, sir.
Thank you, sir.
Okay, thank you very much.
And thank you everybody for all those who have participated. I mean, Ashok Kumar sir, I was telling yesterday, like a PG day, Saturday evening is so precious, and they all found part of their time yesterday for the trial run. And it was actually a great experience. Thank you everybody. It was a close neck-to-neck competition. In the point separating team 3, team 45 is like hardly 1,000 points. I mean, hardly 1 or 2 questions. So it's like nothing like winner or loser. So thank you so much. Over to the organization team for the closing remarks. Thank you.
Okay, thank you, Bipin, for a wonderful experience. And I think it is the first time we are holding something like that. The participants, I assure you that we are going to send you a certificate for all the participants. Now we are coming up the flag end of the program. Now, Chairperson of the Kerala State, Dr. Krishna Mohan, I request for your closing comments.
Thank you, sir. That was an excellent session. I should congratulate Dr. Bipin for that excellent organization. And the teams, I think all the 20 teams, all of them performed really well. But personally, I'm a little bit sad because I am an alumni of IMCH Calicut, not because Jipar has won. But they were so good. I think till the 18th question, they were in the first position. But Jipmar, they were not better. I won't say better. All the 20 teams are equally good. So this is the first time, I think, in a virtual platform we are organizing using this app. And I'm happy that we got one more quiz master. Usually we were doing all our quiz with Dr. Nisha, Dr. Nitya and all. And today we got one more quiz master and who is a pediatric pulmonology critical care specialist also. So thank you so much. And about the conference, I think it was one of the best conferences of respiratory chapter organized. And if you ask me which was the second one, then also I will say the last one organized by Madhyakerala in, I think it was in Alua, so that one was also equally good. I should say, if I have to say one name for this thing, I would say Rafiq Sir's name, because he was the one. No, I don't mean that others are bad, but Rafiq Sir, from the beginning onwards, every day he used to call me at least once on a daily basis for asking something and all. So that was really good, and all the faculties were all of them were good and in their specific topics, and everything was good. Only thing is that what we are lacking is the food. If it was a physical conference, then also we would have enjoyed it. Soon, I think at least next year we will meet. So thank you so much. Thank you once again.
Closing early. Congrats. All the best. Well done.
Yeah, thank you, Krishna Mohan sir, for the kind words. We're coming to the end of the session. I think time is exceeded so much. So thank you everyone for the cooperation, all the speakers, office bearers, especially members of IAP Madhyakerala who made it possible. Thank you everyone.
I don't think I have sat through 6 hours in the recent past. This is the first time I'm sitting continuously from morning. That is because of the quality of the product, quality of the talks, And the climax was unbeatable by Bibin. Kudos to the Madhyakerala team. Fantastic show.
Thank you, sir. Thank you so much.
Fantastic. It was simply unbeatable.
No, sir.
Hungry. Gotta go.
Okay.
Yeah.
Thank you.
No, the person behind that quality is Rafiq sir only. He has decided topics, speakers, everything.
പുള്ളി ഇറങ്ങി തിരിച്ചു കഴിഞ്ഞാൽ അവനെ പിടിച്ചാൽ കിട്ടില്ല ആളാ.
Thank you.
Adrisha, well done. Nimmi, great.
നിമ്മി ഏതായാലും പണി പഠിച്ചു.
പിന്നെ
നിമ്മി പണി പഠിച്ചു.
പോയിരുന്നു. അദൃഷ്ട ഊണ് തുടങ്ങി ഓൾറെഡി. എങ്ങനെ പിടിച്ചു നിൽക്കുമല്ലേ? നമ്മുടെ സ്ഥിരം സമയം ആവണല്ലോ, അതുകൊണ്ട് കുഴപ്പമില്ല.
Okay then. Okay.
Yeah. Okay, sir. Thank you.